Good morning, friends. Though there are very few people in the hall, but a lot of people are connected virtually. So I don't think the speakers should face any problems. We want to be on time, so we'll start with the first session. I would like to invite Dr. Biranchi Narayan Mahapatra, Dr. Ramchandra Shetty, Dr. Tanu Thakur. If they are here, yeah, please come and start the session. We have got three speakers, Dr. Nidhi Kale, Dr. Vanisha Nambiar, and Dr. Rakesh Sahay. Please start the session.
It's on.
It's too early to discuss about snake bite management. And I am Dr. Nidhi, Head of Department of Emergency Medicine, currently shifted from General Medicine from AIMS Rishikesh. I'm here to discuss about snake bite. So a lot of us would be thinking, why are we discussing snake bite today on this forum? The importance of snake bite for me is, I am from Rishikesh and we have lots and lots of rainfall and we have lots and lots of snake bite cases in our department. We get around 200 to 300 cases per year of snake bite envenomission. So for me, it was very important, and trust me, they have all very varied presentations, and we're going to discuss what is a basic management and what is out of the box and what is new in snake bite management. So I want to highlight our experiences, and through our experiences, what we have learned in something new, something novel in snake bite management. So we all know this, that we have venomous snakes and non-venomous snakes. So I'm not discussing in detail about the non-venomous snakes, but the poisonous snakes can be divided as majorly, but we have the other subclasses as well. That is Elapity, Cobra and Crates. They are mainly neurotoxic. Viperidae, that is the vipers we all know. Russell's vipers, saw-scaled vipers, pit vipers, they are hemotoxic snakes. And Hydrophidae, they are sea snakes, they are mainly myotoxic. That is, they are affecting the muscles. So we have three types of presentation mainly. They are neurotoxic, hemotoxic and myotoxic snake bites. Now this is something which was given to us by the forensic team, that how to identify. I'm not going into detail reading this, but we have all done this in our MBBS days, that how do we differentiate between venomous snakes and non-venomous snakes. So on the basis of the scales, on the basis of your third supralabial shield, and on the basis of the vertebral scales, infralabial scales, and the belly scales, we can differentiate between venomous case and non-venomous snakes. But as per the guidelines, it is not important for us to differentiate physically. If the patient, sometimes a lot of times the attendants, they get the snake with them. So we cannot differentiate, and we should not try to attempt to differentiate, identify the venomous versus non-venomous snakes. It is basically the classification, clinical classification of the manifestations that we are worried about, and the management would only depend on the manifestation. The Elapidae snakes, for our information, has fixed front fangs. They're generally venous and distributed throughout the India, and the examples are cobras and kraits. And they are mainly neurotoxic presentation. Viperidae have long, hollow, retractable fangs. They keeled scales, slit-shaped elliptical pupils. They're distributed throughout the India, and they are mainly vipers. Hydrophidae, they're highly venomous, and they're relatively shorter fangs, and they're species of coral snakes and sea snakes. Now, venom, to understand venom and the composition of venom, it is important for us, because there are a lot of things going on. What are the various enzymes and non-enzymatic peptides and polypeptides involved in the snake venom? And what is the underlying pathophysiology of mechanism of action? How does it cause hemotoxicity? How does it cause neurotoxicity? Because we have to know that where it is acting and how can we manage the case further. So just a brief on that the snake venom basically has 90 to 95% proteins, and the non-protein compounds encompasses of 5 to 10%. There are multiple enzymes in snake venom, including phospholipase, collagenase, acetylcholinesterase, endopeptidase, prothrombin activating enzyme, which is basically responsible for your hemotoxic presentation. The non-enzymatic polypeptides are polysynaptic neurotoxins. It can be either presynaptic or postsynaptic, and cardiotoxins. Lot of times we get a patient with unexplained hypotension and there is no overt bleeding. So one is if the patient has some kind of subclinical bleeding and we cannot recognize that bleeding, and the other is the cardiac toxicity. So we have to know that the snake venom can also cause cardiotoxicity. Peptides and pyroglutamyl peptide, phospholipids, histamine, serotonin, and spermin. Now, the toxic effects of snake bite, it can occur both from the proteinaceous and non-proteinaceous compounds. The phospholipase A2 inhibits electron transport of cytochrome C level, rendering the mitochondrial enzymes insoluble. Thus, it damages the RBCs, leukocytes, platelets, skeletal muscle, vascular endothelium, and myoneural junction. Hyaluronidase, it helps in the spread of the venom. The proteolytic enzymes results in local edema and blistering and necrosis. So we get a lot of cases of subcutaneous edema, cellulitis, and progressive swelling post snake bite. That is because of your proteolytic enzymes, which causes blistering. So much so, it is so severe that the patient can require fasciotomy post snake bite. Then you have the alpha neurotoxins and the beta neurotoxins. The alpha neurotoxins, they bind to the acetylcholine receptors at the motor end plate. At the motor end plate, the alpha neurotoxins would bind. The beta neurotoxins initially cause the release of acetylcholine, and they then cause damage of the nerve endings, preventing further release, and it causes paralysis. Polypeptides, being smaller molecules, are rapidly absorbed into systemic circulation, and they lead to systemic toxicity. So as we know, the snake bite, after the snake bite, it can be divided as a dry bite or an overt bite. The overt bite clinical manifestations, the patient can present with neurotoxicity, hemotoxicity, myotoxicity, or painful progressive swelling. Dry bite also, that means the venom has not been injected into the patient. So in that patient can also be symptomatic. The patient can have symptomatic symptoms. Patient can present with severe pain, acute agitation, and the patient can be severely anxious, and it can lead to rise in blood pressure, chest pain. Neurotoxic symptoms are mainly diplopia, dysarthria, dysphagia, and the most important symptom and the first one and last one to go is your ptosis. Ptosis, descending paralysis, diplopia, dysarthria, dysphagia, and the patient can have even altered mental status. Hemotoxicity, the patient can present with bleeding from any site. It can be basically consumption coagulopathy. It is a consumption coagulopathy. The patient can have bleeding from any side. And then you have myotoxicity and painful progressive swelling. Now, mind it, these four are the indications of giving ASV. Why are we discussing these signs and symptoms? Because these four are the indications of giving ASV. So these are all the vasculotoxic, hemotoxic or bleeding signs and symptoms. The patient can have local manifestations. The Russell Viper, the pain is very local manifestations and pain is very severe as compared to the saw-scaled viper, and it is least with pit viper bite. The local manifestations can include the patient can have localized swelling, bleeding, blistering, necrosis, pain at bite site, absence of peripheral pulses and hyperesthesias, and tender enlargement of local draining lymph node. That means the patient can also involve the lymph nodes and the patient can have lymphadenitis. Then there are some systemic symptoms, systemic manifestations as we have discussed. The patient can have bleeding from any side. Bleeding, and the skin in the mucous membrane can also have petechiae, purpura, rashes. There will be swelling, localized pain. Acute abdominal tenderness. Acute abdominal tenderness is a catastrophic sign and actually can tell you about the severe gastrointestinal or retroperitoneal bleeding. Then there can be lateralizing neurological signs. So most important neurological manifestation is ptosis. Patient can also have asymmetrical pupils. Then the other are the hematological manifestations. About 20-minute WBCT we'll be discussing soon. So these are all the signs and symptoms. So bilateral conjunctival edema, and the other is a painful progressive swelling, and the third is gum bleeding with viper bite. Now, what are the life-threatening complications due to renal involvement? The patient can have hematuria, hemoglobinuria, followed by oliguria and acute kidney injury. So this can be because of thrombotic microangiopathy, or patient can have rhabdomyolysis, which can lead to acute kidney injury. Bilateral renal angle tenderness, passage of discolored dark urine, dark brown urine. That can actually give you a clue of about rhabdomyolysis. Acute kidney injury is very commonly associated with Russell viper or saw-scale vipers, basically because of rhabdomyolysis. Hypotension because of hypovolemia can be due to direct vasodilation or because of direct cardiac toxicity, myocarditis. Patient can also develop parotid swelling, conjunctival edema, subconjunctival hemorrhage, renal failure, and there are certain long-term sequelae reported in various case reports. It is pituitary insufficiency caused by Russell vipers and Sheehan syndrome and amenorrhea in females. Now, as per WHO, there are certain early clues that the patient has a severe inflammation. These are snake bite identified as a very dangerous bite. So you can identify the snake, which is very difficult. Rapid extension of the local swelling from the site of a bug. Basically painful progressive swelling, what they are talking about. Early tender enlargement of the local lymph node. That is basically the venom has spread to the lymphatics. Early systemic manifestation, patient can develop hemotoxicity or patient has developed neurotoxicity and unexplained hypotension. So what first aid you can give to the patient? So we are doing training of the medical officers in our area. So teaching them, it is very important. In even the general public, teaching them is important. So first thing you have to do for these patients is reassurance. Reassurance is first thing you will do, and then you can immobilize the person. You can immobilize the affected limb, remove the rings and other tight objects. Tourniquets can cause severe local damage and gangrene. And then if the venom has gone into the eyes, one needs to irrigate the eyes. So examination is, one can look for fang marks. However, fang marks are not absolute for snake bite. One may or may not get fang marks in a case of snake bite. Other systemic examination we have already covered, that is signs of coagulopathy, any active bleeding, ecchymosis, the pericardial or pleural effusion is there, unexplained, or hemorrhage is there. These are the systemic examination findings. Assess the extraocular movements, bulbar function and muscle power. Look for ptosis, muscle tenderness and jaw stiffness. Jaw stiffness is a prominent but overlooked feature in sea snake invermation, and it can be reduced by sustained pressure on the lower jaw. Now a word about neurotoxins. You have two types of, basically the major ones are two types of neurotoxins, otherwise the reported ones are four types: beta bengaro-neurotoxin, alpha toxins, kappa toxins and dendrotoxins. So common kraits have all the neurotoxins. Indian cobra has alpha cobra toxin, Russell vipers has rust toxin. The cobra krait, the toxin can act, the site of action is presynaptic, postsynaptic, and it can also enhance the acetylcholine release. So what is the action of neurotoxins? The neurotoxins, they lead to depletion of the presynaptic neurotransmitter vesicles, inactivation of the nicotinic acetylcholine receptors, and eventual physical degeneration of the neuromuscular end plate. So this is the diagrammatic representation of the action of neurotoxins. Now, why do we want to know about the action of a neurotoxin? Whether it is alpha, beta, how does it matter? Whether it is acting on the presynaptic junction or postsynaptic junction, what is the mechanism? Because in emergency or in an acute care critical setting, we need to give these patients atropine neostigmine, and what is the role of calcium gluconate in these patients is important. So we can't keep giving the patients atropine neostigmine if it is a postsynaptic bite. Okay, so presynaptic was only which basically the patient, the neostigmine atropine would be effective. So to know the underlying mechanism of neurotoxin is important because it will improve the management of the patient also. So as we've already discussed, a patient with neurotoxic snake bite will present with ptosis, paralysis, diplopia, dysarthria, dysphagia. Now, a lot of times the patient does not know, for the PGs there, a lot of times the patient does not know that there is underlying snake bite. They have not seen the snake, and the patient has come with diplopia, dysarthria, dysphagia. So there are multiple differential diagnoses. Patient may or may not have had snake bite, but there are multiple differential diagnoses. So can we have some differential diagnosis from the PGs? I guess you're postgraduates, right? So can we have some differential diagnosis of snake bite from you? Diplopia, dysarthria, dysphagia, paralysis, descending myasthenia gravis, and what else? Very good. Botulism is important. Others? Lambert-Eaton syndrome.
Bulbar GPS.
Yes, very good. Bulbar GPS. Anything else? So any disease which is acting on the, which is affecting the NM junction, neuromuscular junction related disease. So it can be myasthenia gravis, Lambert-Eaton syndrome, or it can be botulism, or it can be GPS. The patient has presented with descending paralysis here, descending paralysis. But then there can be the different variants of GPS the patient can present with. So this is an important differential diagnosis. Snake bite, however, is missed as an important differential diagnosis in this kind of presentation. So one needs to keep this diagnosis as one of the important, and these patients can be improved with by giving ASV. Now, how do we identify impending respiratory failure? So what we are looking in a patient with neurotoxic snake bite is involvement of the respiratory muscles. So impending respiratory failure can be identified. Now these are we've all done at the bedside in case of critical care in ICU setup or in emergency setup. So we can identify by single breath count, breath holding time, ability to complete a sentence, husky cry in children, and absence or diminished tendon reflexes. So this is how we can identify the patient having impending respiratory failure. Now, before we discuss the management, now we all know what are the indications of giving ASV in a patient of snake bite. So the patient can have hemotoxicity, neurotoxicity, myotoxicity, or painful progressive swelling. That is called as PPS. Now to discuss that, something we have all discussed about the neurotoxicity. What are the differential diagnoses of neurotoxic snake bite? The important one more thing I want to discuss about hemotoxicity is underlying mechanism of hemotoxicity. It is something similar to DIC. Yesterday we learned about DIC. Now DIC versus VICC. Another important term is venom-induced coagulation, consumptive coagulopathy. Venom-induced consumptive coagulopathy. VICC is nothing but snake bite-induced DIC. Okay, so the patient will present with bleeding, overt bleeding, bleeding from every side. The patient will have petechiae purpurae rashes. Okay, now if the patient is having VICC, that is a kind of consumptive coagulopathy, so all the patient will have all the coagulation factors would be deranged and the factor levels would be reduced. You know, mainly factor 5, factor 8 and fibrinogen levels would be decreased in this patient. Okay, VICC will be consumptive coagulopathy. It is nothing but a venom-induced DIC. Okay, this is one manifestation. Now, sometimes your coagulation studies are normal. Okay, and the patient has thrombocytopenia, unexplained thrombocytopenia. Okay, the patient has unexplained thrombocytopenia and microangiopathic hemolytic anemia. So thrombotic microangiopathic hemolytic anemia is another presentation has been found to be associated with snake bite, and we had present patients with thrombotic microangiopathic hemolytic anemia associated with snake bite. Now these patients presented with anemia, thrombocytopenia and peripheral smear, you can see schistocytes. So if you have schistocytes on your peripheral smear, then probably you're dealing with snake bite induced TMA. And the management of this TMA associated snake bite is not a regular dialysis. You will give first dialysis to the patient, hemodialysis, but these patients might not respond to your regular hemodialysis, and then you will have to give plasma exchange therapy in these patients. So this is something new in recent years that has been come. Less than 10% cases of snake bite is associated with thrombotic microangiopathic hemolytic anemia. So these patients will have unexplained thrombocytopenia, unexplained anemia, and on peripheral smear, you can get to see thrombocytes. So minimum two schistocytes per high power field, or 1% is what is documented to be significant level of schistocytes on peripheral smear. So this is something new about role of plasma exchange therapy in patients with hemotoxic induced snake bite. Now how are we managing these cases? So we are doing 20-minute WBCT count. Now 20-minute WBCT everyone has done. What is a significant level, what is not. But important aspect of 20-minute WBCT is it is only able to detect patients with moderate to severe hemotoxicity. That means if the patient is having mild hemotoxicity, then there are chances of missing on your hemotoxicity by just doing a 20-minute WBCT. Okay, this is something which has recently come in the meta-analysis and systemic review. Okay, so we have discussed what is VICC, we have discussed TMA associated, what is the relevance of 20-minute WBCT. So after your 20-minute WBCT is positive, you will give 10 vials of ASV. Okay, in case of hemotoxic snake bite, you will repeat your 20-minute WBCT 6th hourly till it is normalized. Maximum vials in hemotoxic snake bite is 30 vials what you will give. In case of neurotoxic, so a lot of times, you know, we get this question, Doctor, INR is still deranged. Should we keep giving ASV? No. INR can remain deranged as in case of DIC, but you will not give more than 30 vials of ASV in hemotoxic snake bite. Okay? The other, yes.
Madam, please, it's running out.
In neurotoxic snake bite, you will give only 20 vials of ASV. And we have discussed what is the role of neostigmine atropine. You will give neostigmine atropine, and calcium gluconate is also given in case of neurotoxic snake bite. Okay. Thank you so much for giving me this opportunity to present snake bite. Thank you. And locked in syndrome, also a lot of presentation.
Thank you, madam, for this kind and very comprehensive deliberations.
Thank you,
and
so much.
covering all aspects of the snake bites. Thank you very much.
Thank you.
So the next speaker we have Dr. Vinisa Nambiar, and she will be talking on global accelerated actions for the health and nutrition for adolescents. Madam, please.
Thank you so much, respected chairpersons, for inviting me here on the dais. My greetings to the entire team of ACP India for having me here. Can you please come up and help me out? Need to stop this presentation. बंद करना है नहीं ये लैपटॉप इनेबल करिए So very good morning to all present here. Today, I have a disclaimer. In this American College of Physician conference, I am not a physician and yet standing tall amidst you. So, and I'll be talking on the topic, global accelerated action for improving the health and nutrition of adolescents. And this presentation is mainly in line with the work that I'm doing with the World Health Organization. And in order to respond to global epidemiology and to complement the existing prevention-focused guidelines, the World Health Organization is currently developing a science-informed, people-centric guideline on the integrated management of infants and children at high risk, that is excessive adiposity, and also adolescents using a primary healthcare approach. And as mentioned earlier, I'm not a physician. I am a professor of nutrition and from the Maharaja Sayajirao University of Baroda. And I work with 2 committees in the World Health Organization. And so when the spirit of people is strong, focused and vibrant, along with that strong spirit, wonderful things happen. And this is one such feast of wonderful things that are happening. And thanks to Dr. Anuj Maheshwari sir, the very vibrant governor of ACP India, the scientific committee, intellectual mind, Dr. Veermani sir, and the ever enthusiastic Panda sahib. Why are we talking about adolescents in this conference? This is the picture which I shot yesterday while I was going around Orissa, the beautiful Orissa. And the school had just got over, and all the adolescents were heading towards this place, which is the Pani Puri stall. And when we look at the global data, we look at the data from Bangladesh. I picked up Bangladesh because we do have representation of Bangladesh here. And then we have UK news. We have the Indian news about adolescents born with heart defects and what's happening with the heavy bag loads. And then we have the same concerns in the United States. And then post-COVID, we all are looking at this short-tempered adolescents all over the world. And then there is a huge problem of sleep in the adolescents. So why? What is adolescence? It is a phase of life between childhood and adulthood, ages 10 to 19. It's a unique stage of human development and an important time for laying the foundations of good health. And for years, the unique health issues associated with adolescence have been little understood or in some cases ignored. Some adolescents don't even reach the primary health centers, though they are facing anxiety, stress, conflict, depression, and delusions. So let's look at what exactly happens in adolescent stage. So there's rapid physical, cognitive, sexual, emotional development along with the social negligence or maybe introvert behavior that's happening as a child enters the adolescent stage. There is widening gap between biological maturity and the social transition to adulthood. They are not children, they're not treated as adult, and they're not even treated as children. And there has to be a balance between protection and autonomy. And there is an increased vulnerability to some aspects of globalization, example, pornography, gaming, online bullying, and which is very, very much, it needs to be looked into. Now, the new Lancet series on adolescent nutrition sets out challenges and opportunities for addressing healthy adolescent nutrition and development. And therefore, adolescent is a time. So there is a period of rapid growth during the adolescent period. So if you're missed during the first 1,000 days of life, if you're missed during school age and early childhood, this is another period where you can catch up and improve the health and nutrition of the adolescents. And this is also a time for extreme plasticity of the body and of changing lifestyles and norms when unhealthy behaviors can be adopted and they live lifelong with the adult. So when we look at the statistics, over 1.5 million adolescents and young adults aged 10 and young adults of 24 died in 2021. And the maximum death was road traffic injuries and drowning, along with interpersonal violence, self-harm. The next very important cause was maternal conditions, which were leading to death among adolescents and young adults. Now, all of you must have seen this, and this is one of the growing issues of adolescent health in our country, India. It was a global pandemic, but now this has become a menace in India too. So globally, half of all the mental disorders in adulthood start by the age of 14, and the early onset of substance abuse is also associated with high risk. And globally, there were 42 births per 1,000 to girls aged 15 to 19 years in 2021. Early pregnancy and childbirth is seen even today in this country. When you travel the tribals, you see a 14-year-old, 11-year-old giving birth to 1.5 kg babies. So along with this comes the complications and low birth weight babies, which we are all talking about. So let's look at some more statistics. Among the females, maternal conditions and self-harm were the maximum causes of death rates in adolescents. And when we look at the males, it is road injury and interpersonal violence along with self-harm and drowning. When we look at the DALYs, that is disease-affected life years, we look at the, in females, it is iron deficiency anemia, lower respiratory tract infections, and even in the older adolescents, that is 15 to 19, it is iron deficiency anemia along with depression. And most of the cases of depressions are not detected, okay? And the scenario changes when we look at the data of the males. it is IDA in the younger adolescents, but in the older adolescents, it is road injury and interpersonal violence. And this interpersonal violence has increased during COVID, when there's online education, when children do not have their they cannot vent out their emotions. There's practically no play. And there is a very beautiful study where we have data from Finland, and the adolescents' happiness index have decreased. So it is an ignored group. And the Global Accelerated Actions for the Health of Adolescents, the AHA report, which has just come out, talks so much about guidance and support and country implementation. So I would like to quote this poem by William Henry Davis, which says that, where is the time to stand and stare? And what is this life full of care if we do not have time to stand and share? We do not actually give some time for the adolescents. They are running from pillar to post. They are loaded with their textbooks and tuition classes, and one class to another class. And this is the major challenge in this adolescence, where they are having issues and concerns related not only to their physical and psychological growth, but also sexual maturity, emotional, economic, and social independence. The family time with the adolescents is practically negligible. Either the mother's available or the father's available. And as I spoke earlier, adolescent pregnancies is another huge issue in this age, and that leads to higher risk of eclampsia or infections, or babies with low birth weight, preterm weight, and severe neonatal conditions. And therefore, preventing adolescent pregnancies is another huge task. So it is not the other problems. The major problem is also nutrition. And adolescents face the forms of malnutrition on both the ends of the spectrum. That means there's a double burden of malnutrition, and I would say triple burden of malnutrition, because they also face micronutrient malnutrition, along with wasting, stunting, lack of vitamins and minerals. And on the other end, it is obesity, overweight, and onset of diabetes, and even heart diseases seen among children. So you need to have a life cycle approach as a physician. And if you have missed out in the infancy or school children, this is the age where you can catch up both behavioral patterns or social or biological or environmental. So the ecosystem can be improved, and if you work on this age group. Now, when we look at UNICEF, UNICEF has tied up with our own Indian government's Ministry of HRD, and it is including in the school curriculum a lot of teaching materials and modules for the benefit of the health and nutrition of the adolescents. And it is also engaging and empowering them by doing many efforts. So what are the global accelerated efforts, and what actions needs to be done? So there's a need to address adolescents not only through conventional public health lens of risk and protective factors, but also consider adolescents as a powerful societal assets whose contribution can be nurtured and augmented through meaningful and engaging participation. The guidance, it takes a radically different approach to the traditional health programming. And there is a need not only for just medical aid, but a social behavior change communication, a participatory approach, understanding from their perspective is also needed in order to do urban planning and criminal justice system, wherein juvenile homes are full of adolescent crimes. That needs to be considered. So you know that body shaming is a biggest problem during adolescence. They're not performing well in school, and that leads to eating disorders, anorexia, bulimia. Suddenly you see this weight gain or weight loss as the child enters the adolescence. And therefore, I'm very happy that I'm here on the platform, which is as the one of the objectives of ACP, which talks about diversity, it talks about equity, and it talks about inclusion. And ACP is dedicated to racial disparities, or elimination of discriminations and inequities in health and healthcare. So it's just not just the adults, but because there's growing realization that they have poor physical and mental health, harassment, rape, assault, this adolescent-specific consideration for programming in humanitarian and fragile settings needs to be considered. So priority setting has to be done, and India is looking so much in this concern, in this area, and physicians not out of the clinic, working with the community setup in the especially rural and tribal areas has to be done. There has to be strong leadership, and Indian government is doing so much under the nutrition, the NHM, National Health Program, both in urban and rural setup, and I'll be talking about that in a while. And the recent report on women's, children's, and adolescent health also has so many clearly defined targets for the adolescents. Now, as far as leadership is concerned, I'm happy that Dr. Anuj Maheshwari sir has been putting up this topic of adolescent health in all the symposium, and I've been a part of it. The first one was the World Congress of Medical Food and Nutrition in Udaipur, where we had the entire panel discussion on adolescent. And the second one was in Vizag in ACP India 2022, where we had this adolescent nutrition symposium. And this is a third one where we're talking about adolescent action, accelerated action plan. And there will be a document out of this very soon on your tables. So we have to focus on adolescents because there's yield. We are talking about finance. We all talk about business and what is the profit in adolescent health investment, because it is a good investment for the nation, for the youth. And this is the report on by the WHO, and it talks about global strategy for women, children, and adolescent health. And it gives you so much of guidance about not only individual level, but community as well as country level tasks that needs to be done. So it's time to act now. And as explained earlier, behavior change, communication, nutrition, health, education, and promotion is the need of the hour. So as the theme of the conference is art and science of medicine, how do you handle adolescent? Is it art or is it science? So here I would say that when Dr. Maheshwari, aap sun rahe ho, Anuj sir, so Marma sir and Anuj sir are busy talking. So what is adolescent health? Is it the art or is it the science? The science or the physicians, they'll provide prescriptions and do some talk therapy. And they have degrees in medicine. And they treat conditions when the adolescent comes to your office using their knowledge of biology or maybe neurochemistry. But the psychologist or the people who are actually treating adolescents also need to have not just one, but the talk therapy using social behavior change communication theories. They need to have a lot of training in psychology, and they treat the conditions based on their behavior, because most of the problems of adolescents are due to the problems of the mind. Okay, so it is not an art, it is not the science, it is the combination of art and science which is needed for the management of all the issues and concerns of the adolescents. Then there is empathy and treatment which is needed, particularly in the vulnerable adolescents who are living with disabilities. Sickle cell anemia in the tribal belts of India is a big problem, along with HIV. And then there is conflicts, disasters. There are marginalized segments because of sexual orientation, gender identity, ethnicity, and then there is domestic violence and substance abuse. In the metros itself, forget about the rural or the tribal areas. In the metros itself, there is child labor. There is so much of harassment in domestic violence by the so-called rich societies to the poor maids who are hired. And there is early marriages, there's migration, and therefore they do not have access to good health services or social protection. So adolescent health is a good time for investment for the prevention of NCD and metabolic syndrome, and mental health is one more issue which needs to be taken care of. So the meaningful involvement of young people will benefit not only the society but the entire country. And from the development perspective also, it is very important to take care of this age group, and communication in ways tailored to an adolescent health is important. So there are 3 domains of handling adolescents. First one, basic concepts in adolescent health and development and effective communication. The second one is laws and policies and quality standards. And the third one is the time when they reach you, the tertiary care, where clinical care for specific conditions needs to be done. But much before that comes the primordial and the primary care. So these are the various schemes by our own Indian government which are related to adolescents, related to livelihood and health and leadership. And I think all of you should be aware of these schemes. We have the entire portal, and anemia, as I said, is one of the largest problem in both adolescent boys and girls, which needs to be taken care of. We have the NEP program, intensified INEP program by the government of India, how where free treatment is done. But the evaluation part is a huge problem. There's so many interventions available. One more minute, please. And by the government of India, there's so much of IEC material, but where is the use at the tertiary care is my question. So adolescents can do wonders for nation building, for community building, and you need to have empathy and a different approach. It is not a regular patient training which is going to help you in treatment of adolescents. You need to listen to them and then treat them. And I thank you all for your patient hearing, and thanks once again to the entire team of ACP for having me here. Thank you so much.
Thank you very much, ma'am, for this nice deliberation on this very interesting topic. And it is very interesting to see a male adolescent child with the highest number of iron deficiency anemia. That is very peculiar, actually, in contrast to the female. So if you have one question you can take, or we can next shift to the next. Thank you very much, ma'am.
Thank you so much, sir.
So good morning to all of you. Thank you to Professor Anuj Maheshwari and the entire team of Dr. Anil Virmani and the entire team of ACP India for inviting me to be here. Today I'll be speaking on subclinical hypothyroidism, when to treat and what to do if you're not treating it. So basically, if you look at the thyroid function test, if you're looking at interpreting the thyroid function test, what we are speaking of is looking at the higher TSH values. The TSH values which are high with normal T3 and T4 levels are typically defined as subclinical hypothyroidism. When the T3, T4 levels also start going down, then you have a overt hypothyroidism. But when with normal T3 and T4 levels with elevated TSH is what is subclinical hypothyroidism. while the slide also speaks about the entire spectrum of thyroid abnormalities, how to interpret the thyroid function tests. I'll not be going into details of that, but what I would like to highlight here is that the TSH level, which is the commonest or the first test that needs to be done, helps in telling us when it's in the very high range, that is what is overt hypothyroidism. When it is in the range of mildly elevated range, where the normal range is between 0.5 to 5 or 0.5 to 4.5, anything above that and to up to about 20 is what is subclinical hypothyroidism. And then you have, when it is going down further, then you have got subclinical hyperthyroidism, and then you have got overt hyperthyroidism. So again, overt subclinical hyperthyroidism is a scenario where there is a decline in the low TSH values without much of elevation of the T3 and T4 levels. So this is how the spectrum of thyroid diseases are, and today I'm going to speak about this category of problem where you have a subclinical hypothyroidism. So subclinical hypothyroidism, as I mentioned just now, is a state where there is increased TSH levels with normal T3 and T4 levels. There are two categories. You could say that those which are in the range of mildly elevated range of 4 to 10 which constitute about 90% of the cases of subclinical hypothyroidism, are the ones which are having mild subclinical hypothyroidism, and the more severe ones are those in the range of those above 10. So often there is no confusion between treating, whether to treat or not to treat the more severe values, but the mildly increased ones are the ones which are the most confusing ones, and they constitute about 90% of the cases of subclinical hypothyroidism. So what causes subclinical hypothyroidism? It is most common persistent cause of subclinical hypothyroidism is autoimmune thyroiditis, whereas there could be other causes like just with increasing age there is a gradual increase in TSH levels. Irregular sleep pattern can cause this, mood disturbances, depression can cause a transient increase in TSH levels, and similarly obesity is also a factor which can contribute to an increase in TSH levels. So these are all conditions which are transient, which can cause transient elevations in TSH levels. Therefore, when you do a test at a particular point of time, you will find that the TSH level is mildly elevated with the T3 and T4 normal. Patient has no clinical symptoms of hypothyroidism. So that could be any of these scenario also. So therefore, what we like to do is we like to repeat it at least once again. After a few days or after a few weeks, you repeat it, and if it is persistently high, then it is likely to be, then you need to look at other factors to decide whether you need to treat it or not to treat, depending on the presentation of the individual and the other accompanying factors. So I'll take you through 2 or 3 cases, and then we'll discuss about subclinical hypothyroidism. So look at this 70-year-old lady who is referred for possible hypothyroidism after a GP ordered for a TSH screening, and she feels well. She has no medical problems, no major medical problems. She has not been taking any medications. Her BP is 140/70, thyroid is normal on palpation, and her reflexes are normal. Her TSH done twice showed 5.5 on one occasion, 6.1 on another occasion. The T4 values are normal, anti-TPO antibodies are negative. What should we do? Should we treat her with thyroxine or not? So this is a scenario that we will discuss, and we'll come back to this. There's another lady who is a 28-year-old lady who is a primary gravida, 10 weeks pregnancy. She is detected to have a TSH of 9.4. She has no past history of thyroid dysfunction. Her mother is hypothyroid, however, and when you examine her, she has no symptoms of hypothyroidism. There's no goiter. What is to be done in this scenario? Do you treat her or not treat? Then you have another scenario. Look at this 45-year-old lady who's been diabetic for 5 years, presented with features of weight gain of 5 kg in the previous year. She's been lethargic, complaining of puffiness of face, and she's also hypertensive. Her LDL cholesterol is 140 and her HDL is 38. Her TSH is 8.8 and T4 is normal. Anti-TPO antibodies, however, are 560 international units per ml. She is on OADs and antihypertensives. Do you treat her? So this is another scenario. Let us come back to them later towards the end of my presentation. So the definition I've already discussed about what is subclinical hypothyroidism. I said that it's a state of mild hypothyroidism, and most of them may have antibody positivity. And if you look at the burden of subclinical hypothyroidism, the global prevalence is estimated to be about 5 to 10%. It's more common in females, increases with age. Indian prevalence is about 9 to 26%. So we have a higher prevalence of subclinical hypothyroidism in our part of the world. And so who is at risk? So women who are at an older age are at risk of subclinical hypothyroidism. Patients with autoimmune diseases, type 1 diabetics, we treat our patients with type 1 diabetes, we should be screening them for hypothyroidism. Then those with rheumatoid arthritis and other autoimmune disorders. Then patients with previous history of hyperthyroidism who have been treated for hyperthyroidism can go on to develop hypothyroidism, and they can have subclinical hypothyroidism. Those with a history of prior head and neck radiotherapy and those who are using drugs like lithium, amiodarone, they can also have subclinical hypothyroidism. So these are the risk factors for subclinical hypothyroidism. Why do we need to bother about subclinical hypothyroidism? I could say that there are 3 reasons why we should be worried about that, because it could affect the cardiac function, lipid status, and possibly the cardiovascular outcomes. It could have and it could lead to symptoms which could have effect on mood, cognitive function, etc. And then we have the risk of progression to overt hypothyroidism. So these are the 3 concerns that we have when you have individual with subclinical hypothyroidism. These are the 3 areas that we are looking at. So let's discuss the effect of hypothyroidism on cardiac function and the lipid status. So hypothyroidism, overt hypothyroidism, has a effect on the lipid profile, causing atherogenic atherogenic dyslipidemia. It can lead to a hypercoagulable state because of the effect on the von Willebrand factor. It can lead to abnormalities in the hemodynamics, and it can also impair the endothelial function, and it can have effect on non-traditional risk factors like LPA, homocysteine, the LDL size, the remnant particle number. All these can be influenced by hypothyroidism. But what about subclinical hypothyroidism? Does it cause all these things? So this is a little bit of a doubt. We don't have very clear evidence to say that subclinical hypothyroidism also causes all these problems, but there is emerging data that it may have. There's a, we could say, we don't have unequivocal data on that. We have data which some studies which have shown that yes, it does have an effect on these parameters, some data that shows that it doesn't have any effect. So that's the reason why we are looking at whether we need to treat this or not. So if you look at the risk of heart failure events, as you see, look at the TSH level, the rising TSH levels, you can see that there is an increase in the prevalence of heart failure. As you can see, the hazards ratio for heart failure is increased 7.7 to 9.9. It is not clearly on the right of the normal. It is crossing the midline. So it is not very definitely causing that. But as it goes above 10, you can see that there is a clear risk of increase in the risk of heart failures. And then what about cardiovascular risk? So you look at the hazards ratio for cardiovascular events. As you see, as the TSH rises above 10, you clearly see that the hazard ratio becomes significant. So that's the reason why we would say that those who have a TSH value more than 10, we don't have too much of concern about that. We don't have too much of debate about it. And most people would suggest that we need to treat those who have a TSH value more than 10 should be treated, whereas in the range of 4 to 10 is the range where we are looking at all the other parameters. So more than 10 is a definite risk factor for CVD, and all such cases should be considered as high risk. So this is what the ATA guideline also of 2012 said, that this should be about 10 should be considered as a risk factor for cardiovascular events, and we should be treating such. Now, if you look back at epidemiological data of Wickham survey and other data, they all show that as the age advances, the subclinical hypothyroidism increases, the TSH level keeps growing up gradually, and there was a paper which showed that with increasing age, and if you're treating them, if there's an increased risk of problems like atrial fibrillation, increased risk of problem of osteoporosis being aggravated in older individuals, and therefore we are not very much in favor of treating them. So this is also another data which very clearly shows that there's a divergence in the effects of subclinical hypothyroidism. Below the age of 65, there's a clear-cut increase in the risk for cardiovascular events. Above the age of 65, this risk does not is not as evident. So therefore, with older age, probably there is no benefit of treating subclinical hypothyroidism. Now, this is a very recent meta-analysis of 7 studies involving about 1132 patients with subclinical hypothyroidism compared to 11,000 patients without subclinical hypothyroidism with normal thyroid function, and they looked at that and they found these were patients who were going for a percutaneous coronary intervention, a PTCA, and they found that those with subclinical hypothyroidism as compared to the euthyroid individuals had higher risk of cardiovascular mortality, 2.16, doubling of the cardiovascular mortality. All cause mortality was 68% higher, and need for repeat revascularization is also higher in those with subclinical hypothyroidism. Again, this is something which is a recent data which is showing that there is probably an effect of a need for increase in the cardiovascular revascularization, cardiovascular risk amongst patients with subclinical hypothyroidism. The lipid effects, I spoke about the atherogenic dyslipidemia that is aggravated by subclinical hypothyroidism, and there is this data from Taiwan also. This is a more older data, 10-year-old data, which is again showing that there is associated with increased risk for all cause and cardiovascular mortality in adults. And when you come to subclinical hypothyroidism, diabetes, in diabetics have a higher prevalence, maybe prevalence which is not very significantly high, but there is a risk of cardiovascular events which was significantly increased in people with diabetes who had subclinical hypothyroidism. So that is something which we need to keep in mind. And the other issue that has been studied is that there is an increased risk of nephropathy in type 2 diabetes, those who have subclinical hypothyroidism, and this could be explained by decrease in the cardiac output and increase in peripheral vascular resistance in hypothyroidism, and the resultant decrease in renal blood flow and GFR. So what we say is that having looked at that, let us look at the effect on all cognition and mood and all this. So there are subtle decreases in the subsets of memory function or cognitive function in people who have subclinical hypothyroidism. When you do neuroimaging, you find these changes, but however, clear-cut evidence of improvement has not been seen with treatment with thyroxine. I'll just show you one recent review also, recent meta-analysis also. So these symptoms have been shown to be there at younger ages, maybe at older ages again, where it is more of a physiological increase in TSH value that is seen. You probably don't see that much of a change in the effect on the mood, as you can see in this data from Root et al. There was a paper from Bombay where Dr. Prema Vartakavi and her group, they've also looked at the prevalence of clinical biochemical profile of subclinical hypothyroidism, and they found that subclinical hypothyroidism does have a effect by causing sort of mood disturbances and physical symptoms. So let us look at the progression towards towards overt hypothyroidism. The third aspect that we're looking at is progression towards overt hypothyroidism. Over the years, what happens? About 5% per year progress towards developing overt hypothyroidism, and that is also again something which we need to look at. We need to see how many of them actually revert back. Maybe about 50% of them revert back every year, 5% of them progress towards developing overt hypothyroidism. And spontaneous normalization also has been seen in many studies, and that's the reason why we do not want to treat every individual who has got an increase in TSH level, because there could be this spontaneous normalization of many of them. Now, looking at the effect of subclinical hypothyroidism during pregnancy, there have been studies which have looked at women who had higher TSH levels, IQ scores of the neonates born to them or the children born to them. Subsequently, they followed up. They had small effect on the IQ points, and after 11 years, 64% of the untreated women and 4% of the control women had confirmed hypothyroidism. That is the progression of the woman itself towards hypothyroidism versus the effect on the neonatal, on the offspring's mental scoring, and we find that there is some effect on the neuropsychological development. So the question that remains is whether we should treat or not treat. So if we are going to treat, how are we going to treat? If we don't treat, what are we going to do? So quickly in the next 4 minutes, I'll cover that. So if you look at the treatment of subclinical hypothyroidism, what has been seen is that there is a improvement in, as you can see, in younger individuals there is improvement, in older individuals there is an increase in the cardiovascular events. And treatment arguments in favor of treatment are that potential impact on morbidity and mortality, especially with TSH more than 10, possible relationship to dyslipidemia and atherosclerosis, and effects on symptoms, mood, and memory. So these are the arguments in favor, and and also prevention of overt hypothyroidism. So these are the arguments that suggest that we should treat. Arguments against treatment are that it does not have any significant impact, particularly in the elderly, on CVD mortality and morbidity. Data on improvement in the quality of life symptoms and is mostly negative. TSH may normalize, especially spontaneously normalize also if the antibodies are negative. So all these indications, reasons are the reasons to say that we don't need to treat everybody, and cost and danger of over treatment. So if you look at what different organizations are saying, that we may consider treatment in patients who have got a TSH of more than 10, but in TSH less than 10, when do we consider treatment? Those who have got a goiter, those who have got dyslipidemia, those who have got diabetes, those who are during pregnancy or planning for pregnancy also, or those who are being treated for infertility, women who are being treated for infertility. So in all these scenarios, we need to treat subclinical hypothyroidism. And in children, TSH values may, rise in TSH may be a self-limiting condition with a lower rate of progression toward hypothyroidism. So not every child will require treatment. Treatment is required if the TSH values are more than 10, and when there are clinical signs and symptoms of impaired thyroid function or goiter, and particularly when they are found to have short stature or delayed puberty. These are typically the symptoms that we should keep a watch on, and we should treat them if they have any of these two problems. In pregnancy, as we said, that there are significant changes in thyroid physiology. There is increase in requirement of thyroxine for many reasons, which I'll not go into details today. But I'll say that the prevalence is found to be higher. We did a study across 11 cities, and we found that the prevalence was about 13% of subclinical hypothyroidism during pregnancy, and we need to treat them. The pregnancy specific ranges are different, and we need to start treating women during pregnancy. And so the consensus is that those who have got a value of more than 10 definitely need treatment. Those in the range of 4 to 10 need to be treated, may be considered for treatment. Those between 2.5 to 4 also, if they are having antibody positivity, they may be considered for treatment. So these are the concerns during pregnancies. As I can say, the ATA guideline on thyroid disorders in pregnancy in 2017 said these things, that above 10 you treat, between 4 to 10 with TPO antibody positivity, between 4 to 10 TPO antibody negative also you may treat. Those, however, you may avoid if they are less than 2.5 and not having antibodies. Now, one interesting study which looked at a meta-analysis of several studies, and they looked at treatment of subclinical hypothyroidism. They found that there was improvement in there was a reduction in the TSH level, but no improvement in the quality of life. So therefore, doesn't say that, it says that not everybody requires treatment. Okay, then I would like to just say that the dose which is to be used and follow-up of untreated patients. So treatment, those who are not treated can, because there is a risk of progression, they should be checked every 6 monthly. They should have their TSH done initially in the first year. Maybe after that, every 2 years, they can have a TSH done to see whether they are progressing to overt hypothyroidism. These are individuals who are not treated. And if you're treating, the dose of thyroxine that you need to use for treating subclinical hypothyroidism is not the typical dose that you use in overt hypothyroidism. In overt hypothyroidism, we use a dose of about 1.6 microgram per kg per day. But here you use smaller doses, maybe about 25 to 75 micrograms, may be good enough to treat subclinical hypothyroidism, and you need to look at the TSH values to decide about the dose of treatment. And follow-up should be done about 3 months after starting treatment, and maybe then at least annually you need to follow them up. So this is the follow-up of treated individuals. Those who are older people who are treated should be followed up more carefully. Now, just quickly coming back to the 3 cases, the 70-year-old woman without any symptoms who had a mild elevation of TSH, had no antibody positivity, does not require thyroxine, as I'm sure all of you would agree with that after the discussion that we had. The lady with who is pregnant certainly needs thyroxine, because we have seen that mild elevations in TSH happen during pregnancy because of various factors, and even though this is going to get back to normal after delivery, but she needs to be treated during pregnancy because it has an effect on the outcomes of pregnancy for the maternal and the fetal outcomes. And finally, this is the last case which we said, the 45-year-old diabetic with hypertension, with dyslipidemia, with anti-TPO antibodies positive, I'm sure all of you will agree that she requires treatment. So these are the, this was the discussion about subclinical hypothyroidism, when we should treat and how we should follow patients who are not treated. So thank you all for the patient hearing. I will be happy to answer any questions. Yeah.
Sir, in my hospital, the thing is that there are a lot of IVF cases planned and they come for fitness. So the main issue is that the gynecologists say that we need to plan it exactly as the pregnancy guidelines are. The pregnancy guideline states that you have to maintain TSH less than 2.5. So if the TSH is 4 or 5, we usually start with thyroxine, then the patient gets pregnant, and still as the pregnancy advances, the FT4 remains same, but TSH keeps on increasing or maintains at 3.5 or 4. So in such cases, do we increase the thyroxine dose or maintain the same dose because FT4 remains normal?
Yeah, you may need to increase the dose also, because we need to, the target for pregnancy is a TSH of less than 2.5.
Irrespective of the T4 values?
Irrespective of T4 values means you do not want the T4 values to become higher than normal. You want it to be in the higher range of normal, upper range of normal. The FT4 values, you want to keep it in the upper range of normal.
So if that is maintained, but still TSH is high, then also we have to increase the dose? That's what I had a doubt on.
Yeah,
Because
so in those situations, maybe you have to individualize and decide about that. But generally, the goal in pregnancy is to keep the FT4 in the upper range of normal while keeping the TSH below 2.5.
Thank you, sir.
Thank you, Sai sir, for a wonderful talk. Now I would request the esteemed chairpersons and the speakers to kindly go on the side stage for their felicitations. And I would request Professor Anuj Maheshwari, Dr. Narsingh Verma sir, and Dr. Anil Virmani sir to kindly felicitate the esteemed chairpersons and the speakers. Meanwhile, the next session is a Dr. Muruganathan oration, and for this, the esteemed chairpersons are Dr. Pur C.S. Dash and Dr. Laltendu Mohanty and Dr. Aditya Sahu. May I request the esteemed chairpersons to kindly come on the stage. We are truly blessed to have Dr. Anup Mishra sir with us, and he will be delivering the Muruganathan oration. Request the chairpersons to kindly come on the dais, please.
Thank you. It's an honor to be speaking on an oration on the name of the man who's perhaps one of the most popular physicians in India. And not only that he has done a wonderful amount of work. I was speaking to him this morning on cancer care and lots of social work in this particular area, and I'm glad and I'm privileged to be speaking on his name. Now, the topic for today's presentation is ectopic fat and brown fat in Asian Indians, and I'll try to finish within 29 minutes. So what is ectopic fat? Ectopic fat is the excess fat deposition at various places in the body where it is usually not present. And in addition, quality of such ectopic fat is also altered so that it becomes more pro-inflammatory and more pathogenic. Now, if you look at this is the algorithm how ectopic fat is deposited in the body. Once you have increased caloric intake, reduced energy expenditure, and a rare disease called lipodystrophy, and at the background of gene and environment, there is a positive energy balance. Now, this energy tries to become deposited in the fat depots, which are usually there, like subcutaneous fat or intra-abdominal fat. And once they are exceeded, then the triglyceride accumulation occurs in non-adipose tissue. And three most common tissues are muscle, liver, and heart. But these are not all. There are a number of more. For example, heart, epicardial, and I'll come to this, heart. Intrahepatic fat, fat in and around pancreas, intramuscular fat, fat around the neck, fat around the kidney, abdominal visceral fat, and perivascular fat. Now, I'll not be talking about abdominal visceral fat and perivascular fat because of the lack of time. And all these lead to inflammation, insulin resistance, oxidative stress, adipocytokines, increase in the blood pressure, and increased cardiovascular and metabolic risk, and finally leading to end-stage diseases. Now, let's talk about fat around the neck. If you look at this guy, who's a 42-year-old individual with pre-diabetes, he has two problems at the neck. Is the acanthosis nigricans, which you can see very well, and the other is excess deposit of fat over the dorsocervical region, what is usually referred to in, and example is Cushing disease, is buffalo hump. Now let's look at the fat around the neck. Usually there are two types of fat. One is around the circumference of the neck, and other is around the back of the neck, and third type of fat is below the chin. I'll briefly go through all this. Now, it is a proxy of upper body and abdominal adiposity associated with obstructive sleep apnea, and neck circumference is related to muscle sympathetic nerve activity, and you can see on the right side how neck circumference turtle eyes are associated with increased sympathetic activity. And also neck circumference, when it's increased, is associated with multiple cardiovascular risk factors independent of abdominal obesity, the blood pressure, lipid, fasting blood glucose, insulin resistance, etc. So this is regarding the neck circumference. Now, as far as the double chin and buffalo hump is concerned, now buffalo hump, there is a way of diagnosing buffalo hump, and we have done that in our publication way back, 15 years back, in Diabetes Research and Clinical Practice. And these two things are actually not new. They are derived from certain other diseases. For example, buffalo hump from Cushing disease, and also HIV-associated lipodystrophy. And the double chin is very, very common, and excess fat deposition very common in partial lipodystrophies. Now, we have researched that, and we have found that these two are associated with metabolic syndrome and excess diabetes risk. This we did quite some time back. And since then, there was no publication at all till this publication occurred. There, they did one step more by actually assessing the dorsocervical fat, and you can see baseline, if you can see the dorsocervical fat, and the MRI, they quantified that, and blue color is the excess chin fat. The top one is a person subsequently lost 18 kg, and you can see both have gone down, and the person who has lost 5.4 kg has more of a dorsocervical fat loss rather than chin fat loss. Now, they have done a randomized control trial using various measures of lifestyle and diet and found that cervical subcutaneous fat remained significantly down subsequent to the measures, but there is a rebound of the chin fat. And there is a specific relationship of chin fat with glycemic profile, independent of all the other markers, including the total body fat and visceral fat, and cervical fat with triglyceride. So these two stores are important, very easily recognizable. Anybody can recognize. And once you go into the clinic, you should look for the excess fat on the back and the chin fat, apart from acanthosis nigricans. So 3 markers of insulin resistance are right there on the first go when you examine the neck. Now let's come to the fat around kidneys, and you can see our publication here where we quantified the para-retroperitoneal fat and para-renal fat. There are 2 types of renal fat. One is the para-renal fat, and other on the left side, if you see, renal sinus fat. Perhaps renal sinus fat is of more importance. Now, if you look at the studies here, fat in and around kidney, they play important role for maintenance of blood pressure and kidney functions. And high amount of fat in renal sinus, perirenal area is associated with hypertension, and you can see increased number of medications with increased amount of the perirenal fat. Also, microalbuminuria and GFR decline. The more the perirenal fat and renal sinus fat, the more the decline in the GFR. And that mechanism may be many: local pressure on renal veins and ureters, cytokine-induced damage, and effects on renal arteries and mesangium. Let's go to the other organ, which is the now central point of research as far as the ectopic fat is concerned, which is epicardial and pericardial fat. And if you look at here, the epicardial fat is located within visceral pericardium. And you can see here, the pericardial fat is located between visceral and parietal pericardium. Pericardial fat is outside that, and perivascular fat is around the blood vessel. And that's the 5th kind of cardiac fat, which is intramuscular cardiac fat. So there are 5 types of cardiac fat. And if you look at this, epicardial fat area and pericardial fat area in a lean person and in an obese person is much more, 3 to 4 times more. Both have increased. And what is the significance of this kind of fat? Pericardial fat. This is the old publication from Framingham Heart study. Amount of intrathoracic and pericardial fat is associated with cardiovascular risk factors and coronary artery calcification independent of convention factors. And potential mechanism, you can see the tertiles of visceral fat, both slides, men and women, and within those tertiles, the tertiles of the intrathoracic fat assume more importance. And potential mechanisms include association with insulin resistance and inflammatory markers, and local toxic effect like inflammation and smooth cell proliferation. Epicardial adipose tissue has been researched quite a lot in last 10 years. And if you can look at that, it is associated number of cytokines, and huge number of cytokines here. And not only associated with increased risk for coronary artery disease, but atrial fibrillation, heart failure with preserved ejection fraction, and also COVID-19. So this is the kind of significance the epicardial fat carries now. Potential pharmacological intervention for epicardial fat, reduction of epicardial fat include statins, metformin, SGLT2 inhibitors. Pioglitazone actually does not reduce the fat, but it becomes less inflammatory. GLP-1 receptor agonists, DP4 inhibitors, and there are a number of other medications. Deep subcutaneous abdominal fat. This is also something which is talked about very less. Now, if you while the visceral fat, which is intra-abdominal fat, is much talked about. So if you look at the many publications, it is only intra-abdominal fat which is being talked about. It is truncal and abdominal subcutaneous fat. Subcutaneous fat, you can pinch subcutaneous fat from your trunk. This is thicker in Indian population and more important as far as metabolism is concerned. Why? It has 3 times the mass of intra-abdominal adipose tissue and thus associated with high free fatty acid and cytokine load. So this is something which is contrary to the popular opinion, and we have done a number of research studies in the USA and here which show that this is perhaps the more important. Both are important, but more important. Now, if we look at this is the MRI image, lumbar vertebra 3 to 4 labels, and the white color is the adipose tissue, and this is the superficial subcutaneous fat at lumbar vertebra. And you see a fascia next to it, and this is the deep subcutaneous tissue, more so in the posterior side. So I'm not going to talk about much about the visceral adipose tissue, intra-abdominal visceral adipose tissue, but this is perhaps more important. And you can see we can, using a software, we can exactly quantify. This is one of our publication. This is my friend's publication, David Kelly's, in JCM 23 years back. He did hyperinsulinic clamp and looked at the insulin sensitivity versus number of adipose tissues, adipose, thigh, superficial, subcutaneous adipose tissue, deep subcutaneous, and visceral adipose tissue, and found that insulin sensitivity is more correlated with the deep adipose tissue. And you can see the deep adipose tissue in the yellow on the right side on the cartoon there. Not only that, the deep adipose tissue is built differently, and you can see here the smaller adipocytes here as compared to the superficial adipose tissue. And if you look at the genes associated with deep adipose tissue, the number of genes which are associated with and these are associated with PPR gamma genes, also inflammatory genes, and so on. So it is phenotypically and metabolically is different from superficial adipose tissue. It deals with more metabolism, and perhaps that's why it is more important as far as insulin resistance is concerned. And let's look at the pancreatic and hepatic fat. I will not talk much about hepatic fat, which I'm sure you have heard in many lectures, but just a couple of points. Asian Indians have twice the amount of hepatic triglyceride than white Caucasian. Only one study is available. I'll show you. And comparative value of pancreatic fat among various ethnic groups is not known. Both are important, and I'll show you how. Now, this is the only study which is available, which has been done in non-obese, non-diabetic Asian Indian in the United States versus the white Caucasians. And you can see at the BMI of 22, they're non-diabetic people, their Asian Indians are highly insulin resistant and also have 2.5 times more hepatic triglyceride than the white Caucasian. So our livers are packed with the fat. But it is pancreatic fat which has been less researched and more fascinating entry. You look at the pancreatic fat here, how it is quantified. It is usually 3 to 10%. This is the color mapping of the pancreatic fat in patients with type 2 diabetes. And if you look at this pancreatic fat, otherwise pancreas is innocuous, is a well-functioning organ. And you look at this, this is the adipocyte free islet. It is a well-functioning organ. The moment there is infiltration of fat, and look at the infiltration of fat, and next to it you see the inflammatory cells, you look at that it becomes pathogenic. That there is more inflammation, more cytokines, and it is influenced by a hepatokine called fettuin A, which is secreted from liver. This becomes a problem because then the islet cell start having dysfunction and decrease in the insulin secretion. We are the only ones from India who have researched pancreatic fat, and this is a study where we took non-obese diabetic and compared them with non-obese, non-diabetic people and various adipose tissue using MRI scan. And I'm only going to dwell on pancreatic volume. Here, pancreatic fat was not estimated, pancreatic volume was estimated, and pancreatic volume in diabetic people, which is in the dark, is much more than non-diabetic people. And look at one such case here. On the right side is a non-diabetic, non-obese person, age 25 years, BMI 21, body fat 27.2%, pancreatic volume which is less than a non-obese case of type 2 diabetes. So our pancreas is more fatty and increase in the volume. Now this is one study where number of ethnic groups where pancreatic volume has been estimated, and look at our study, pancreatic volume was 53.2, which is different from Canadian, from Japan, from South Korea, from UK. So there are ethnic differences in the pancreatic volume also. Now, we know that once positive energy balance occurs, with pre-existing muscle and insulin resistance, there is increased liver fat and increased insulin resistance, which leads to increase in the secretion of triglyceride and increase in the secretion of ferritin A, which leads to increased fat storage in the subcutaneous tissue, especially deep subcutaneous tissue, and its capacity is exceeded, then the inflammation, islet cell triglyceride deposition occurs, and simultaneously inflammation occurs in pancreas, which leads to decrease in the insulin secretion. This is the two-organ hypothesis for diabetes, and both organs are very important. Now, how to decrease this? 2011, 11 obese patients were given 600 kilocalorie diet, followed up for 1, 4, and 8 weeks. And if you look at this, fasting plasma glucose normalized within first week. So they reversed back. This is one of the first study, in fact, the proof of concept study for so-called reversal of diabetes. But more importantly, look at the hepatic triglyceride content, with decrease from 12.8 to 2.9. So 10% decrease. And the pancreatic fat content 8 to 6.2. Now these authors, Rod Trailer is a topmost author in this area, said that the reversal of diabetes is related to decrease in the pancreatic and hepatic fat content. And so if we do this, then our liver becomes normalized as far as fat is concerned. Insulin secretion, insulin resistance becomes better. There is much less secretion of triglyceride and ferritin A from liver. There is decrease in the islet cell triglyceride and normal insulin secretion. Now, this can be done by the diet, or it can be done by drugs. For example, we did a study with dapagliflozin, and look at we took overweight people and with uncontrolled diabetes, and once we gave dapagliflozin, we looked at their hepatic and pancreatic triglyceride using MRI scan. This is the MRI proton density fat fraction for, look at the report here, 9 regions of interest as far as the liver fat is concerned, and 3 regions of interest in the pancreas. Look at in this person, 30% approximately liver fat, and around 2 to 5% is the pancreatic fat. In 120 days time, this was published in Journal of Clinical Endocrinology Metabolism, reduction of hepatic fat from 15.2% to 10.1%, 5%, which is as opposed to 10% of the study of Lim et al., which I showed you, where diabetes was reversed. And reduction of pancreatic fat from 7.5 to 5.9, 1.5%, in Lim study 1.8%. So we're getting there using the drugs also. Maybe GLP-1 agonists will be acting more. So this is one of the first studies of pancreatic fat reduction using a SGLT2 inhibitor anywhere in the world. Now this led to decrease in the insulin and C-peptide in these patients. So towards reversal. What about muscle fat? Look at the patient with type 2 diabetes, muscle fat here on the left side, non-diabetic subject, no muscle fat. And there was this study which we did long time back in All India Institute of Medical Sciences. Look at the patient of type 2 diabetes using NMR spectroscopy. We found the huge peak of IMCL there, while in normal subject there was no peak. Now people at that time were also investigating in UK, and we were investigating in India, and we found that this is related to insulin resistance more so in the Indian population than the Western population. But subsequent viewpoints have changed. They think that muscle fat is actually storage fat, and it increase in athletes also, increase in diabetes also. Athletes are able to actually utilize it better, and diabetic, it stays there and creates further problem. Now, finally, the brown fat. Now, brown fat, you look at on the left side is the white adipose tissue. On the right side is the brown fat, which is there are number of small lipid droplets with increase in the mitochondrial density and high UCP levels and high sympathetic nervous system innervation. Now, how it is activated? Brown fat is not activated all the time. It is not present in all the people all the time also. It is present in hibernating animals. So if there is a cold or adrenergic receptor activation, then beta-3 adrenergic receptor is activated, triglyceride is released, which goes to UCP1, which there is uncoupling of UCP1, which leads to non-shivering thermogenesis. Now, that is usually found in hibernating animals. Remarkable capacity to dissipate energy via brown fat specific UCP1. And using FDG PET scanning, it is shown that it is detected in only 10% of the population. These are called BAT positive. Higher at young age, decreases with age, and amount of BAT is inversely proportional to BMI, adiposity, and intra-abdominal fat. And there is between white adipose tissue and the brown adipose tissue, there is a beige adipose tissue, intermediate state, and every effort should be made to brown this white adipose tissue so that there is more brown adipose tissue. Now, what about Indians versus Western population? And if you look at that, the resting energy expenditure of South Asian when you are resting versus a white person who's resting, they are spending more calories. Why? Because their brown adipose tissue is almost twice the amount than the Indian population. So they have more brown adipose tissue than the Indian population. That it significantly contributes to whole body thermogenesis, almost 200 to 400 calories per day under cold condition, which is equivalent to the calorie loss with SGLT2 inhibitors per day. And BAT negative subject in 40s possesses approximately 6 kg more weight, body fat, than BAT positive subject. Hence, it is tempting to propose BAT as target for weight loss. Now, if you look at this, there are two pressors here, cold and capsaicin. BAT detector subjects were taken, effect on fat mass was seen, and if you look at the cold, when the cold is applied, body fat mass decreased. And you know, a cartoon here, people are going to cold places to lose weight. Capsaicin, chilies, mircha. Capsaicin application leads to decrease in the body fat mass. So these are some of the modalities where you can activate the brown adipose tissue and make them beige adipose tissue from white adipose tissue. Cold-induced activation of BAT improves glucose and lipid metabolism. So you can see on the left side is person who's not been exposed to cold, right side who's been exposed to cold. And insulin sensitivity in those people who are exposed to cold increased, but fast-paced insulin response, there was no change. Now, there are other things like tea, catechin, and caffeine. Acute study with these and chronic study with these in high BAT people and low BAT people. And look at this, an acute study, catechin given in high back people led to markedly increased energy expenditure and also increase over 5 weeks in cold-induced thermogenesis. How to increase BAT and beige adipose tissue? There's some other methods. Let's look at this girl who's been peeling apples and giving her husband only peeled apples, which is not good because apple peel has ursocholic acid, which if given to people with white adipose tissue and brown adipose tissue, it doesn't do anything to white, but increases brown adipose tissue, increases in UCP levels, and increase body temperature. So the peel of the apple is another thing. And increases, in addition, as a bonus point, AKT signaling. There are a number of things which can actually act on brown adipose tissue or white adipose tissue change to brown adipose tissue, cold beta-3 adrenergic activation, CB1 receptor activation, estrogens, T-catechin and coffee, capsaicin, ursolic acid, resveratrol, melatonin, sildenafil, pioglitazone, sitagliptin, and fluvastatin, and maybe GLP-1 receptor and log. So this is something which is a work in progress. This is something which is extremely important subject and extremely fascinating as far as Indian point of view is concerned. So Indians are composite of this metabolic state. We have number of adipose tissue which are more than Western population. Truncal subcutaneous adipose tissue, abdominal subcutaneous adipose tissue, intra-abdominal visceral adipose tissue, hepatic fat, these are all more than white population, and research has shown that maybe epicardial and pancreatic fat also may be more, but there's no comparative data is available. Again, skeletal muscle fat needs to be researched more. Subcutaneous adipocytes also structure is different as far as South Asian is concerned, and brown fat, I have told you, it is lesser in Indians than white Caucasian. So a person with good metabolism, many of you may be having good metabolism. If you take more energy excess, it is mostly deposited into superficial subcutaneous adipose tissue, and adipocyte hyperplasia occurs. There is not much of outpouring of free fatty acid, not much of liver triglyceride, not much of the islet cell triglyceride, leading to good metabolism here. What happens in most of us who have pretty bad metabolism for whatever reason, energy excess leads to adipocyte hypertrophy and hypoxia, leading to decrease in the adiponectin and deposition in the deep subcutaneous adipose tissue. With a free fatty acid flux, with increase in the hepatic triglyceride, increase in the islet cell triglyceride, and in the background of less brown fat, this leads to all sorts of dysmetabolic state. So finally, to summarize, just to recap, ectopic fat accumulation, abdominal subcutaneous tissue or hepatic, plays a key role in glucose, insulin, lipid metabolism, increasing cardiovascular risk in Asian Indian population. Role of muscle, pancreatic and epicardial fat continues to be researched. Unfortunately, in our country, hardly any group is doing research in this. Whatever we get is from other countries where comparative data are available. We should do more research. Presence of the simple phenotypic markers, buffalo hump and double chin, need metabolic investigation, and research should be done to enhance activation of brown fat in Indians. Again, this is something which needs to be researched. So thank you again for giving me this opportunity, and I speak oration in the name of a person who impresses me and who's a great man as far as the medicine in India is concerned, and I hope he becomes president of IMA and many more things in years to come. So thank you, chairpersons.
Thank you very much, sir, for an excellent talk and guiding us through what is ectopic fat and its role in health and disease, and also about brown fat. It's an eye opener, please, sir. Thank you very much for an excellent talk. Since it's an orison, I don't require any questions from the audience also. Thank you, sir.
Thank you, sir. It was very enlightening. And now I would request the chairpersons to kindly join on the stage for the felicitations. And I request Professor Anuj Maheshwari and Dr. Anil Kumar Vimani, sir, to felicitate the chairpersons and the speakers. Huh? Okay. So moving ahead, so we are running short of time. So now the next session is about burps and bowels. And the first speaker in this category, we'll request the chairpersons to kindly join on the stage, Dr. Uma Shankar Mishra, Dr. Manoj Sahu, and Dr. Nihar Sahu. Please join us on the podium. The first speaker is not there, and you come? Okay. So Dr. Tapas Bandyopadhyay has joined us. So Dr. Supratik will be chairing the session with Dr. Uma Shankar.
You can change, yes. Which one? So,
Just wanted to introduce, he's very renowned physician in Kolkata, and he's the secretary of API West Bengal chapter and a fantastic orator. So it's a pleasure to have you on board.
Thank you, Chairperson, sir, and thank you, organizer. This is a Sunday morning, and I am very much satisfied and pleased to see the number of faculties and delegates being present here. I would like to, at the onset, thank the organizer, particularly Dr. Anuj Maheshwari, Governor, Dr. Anil Virmani, and Dr. Jayant Panda for organizing this, for giving me this opportunity, and to present this my presentation before you. So my topic is functional dyspepsia, how to manage. I'll make it very brief, and I'll definitely finish on time. I have no conflict of interest. So the outline of talk, this is my outline of talk, and as you all know that prevalence of functional dyspepsia is 5 to 10% worldwide. The pathophysiology is not well understood, and there lies the confusion. If the pathophysiology is not well understood, easily you can imagine that there will be multiple proposed pathophysiologic mechanism. Now this functional dyspepsia, this is being divided as per Rome 4 criteria into postprandial distress syndrome and epigastric distress syndrome. And there is a overlap of PDS and EPS, and that amounts to almost 30%. That is 30% of PDS, 30% to 40% epigastric pain syndrome, and overlap 20 to 30%. And this is the actual algorithm, that epigastric pain syndrome is when one or more of the features of epigastric pain 3 days a week, more than or equal to 3 days a week, epigastric burning 3 days or more a week, and impacts on life, no organic pathology being found. I will explain it later on. And criteria should be present more than 3 months, and the onset should be at least 6 months from the diagnosis. While postprandial distress syndrome, there's the one or more of the following, that is postprandial fullness, and that should be present more than 1 day or at least 1 day in a week, early satiety for same duration, and impacts on life, no organic pathology. Criteria should be more than 3 months, and onset should be more than 6 months from the diagnosis. Now, I will not go to the detail of each pathophysiologic mechanism, but these are the proposed: gastric emptying, accommodation, visceral hypersensitivity, then Helicobacter pylori infection. The role of each pylori infection remain unclear, but this is very important to rule out sometimes for H. pylori functional dyspepsia management purpose. Then altered gut microbiome, psychological dysfunction. I will come while I will describe the treatment. And this is the vast number of differential diagnosis of functional dyspepsia, but clinically you need to rule out 2-3 important common clinical scenario like gastroesophageal reflux disease, medications, then peptic ulcer disease, and most importantly, you should not miss gastroesophageal malignancy. So I will come one by one. As usual, the history is very important. A dominant history of heartburn suggests gastroesophageal reflux disease, as you all know. Aspirin use or NSAID use, possibility of peptic ulcer disease. If there is any radiation of pain suggestive of chronic pancreatitis, significant weight loss, anorexia, anemia, and dysphagia, odynophagia suggestive of or ruling out gastroesophageal malignancy. Physical examination, epigastric pain or tenderness. This is very important because the presence of increased local tenderness during muscle tensing, this is called positive Carnett sign, that suggests presence of abdominal wall pain. Negative Carnett sign suggests visceral pain. One should also look for palpable abdominal mass clinically. If there is any lymphadenopathy, if there is jaundice, if there is any bruit or succussion plaque or pallor. Ascites indicates peritoneal carcinomatosis or any malignancy. Patients with an underlying malignancy may have evidence of muscle wasting and also some other features. This is the Carnett sign, how to elicit Carnett sign to differentiate between the visceral pain and the parietal pain. This is already I have described that the functional dyspepsia is there is a overlap between EPS and PDS, and most important is you should exclude organic pathology. This is the part that we should give due importance. According to Rome 4 criteria, functional dyspepsia is defined as presence of one or more of the following, that is postprandial fullness, early satiety, epigastric pain or burning, and no evidence of structural disease. And that includes to rule out by upper GI endoscopy to explain the symptoms. While patients with these symptoms and a negative diagnostic evaluation likely to have functional dyspepsia, the criteria should be fulfilled for 3 months at least, and the onset should be 6 months at least. Now, this is very important. Where and in which group of patient, at which age, endoscopy should be done. Endoscopic evaluation of patients less than 60 years is reserved for following purpose, for following group of people. If there is clinically significant weight loss, more than 5% in last 6 to 12 months. Second is overt GI bleeding, more than one other alarm features or rapidly progressive alarm features. And the recommendation to selectively perform upper GI endoscopy in patients with less than 60 years is based on the evidence that individual alarm features have low positive predictive value for an upper GI tract malignancy. And these are the alarm features. The clinician must know that what are the alarm features: unintentional weight loss, as I have already said, dysphagia, odynophagia, unexplained iron deficiency anemia, persistent vomiting, any palpable mass clinically, if there is any lymphadenopathy, and family history of upper GI tract cancer. Regarding the cutoff age for doing endoscopy, the optimal age cutoff for endoscopic evaluation is controversial, and the support is by limited evidence that suggests that risk of malignancy in most US population, in contrary to the Asian population, below the age of 60 is very low, chances of malignancy. But in Asian population, the age is much lower. The American Gastroenterologic Association guideline that suggests that it may be reasonable in rich countries to consider the age of 60 or 65 years as the threshold for endoscopy, while 45 or 50 years is applicable and is more appropriate for Asian countries and few ethnic groups like Asian Americans, Hispanic Americans, and Afro-Caribbeans due to the increased risk of gastric cancer or in population with high incidence of cancer in younger individual. European consensus again that recommends endoscopy in patients older than adults older than 45 years with persistent dyspepsia. And this is another important area that internists must know, that where to test for H. pylori because it is causally related to functional dyspepsia, and when to treat. The rationale for H. pylori testing in patient with dyspepsia is based upon the recognition that H. pylori as an etiological factor in peptic ulcer disease, and there are various methods of H. pylori diagnosis. Mucosal biopsy is one of them. It should be done, when done, it should be done according to the SIDD protocol, and this is the protocol. In patients who do not require upper GI endoscopy or in whom biopsy is not performed at the time of endoscopy, testing for H. pylori can be done for active infection using two of any of the tests like urea breath test or stool antigen test. Serological testing should not be done because of their low positive predictive value, and patients who test positive for infection should undergo treatment with eradication therapy, and eradication should be tested after 4 weeks, at least 4 weeks after giving anti-H. pylori therapy. So urea breath test and stool antigen tests are the tests that should confirm eradication. Invasive methods by histopathology, Sydney protocol I have already described. Biopsy rapid urease test is very sensitive and specific, and culture if there is failure of second line therapy only. But H. pylori, one should remember, may not be detected in conditions like extensive gastric atrophy, intestinal metaplasia, maltoma, I will come to later on, and recent antibiotic therapy or recent PPI intake. American College of Gastroenterology recommends using testing of H. pylori only if clinician plan to offer treatment for positive results, and these are the indications: active history of peptic ulcer disease, patients with unexplained iron deficiency anemia or vitamin B12 deficiency, patients who are likely to be on or are already on long-term NSAIDs, patients on chronic PPIs, and most importantly, gastrointestinal maltoma, because 60 to 90% of low-grade GI maltoma disappears when infection is given and patient is treated. Patients who underwent endoscopic resection for early gastric cancer is another indication. Now this is the treatment algorithm. Patient with undiagnosed dyspepsia, age less than 60 years or age less than, one should look for whether age is more than 60 years. If the age is less than 60 years, then upper GI endoscopy with biopsy if overt GI bleeding, if there is alarm features or significant weight loss. If the age is more than 60 years, endoscopy in all patients with biopsy. If it is negative, then it is functional dyspepsia, and patients who did not perform endoscopy, one should go for stool antigen test or breath test, urea breath test for H. pylori infection detection, and one should look for whether it is positive or negative. If it is positive, then definitely antibiotic and confirm the eradication after 4 weeks at least. And H. pylori if negative, then trial of PPI for 4 to 8 weeks. If antibiotic, after giving antibiotic, one should go for trial of PPI for 4 to 8 weeks. If the symptoms is persistent, then what to do? Discontinue proton pump inhibitor and go for trial of anticyclic depressant, tricyclic antidepressant therapy for 8 to 12 weeks. Again, if the symptom persists, then continue for 6 months and then discontinue. And if again it recurs, then resume the treatment with antidepressant drugs. If the symptom is persistent, then discontinue tricyclic antidepressant and go for prokinetics. And this is particularly important in one variety of functional dyspepsia. If the symptom is persistent, then reevaluate the symptom, perform an upper GI endoscopy if not already done, assess gastric emptying in patient with nausea and vomiting, predominant symptom, and trial of psychotherapy in patients with functional dyspepsia who are motivated. If the symptom improves, then discontinue prokinetic and repeat 4-week course of if there is again recurrence of the symptoms. Now, eradication of H. pylori infection can be confirmed with a urea breath test, stool antigen test, or upper endoscopy based testing, as I have already mentioned. For patients with partial response to a proton pump inhibitor, tricyclic antidepressants can be initiated as a combination therapy with a proton pump inhibitor. And PPI, as you all know, particularly is useful in case of gastrointestinal reflux disease, gastroesophageal reflux disease. Proton pump inhibitor appears to be moderately effective in treatment of some patients with functional dyspepsia, particularly postprandial fullness. And low and standard dose of PPI had similar effectiveness. Not that you can give high dose to treat this type of patients. Twice daily PPI has not been shown to be superior to once daily PPI use. In patients with functional dyspepsia who respond to PPI, attempts should be made to discontinue therapy after at least 6 to 12 months to minimize the long-term side effects of proton pump inhibitors. H2 receptor antagonist, again, only 2 studies compared the efficacy of PPI and H2 receptor antagonist with no difference, but the quality of most trials is very poor and there is insignificant heterogeneity among studies. Another limitation of this study is that the patient with reflux disease may have been misclassified as functional dyspepsia, where the case is actually not functional dyspepsia. For patients who fail to improve with PPI, PPI should be stopped and tricyclic antidepressants initiated. Begin with TCA at low dose, starting with say amitriptyline 10 milligram, and then gradually build up the dose according to the response. Higher doses may not be more effective than in lower doses, and it may be associated with daytime sedation and other anticholinergic side effects. So usually we continue the TCA for 12 weeks before stopping if it is ineffective. If patient responds, continue the drug for approximately 6 months and then consider slowly tapering of the drug. Reserve the use of prokinetics to patients in whom other therapies have failed. C-peptide steroids should preferably avoided due to QT prolongation. If postprandial nausea is a predominant symptom, trial of other antiemetic agents can be employed. There are other modes of therapy like psychotherapy. We reserve psychotherapy for motivated patients who associate symptoms with stressors and in patients who fail to initiate initial empirical antibiotic therapy, medical therapy. Other modes of therapy are funding relaxation drugs, not very useful, and diet modification. I thank you, and before I conclude, I would like to invite you to our annual conference of API West Bengal chapter that will be held in Hotel Hyatt Regency in the month of November 9th, 10th and 11th. Thank you so much, Chairperson.
Good morning. Excellent talk, Dr. Tapas. I'm Dr. Arya from Jamshedpur. I just wanted to know, in functional dyspepsia, you have shown in your slide that if the patient is not responding to PPI, stop PPI and then start TCA.
Right, sir. That is the algorithm, yes.
Suppose we continue PPI with TCA, will it benefit further? What is the reason to stop PPI and then start TCA?
No, actually, what is the question, sir? Once more. If the PPI is stopped and then we start.
This is what you have shown in your
Yes,
slide.
yes, yes.
That in functional dyspepsia, we stop PPI and then we start TCA. Is it?
Is it? Yeah.
So what is the reason to stop PPI?
No, actually,
Why can't we continue both?
alongside with
Yes.
antidepressant.
Right.
No, that in that case, many of the patients may not be actually requiring triclassic antidepressant. They are not due to depressive symptoms as such, but probably the functional dyspepsia is due to postprandial fullness or epigastric pain syndrome. In one group, the prokinetics acts well. In one group, the PPI acts well, but not that we start the antidepressant along with that. We give the PPI along with prokinetic agent blanketly, that patient might be having depressive symptoms, assuming this is not the right way to actually, according to Rome criteria, this should not be done.
Okay, and next thing is, what is your experience? We are using PPI mostly 40 milligram, we have been using so many years. Now, most of them have come with 80. So, what is your experience with this 80?
Sir,
that has to be given OD only.
yes, but basically the recommendation is once daily, not twice daily, but definitely few of the patients who have severe symptoms of particularly GERD, those patients respond to the 80 milligram, but that should be individualized, not that every patient we should start with 80. If 40 milligram does not act even after a reasonable time period, that should be clinically assessed, and then only we can go for 80 milligram.
Thank you.
Thank you, sir.
Can I make a comment?
Sure, sir.
Asia Pacific guidelines, they have very clearly tried to differentiate epigastric pain syndrome versus the postprandial fullness. So in patients with epigastric pain syndrome, the response to PPI is very good. And if you have H. pylori, then obviously treat it. The American guidelines say first treat H. pylori. But in India, the general experience is that treatment of H. pylori may or may not benefit. It's very controversial. Now, for patients who are having the postprandial
Fullness
syndrome or early satiety, which is very common, early satiety, the drug recommended by the Asia Pacific guidelines is acochamide as a fundal relaxant. And they have not recommended PPI for those patients, but I know that in clinical practice people use both. But I don't know whether it is really required, but you try to play safe with your patients. So that is one. And then for others who are not responding again, the postprandial syndrome who are not responding to acochamide, PPIs remain important because two areas have been shown to be very useful. One is those with duodenal eosinophilia or those with duodenal hypersensitivity. Both are fairly responsive to PPI. So PPI does sort of have a role, but then epigastric pain syndrome is the major indication.
Thank you, sir. Which syndrome? Sorry? Sorry? Yeah. Or psychiatric. Yes, definitely this is very much important because as the name implies, this is functional dyspepsia. There is no organic pathology and all the drugs, PPI and prokinetics are not working, and it is related to some sort of somatization problem. So in those cases, definitely we should take the help of psychiatrist and psychologist who can help and sort out this problem, because psychotherapy is one of the important management tool for treating this type of functional dyspepsia.
Can I make one comment?
Yes,
I
sir.
think one thing in clinical practice, and which is my experience as well, is I think we must pay a lot of attention to the diet and the lifestyle of the patient.
Yes, sir.
And it is important, I always tell my patients ki doodh band kar do and put them on a low FODMAP diet. Urad ki dal, rajma, matar, chole and all that has to stop. Gobi, bhindi, muli and all these has to stop. And with that and exercise, I think there is a number of patients who do improve. So that is one area which we should not just ignore.
Yes. Thank you, sir. Thank you, sir.
Good morning. Thanks to the scientific committee, Dr. Virmani, Dr. Panda for inviting me, and also for keeping a topic which is very important, and with increasing age of the population, I think it's time that physicians get apprised of this day-to-day problem of constipation in elderly. Thank you. So, nearly 15% of our general population suffer from constipation, and if you consider a really geriatric group, it's nearly 1/4 of women and 1/6 of men. Very old, prevalence is even higher. A disease that significantly affects the quality of life, and there are significant healthcare costs because of hospital visit, unnecessary investigations, and cost of laxatives and purgatives. Constipation is a symptom, not a disease. And in common clinical parlance, it's usually unsatisfactory defecation. But there are two different issues. One is infrequent stools that suggest colonic motility or propulsive disorder. Another is difficult stool passage that suggests anorectal dysfunction, like either impaired rectal propulsion or defecatory dyssynergia, where the rectal and anal muscles do not work in synchrony, or there may be a combination of both. Likewise, patient may present with infrequent stool once or twice a week, may present with straining, difficulty passing stool, fingering, manual maneuvers, etc., or there may be a combination of both. And it is surprising to know that of elderly people, because my topic is constipation in elderly, 1/5 suffer from rectal outlet delay and most go unnoticed. There is an elegant study which shows that in nursing home or long-term care resident elderly, the use of laxative is very, very high. And on the medical front, there are complications of constipation like fecal impaction, starcoral ulcer with bleeding or perforation, volvulus, and frequent visit to hospitals for enema administration. There are certainly certain physiological changes that occurs in elderly, one of the most notable being reduction in high amplitude propagated contraction or HAPS that decreases colonic propulsion. But even more important than that, there is decreased colorectal sensory motor function, impaired rectal sensitivity, so impaired urge to pass the stool. Most of this result in constipation, in some cases with concomitant urgency, incontinence or seepage of stool. For physicians, this is important to rule out secondary constipation because we know there is a long list of causes that can present as secondary constipation: antidepressant, some antihypertensive, steroids, even antacids or drugs used in neurological disorders or psychiatric disorders, several metabolic abnormalities, endocrine disorders like diabetes, hypothyroid, and obviously some neuropathic disorders, particularly Parkinsonian group of disorders or those with autonomic neuropathy. And it's important that we identify them and treat or remove the cause as far as possible before embarking on evaluating patients on primary constipation. Again, primary constipation could be three types. Slow transit is a failure of colon. Defecatory disorder, it's failure of anorectum. And a constipation predominant IBS, failure of none. So in constipation predominant IBS, along with constipation, you get abdominal pain, which is the predominant symptom and related to bowel action. In slow transit constipation and defecation disorder, patients usually do not complain of significant abdominal pain because these are usually muscle disorders and there is very little sensory component in that. We have Rome for diagnostic criteria. A group of GI specialists sit almost every 10 years in some of the USA cities, and the nomenclature goes after the Rome because they had their first meeting in the historic city of capital of Italy, Rome. There are criteria for constipation, functional constipation, because you cannot do any number of investigations to rule out, diagnose secondary. So there is at one point of time, you must stop doing investigation and diagnose this based on symptom criteria. And that was the rationale for development of Rome 4. Symptoms must be present for at least 6 months to qualify for a chronic disease, that is chronic functional constipation. Again, I repeatedly stress on this point that organic etiologies need to be excluded by history, examination, basic laboratory, and sometimes disease-specific investigations. And there is an overlapping nature of functional bowel disorders as elaborated by Dr. Taposh. Sometimes diseases shift over time, sometimes diseases co-present. Bristol School chart, since its inception in 1986 by some UK group, became very popular, and this has very strong correlation with colonic motility. Harder the stool, lower is the colonic motility. This almost does not have any relevance in anorectal dysfunction. Type 1 is constipation in India because we consume lot of fibers. Type 1 and 2 is constipation stool in Western countries. They don't consume fiber like we Indian people do. Presence of other GI disease, fecal seepage, alarm symptoms, neurological disorders. In history, all this need to be excluded to identify which group of patient we are dealing with. On examination, abdominal mass or lymphadenopathy to suggest secondary cause, pararectal examination to rule out local causes, including digital rectal examination, which is must to identify perineal disease during straining and anal sphincter relaxation during relaxation. Very limited laboratory test because constipation, functional constipation is a symptom-based criteria. Hemoglobin, ESR, CRP, thyroid, calcium, and in some cases, and transabdominal ultrasound. One of the greatest debate of this century is, does constipation, all constipation patients need colonoscopy? Let us see. We have a 60-year-old lady which is hypertensive on telmisartan, well-controlled thyroid, and these are the basic important issues. Constipation with bleeding PR, significant weight loss, elderly sister died of colon cancer. Every physician will do colonoscopy, even she qualifies the criteria for Rome 4 criteria for functional constipation. So colonoscopy in whom alarm features are present, routine, not recommended. There is another debate. Does constipation increase the risk of colorectal cancer? Because low fiber intake is implicated in both. We had a beautiful meta-analysis in 2019 in American Journal, 2011, showing that this is not related. We have another case of 80 years old lady with patient with Parkinson's disease and constipation for long. Only some over-the-counter medicines work. He had sense of blockage of rectum and digital evacuation required at some times. So how do you approach this case? We need some neurophysiological testing, like balloon expulsion test. Very simple test, 4 centimeter balloon filled with 50 cc water inserted in the rectum. With a patient in squatting position, normal person will take 1 minute. Those with defecatory dyssynergia will take 5 minutes or more with patient squatting position. Further, anorectal manometry. Further refinement is MR difficography, which will show the prostate coccyx line, anorectal angle. Any distortion of this line, deviation of this angle, or descent of the anal canal below, significantly below this angle, is suggestive of defecatory dyssynergia or anorectal dysfunction. Another case of 70 years old female, constipation in high school days for last 50 years. Laxatives never give benefit, thyroid biochemistry normal, no other issues. This is slow transit constipation. Passing stool once in a week. This will be diagnosed by colonic transit studies by radioactive marker, further by colonic scintigraphy, and this is very useful to identify what is actually the rate of movement in the ascending colon, because that part stool moves against the gravity. And there are wireless motility capsule, which also identifies the pH. From that you can know whether the pH is low, high or intermediate with stomach, intestine and colon, the upper panel, as also the amplitude of contraction, whether the contractions are normal, upper panel, or infrequent as in the lower panel. So investigations baseline for all, and there are some select patient groups who need more sophisticated and dedicated investigations. Coming to the management, some general conservative approach, definitely drugs will play an important role, and there are other novel therapies, but I know that everyone in this audience, being learned physicians and knowing very well that an effective physician-patient relationship is the cornerstone for successful management of any chronic condition, including chronic constipation. We have to identify learning barriers for each patient. Patients are advised to keep a detailed bowel diary and provide education. Specific dietary recommendations including well-balanced healthy diet, adequate fluid and fiber intake, which has been extensively proposed in most of the guidelines, regular physical activity. But let us take a look how these methods are going to be useful. Does fiber intake benefit constipation? The systematic review says soluble fibers only improve constipation. Insoluble fibers do not. In India, we consume enough of fibers, so it's hardly going to be beneficial for any patient, and particularly if the patient consumes insoluble fibers like skins or the seeds, there is more bloating, particularly in elderly. Does increased fluid intake improve constipation? No. If you are giving fiber, 40 grams, which is the usual recommendation per day, give enough water so that the fiber helps in movement and the water makes the content more slurry. But if the patient is not taking enough of fiber, there is no point. And if the patient is not dehydrated, there is no point. You cannot improve much by just increasing the fluid intake. Does exercise improve constipation? Yes. It has some anti-inflammatory and antioxidant mechanisms and has been extensively reviewed in this article in 2019. Apart from these futile attempts, most of the times with these fiber or lifestyle approaches, we have drugs. 3 major groups like osmotic laxative, stimulant laxatives, and pro-secretory or other pro-kinetic agents, which are usually available as tablet forms, which help in colonic propulsion, and this is a significant new addition in our therapeutic armamentarium for constipation. Amongst osmotic laxatives, 2 are quite popular, lactulose and polyethylene glycol. But the question is, which one is better? We have extensive Indian experience with lactulose. America is more in favor of PEG. And there is a comparison study 2 decades back, PEG is better than lactulose. Amongst the drugs which are stimulant, we have again common use of 2 drugs, sodium picosulfate and bisacodyl, which is usually available as Dalcolax or Dalcoflex. Which one is better? Michael Camilletti's group performed a meta-analysis, the right panel, showing that bisacodyl is the best stimulant laxative. But nevertheless, picosulfate is also useful. Coming to the third group of drugs, pro-secretory or pro-kinetic drugs, there are 3 basic groups. 5-HT4 receptor agonists, they work on stomach like etopride. They work on colon like prucalopride and velucertan. Prucalopride is available in India, other 2 are not. You can have colonic secretogogues which increase colonic chloride and accompanying sodium and water secretion acting on 2 different chloride channels. One is calcium dependent channel, CCl2, another is CFTR, we know cystic fibrosis channel. Final group is opioid receptor antagonist. We knew since our pharmacology days that morphine causes constipation. So opioid antagonists, particularly those working on mu opioid receptors, which are abundant in GI system, they are useful against constipation. And this is a very good review which have shown that almost all these drugs have some limitations, all as well as some merits. But when osmotic and stimulants and even your prokinetics might fail, if the patient's colonic transit is normal, this is functional constipation, and the recent American guideline says, this is from that guidelines, that we have to go for pro-secretory or pro-kinetic agent. Suppose if everything is normal and osmotic and stimulants are not working, but it is advisable to continue osmotic and stimulants SOS basis and to continue the pro-kinetic or pro-secretory continuously. There is not much data what happens or whether prokinetics are going to be useful if you continue them beyond 3 months. If it is a slow transit constipation, patient passing 1 or 2 motion per week, believe me, nothing is going to be useful. Surgery, nobody does for constipation. But if there are rectal evacuation disorders, patient might require enema sometimes and benefit from biofeedback therapy. Problem is that in our country, we have dedicated trainer for this biofeedback therapy. But in ideal circumstances, the efficacy is nearly 70%. 2 basic important issues for elderly. One is opioid-induced constipation because of use of opioid in chronic pain, non-cancer pain. Risk is up to 40%. Risk increases with age. And now we have many good drugs like mu opioid receptors. Some of these are going to be available in India shortly. And in elderly, constipation is often associated with fecal impaction requiring digital disinfection sometimes. We need to rule out other causes with sigmoidoscopy because organic diseases also increase with age, as well as to rule out starcoral ulcer, which will benefit perhaps from topical therapy. Just to summarize, respected chairman, ladies and gentlemen, clinicians must distinguish primary from secondary constipation. Pelvic floor dysfunction is a significant contributor. Fecal seepage or incontinence can occur with constipation. We have to keep that in mind. Giving antidiarrheal for fecal incontinence or seepage will long-term produce more and more constipation. Patients with slow transit are unlikely to benefit from fiber and unlikely to benefit from anything on this earth. Lactulose is safe. Polyethylene glycol is more effective than lactulose. Finally, by adopting a stepwise approach which I have shared with you, towards the diagnosis of chronic constipation in its individual subtype, clinicians have the opportunity to tailor therapy accordingly and improve the symptoms, and the final target is to improve the quality of life and patient satisfaction. Thank you very much.
My question is, when you're doing colonoscopy, how frequent is that is every basis, and how much does that account for constipation?
What is the question? I think. We find what? Diverticulitis. Yes, that's quite common. Maybe in constipation in elderly, 30 to 40% have diverticulitis.
I had one question. This polyethylene glycol, it is said that it causes a lot of mineral imbalance. So if suppose the patient is improving with polyethylene glycol, how long do we give it? And similarly with prucalopride also, if patient is improving, for what duration do we give it? In elderly especially.
No, most of the studies which have been done with most of these purgatives or laxatives, including polyethylene glycol or prucalopride, studies have been done for 4 weeks, 8 weeks, or 12 weeks. So safely you can write that based on the existing literature. But you know, constipation is a lifelong problem. So for most of the patient, practically speaking, you have to continue them for long term. There are studies on polyethylene glycol up to 1 year you can give, but till date there is no study, particularly not for elderly, in prucalopride beyond 3 months. But in any case, you have to continue these drugs for lifelong.
Yeah, I was just coming to what you asked. I absolutely agree with the speaker that about 20% of the patients will have diverticulosis, but not diverticulitis.
Yes.
But diverticulosis is not the cause of the constipation, it is an effect of the constipation.
Yes.
So it's not causing the problem, but a consequence of the problem.
Yes. Thank you.
Good morning, everyone. First of all, I would like to thank the organizers, particularly Dr. Virmani, Dr. Anuj Maheshwari, and Dr. Jayant Panda for having given me this opportunity, and congratulate them for having a very practical session on gastroenterology. These are all common problems which you see in clinical practice, and I think they are not very often discussed. For example, the functional dyspepsia, constipation, etc. They are all very common in clinical practice, not only for physicians, but for every specialty. So I'm going to talk about the assessment and the management of fatty liver disease, which is something which all of us see day in and day out. You send any patient for ultrasound and they come back with a report that there is fatty liver. So fatty liver is very common. That is one thing which is well known, and the overall prevalence globally is about 25 to 30% worldwide. So can you imagine this epidemic where 30% of the global population is suffering from fatty liver disease? Now, what is the prevalence in India? Well, it is variable from region to region. It is variable, and you can see that studies done in Chandigarh in particular showed almost 55% of the individuals had fatty liver. Similar data from Delhi and parts of South India, whereas there is a very old study which is going on from rural part of West Bengal saying that the prevalence is low over there. So I think prevalence varies from region to region. And it is important to know now that this is a recent study where almost 38% of the adults and 35% of the children. So that is very important. Very common in children is something which we are seeing now. The urban population has a higher prevalence than the rural. If you do hospital-based studies versus community, yes, it is higher in hospital-based. There are state-wise differences, and clearly patients who are high risk, those who are obese, diabetics, hypertensives, dyslipidemics, will have a higher risk. So let me take you through the spectrum of the disease. So the disease starts with what we call the steatosis, which means deposition of fat in the liver. And this is what we are talking about, that about 30% of the world population is suffering with steatosis. A significant number of them will develop NASH, which is steatosis plus inflammation plus or minus fibrosis. And over a period of 7 to 8 years, 20 to 25% of the NASH patients develop cirrhosis of the liver. And therefore, we have to catch them early and prevent the cirrhosis. And once you have cirrhosis of the liver, in about 8 to 10 years, 25 or even more patients will develop decompensation of the disease with ascites, bleeding, hepatic encephalopathy, and so on and so forth. And subsequently, death occurs in a significant number of these patients. But one thing to remember, that the most common cause of death is not the liver disease. On the other hand, it is cardiovascular disease, malignancies, HCC, etc. So liver disease is there, but cardiovascular disease remains the most common cause of death in these patients. So it is not, when you talk of fat in the liver, it is not only the liver we are talking about, we are talking about the cardiovascular risks as well. So what is the Indian scenario? Because I think it is important to understand as to what is the natural history, in the sense that if you see 100 patients with fatty liver, should we be bothered about them? Because when you see a report day in and day out, there is a tendency to say, yaar, fatty liver to sabko hoti hai, and let's just ignore it. But we know that the pooled prevalence has been 38%, but at presentation, biopsy studies, fibroscan studies have shown that almost half of the patients have NASH. So that is something very important to remember. We thought previously that the NASH prevalence was not more than 5-10%. They have 50% of them will easily have NASH. And that is irrespective of whether AST, ALT is normal or abnormal. Out of these NASH patients, 30% have got significant fibrosis, 20% have advanced fibrosis, and 10% of them may have cirrhosis right at the time of diagnosis. And I'm talking about, we are in the process of doing a study in our hospital regarding diabetics and fatty liver. And we are picking up so many cirrhotics based on the fibroscan that I am really surprised. And this is something which has always interested me. And I've, many years ago, I kept on talking about diabetic hepatopathy is being ignored. So it is important that we know what are the risk factors which lead to fatty liver and NASH. And the wrong diet, which is high calorie diet, excess of saturated fats, refined carbohydrates. Mind you, this artificial sugars are poison. High fructose intake, because fructose, unlike glucose, is not metabolized in all cells of the body. It can only be metabolized in the liver. And if the liver is already full of sugar, then it is converted into fat. So fatty liver and fructose have a very close association. Patients who are obese, those with hypertension, with diabetes, those with serum triglyceride more than 150 or HDL cholesterol which is low are all high risk. Now, why am I coming to all this and keep talking about NASH? Is once you have fibrosis of the liver, that is the best indicator of progressive liver disease and a higher mortality. So liver mortality increases exponentially with the stage of fibrosis. So if we have to really prevent cirrhosis, we have to start, diagnosing them earlier and treating them earlier. And one common myth, the SGOT, SGPT is normal, so you are safe, is totally irrelevant. Abnormal ALT may warrant workup for NAFLD, but it is not a normal value, does not mean that the patient may not have. And therefore, you should be very careful. If the risk factors are there, you must certainly do proper testing for such patients. Liver biopsy is being done less and less, and it is now called the imperfect gold standard. It was always the gold standard, but imperfect gold standard. But nevertheless, in difficult cases, we still do it. Why? Because it is invasive, it is painful, it is expensive. There is a small morbidity and occasional mortality and sampling variability. And most important, it is very impractical for population screening. And most places, particularly in the rural areas, liver biopsy cannot be done. So the importance of non-invasive testing has now come. So when we are talking about diagnosis of NASH, we are really talking about non-invasive testing. And the ones which are practically, practical for us in a country where we have large areas where all investigations are not available is FIB4 index, NAFLD fibrosis score, and the APRI, the AST platelet ratio index. And you can actually pick up patients who are high risk or those who are low risk or those who are intermediate. And high risk, you know what you are dealing with. Intermediate is the one which requires further investigations. And that is done, most practical way is doing a fibroscan. So the reason I am harping on FIB4 is it only requires 4 parameters: the age of the patient, the ALT level, the AST level, and the platelet count. Something which is available anywhere and everywhere. So just with this data, you can calculate the risk of the patient for developing more advanced disease. So what are the recommendations for screening in adults? Screening for NAFLD and advanced fibrosis is specially meant for those who are obese, those who have features of metabolic syndrome, those who have pre-diabetes or diabetes, those who have hepatic steatosis on ultrasound imaging. So most patients you will pick up because of the ultrasound. The ultrasound showed fatty liver, and therefore you take things from there. But there is also another indication which has been added. Relatives of patients with severe fibrosis or cirrhosis. Why? Because it was seen in studies that relatives of such patients have a higher prevalence of NASH. So this is the guideline which is broadly followed, and this is the American, but we have got now our Indian guideline as well. And so if you have patients who are high risk, which is shown on the left hand side, you obviously will do an ultrasound to see if they have fatty liver. And if they have fatty liver, the first thing to do is to do a FIB4 scoring. A FIB4 value of less than 1.3, remember the values, 1.3 is low risk. On the other hand, a value of 2.6 or more is high risk. And anything in between is the intermediate risk. And for the intermediate risk in particular, the next step is to use a liver fibroscan. The best method is vibration controlled transient elastography, which is simple and is now becoming very popular and is available in most places now. And this is the American data. They say that if you have a stiffness of less than 8, they are low risk. Stiffness of more than 12, they are high risk. And in between is the intermediate. And if you have doubts, then you will go ahead with liver biopsy. So what is the role of liver biopsy now? Well, where you think a patient may have advanced fibrosis, but the issue is always you have diagnosed, what will you do? The treatment remains same or similar. But liver biopsy is even more important when you suspect that there might be some other diagnosis. A patient, for example, who has anti-nuclear antibody which is positive, or a ASMA which is positive, and so on and so forth. And there is always a category of patients where despite treatment, the liver enzymes remain elevated. And I think these are patients where we just try one drug after the other. I think these are certainly patients where you would stop and consider doing a liver biopsy. And this is our Indian data. And the Indian data, basically, we have divided the liver stiffness measurement less than 8.2. So I think this is what we need to remember. Less than 8.2 is low risk. And if they are low risk, what do? Do you just forget about them? No, I think you would give them lifestyle measures and repeat the liver stiffness measurement after 6 months or so. If they are intermediate, then they are candidates for treatment in any case. And if they are high, which is more than 13.6. So we in India have taken the lower value as 8.2, and above 13.6 is severe fibrosis or taken as cirrhosis. But cirrhosis and portal hypertension become more likely if you have a scores of 20, 25. Portal hypertension is said to be present in patients who have LSM of more than 20. So that's how we go about it. Now I will come, so this is the algorithm for diagnosis. And what you are trying to pick up is patients who have got NASH and treat them early, prevent cirrhosis. So patient care has to be individualized. You have to identify and treat all the metabolic factors which are present. And that is most critical. So if a patient, for example, is obese, you have to treat the obesity. And don't, ignore the dietary aspect. Stop alcohol, stop smoking, reduce fructose as much as possible. Now the question always comes, fructose to phal to khane ko kehte hain. So we ask them, but there are high fructose fruits and there are low fructose. And even in diabetics, you allow certain fruits and don't allow other fruits. So you have to be careful there. And there is one thing mentioned over there is coffee. Is coffee harmful? No. On the other hand, having 3 cups or more of coffee may be beneficial for fatty liver disease. So that is something which we ought to remind. I tell my patients, ki chai peete ho yaar, to why don't you switch over to coffee? And maybe I'm not saying there's definite evidence, but there is reasonable evidence. Now this weight reduction pyramid you have seen over and over again. If you have less than 5%, it will certainly affect the steatosis. The fat in the liver will reduce. But it is only when you achieve that 10% level, 10% weight loss, that there is actually reversal of fibrosis. And that is a goal which is very important. If you have a patient with a fibroscan level of 14, you want to revert him. Patient पूछता है, Doctor Sahab, will it come back to normal? I tell them, I don't know about the normals, but certainly with your effort, it will come back. And that is for certain. This is something which you see in clinical practice day in and day out. What drugs to use now? Well, we keep going back to 2011 on this PIVENS trial with vitamin E and pioglitazone, which were used in patients with biopsy-proven NASH and those who did not have diabetes or cirrhosis. And it was found that both these drugs were beneficial in treatment not only of fatty liver, but also of NASH, although the data on reversal of fibrosis is a little bit of a question mark. But then further studies with pioglitazone was done. I think diabetologists are using less and less of pioglitazone. Probably the hepatologists are using more these days. So there was good evidence to suggest that pioglitazone causes improvement in NASH in patients with pre-diabetes and diabetes. And the third drug I'm coming to, and this is the drug which is now approved by DGCI in India, is saroglitazar, which is a novel dual PPAR alpha and gamma agonist. And it certainly improves not only the fat and the insulin resistance, but improves in inflammation, and there is evidence to suggest that they might have some beneficial effect on hepatic fibrosis as well. Now, more recently, I think you all are using a lot of semaglutide, which is one of the GLP-1 analogs. And I think the gastroenterologists are also using a lot of these drugs now, particularly in diabetics, because there is good evidence to suggest that semaglutide increases NASH resolution. And there are a number of other drugs, and for paucity of time, I will not go into each and every one, but certainly just show these currently available drugs which are there as the insulin-resistant targeting drugs. Pioglitazone, liraglutide, semaglutide, exenatide, that doesn't have so much of data on that or evidence on that, but SGLT2 inhibitors are also proving to be good in reduction of fatty liver, although data on fibrosis is still poor, but it is, I think getting there now. So these are important drugs, and some of the other drugs in phase 3 trials, obeticholic acid, I think I've been talking about for the last 10 years. It remains in, the FDA approval has not yet come. So all these drugs are there, but we are not largely using it. So let me just straight come to what are the Indian guidelines telling us, because I think it is practical to follow the Indian guidelines. And the Indian guidelines again are talking about the weight loss, which is induced by diet and exercise, daily calorie restriction by 30% or 500 to 1000 kilocalorie to achieve the target weight loss, and moderate intensity aerobic or resistance exercises also. It's not only the aerobic exercises, but resistance exercises for 30 to 45 minutes a day for at least 5 days a week in all patients of fatty liver, irrespective of body weight. That's the least we can do for all patients. And at the moment, lots of people talk about bariatric surgery, but as of now, we cannot recommend bariatric surgery as a primary treatment for NAFLD. So if you're doing it for somebody who has got morbid obesity, go ahead, but not as a primary treatment for NASH. So the Liver Society of India recommends vitamin E, pioglitazone, and saroglitazar as of now. And you can see over here, and you can read it, that each of them have got their own little problems. For example, use of high dose vitamin E can lead to increased risk of hemorrhagic stroke, possible all-cause mortality is at risk if you're giving more than 800, and prostate carcinoma issue has been largely resolved, I think. But how long do you give the drug for? And don't forget that Piven's trial was for 96 weeks, which is 2 years. So at least we have got evidence for 2 years. But interestingly, when the drug was stopped after 2 years, for most of the patients, there was again a rise in the AST, ALT, and things started to come back. So basically, unless you can really train your patients to go for major lifestyle changes and continue to work on that for a sustained effect, but 2 years we can go ahead. And pioglitazone, well, it is said 30 milligrams per day, but in India we are using broadly less dosage practically. And that again has shown improvement, but you are well aware of the side effects of pioglitazone, and I don't have to talk about it. Unfortunately, it can increase the body weight as well. It has got the cardiac side effects and so on and so forth. Saroglitazar used in 4 milligram dosage, 4 milligrams, and it has shown to be efficacious. There is no significant effect on the body weight by this drug, and ideal situation for giving saroglitazar is a patient with NASH who is a diabetic with dyslipidemia and a high triglyceride. If you have that patient, that is the ideal. I'll sum up in 1 second because I was going to the endoscopic treatment. It is 2 slides, but it doesn't matter. Duodenal mucosal resurfacing is coming as a very useful tool for not only management of obesity, but also for weight loss and liver effects. Combination therapies are in vogue now, and I'm sure in years to come, we will be combining drugs. In conclusion, I would say non-invasive assessment is taking the center stage in risk stratification for advanced fibrosis. So I would encourage everyone to use the FIB4, which is a simple tool for assessment of your patients with fatty liver. Common risk factors are metabolic syndrome or type 2 diabetes and obesity. FIB4 score can be easily calculated and used to identify patients at low risk, high risk, intermediate risk, and so on. All patients with NAFLD should receive lifestyle intervention in the form of diet and exercise, and drug treatment has to be individualized. The more commonly used drugs are vitamin E, and now saroglitazar also has come in. Pioglitazone also we use in selected patients. Thank you very much. But before I finish, can I just make one announcement? I would like to invite each and every one of you to APCON 2024 in Delhi, which will be held from 22nd of February to 25th of February. I'm sure it will be a great event. We will have a great academic feast. And I would like to request you all to register yourself, because all this NMC sword which is hanging, I think we have been in the habit of getting the pharmaceutical companies to register us, but I think we have got to get used to the new normal, which is let's get ourselves registered. It'll be great. Thank you so much.
Sir,
benefit so far as the fibrosis is concerned?
That evidence is coming. The trial is on at the moment, but there is a small evidence, not a very good evidence, but evidence in relation to improvement in AST, ALT, fat reduction is all there, and triglycerides go down. And if the patient is working, I think in practice we find that typically when I've given it to patients for the ideal indication, which is diabetic who is dyslipidemic, etc., I have found a significant reduction in fibroscan levels as well. But that is my personal experience. We are waiting for the final trials or larger trials, I would say.
Sir, you are all right. Actually, in treatment of NAS, or you can say NAFL, what matters is the ultimate outcome, that is development of fibrosis. Unless the drug has a very solid effect or documented effect on the reversal of fibrosis, I think hardly it is of any use. The second question, sir, regarding the semaglutide, when you are going to study the development of fibrosis, it takes a long time.
Yes.
It takes years. This
Yeah.
is a molecule which has come off only recently. So I have a doubt actually, is there any RCT or any documented proof that our long-term study where semaglutide has been shown to reverse fibrosis?
Your reservations are absolutely valid, but I feel that if you've got a good drug with reasonable evidence, and we say कि नहीं जब तक हम 10 साल का study देखेंगे नहीं, I won't
No, I want
use
to
it.
know, is there or not?
Yes.
I don't say that not to give.
ऐसा
Because
है,
logically we are supposed to give, but I
No,
I
no.
want to know about the
I will
evidence.
tell you, as far as the saroglitazar is concerned, there are small studies to suggest that there is reversal of fibrosis. But whether we believe in those studies or we should wait for larger studies is one thing. However, if you have a drug which you are using for a diabetic with dyslipidemia and also has positive effects on the liver, there is definite evidence to suggest that it reduces the AST, ALT level, that it reduces the fat in the liver, and some evidence to suggest that it may improve fibrosis. I don't think that we should become too critical of it, and there is no wonder that DGCI has given its nod, because it's not that that is the end of the story, but yes, it can be used in those situations.
Thank you, sir.
May I just one thing? First of all, his question. We have recently done meta-analysis on saroglitazar published and meta-analysis on semaglutide in NFLD. Saroglitazar is very useful drug, as sir you said, on all parameters except that fibrosis, because in fibrosis there is not many studies on which we can conduct the meta-analysis. Semaglutide is also same, but problem with semaglutide that is it increased GI side effects significantly, and as you know, most of patients who suffer from dyspepsia, semaglutide increases their symptoms.
Yeah, yeah.
So, sir, my question to you is that is your approach for lean NASH is different?
No,
What lifestyle advice you are going to give?
See, lean NASH is basically lifestyle becomes the most important, because there is good evidence to suggest that diet and exercise itself reduces insulin resistance and thereby benefits these patients. So lean NASH treatment predominantly remains lifestyle measures. As far as I said, we can either be a science purist or we can say this appears to be a good drug and use it. And my last conclusion was individualize your treatment. You have to choose as to which drug I am going to use in which particular patient. And I'm not saying that giving a drug is going to reverse it. Don't forget that progression took 16 years, 20 years. And you want a drug to be proven that within 3 months it reverses the... So that is, data is not going to be easily available. It will take time. But shall we just wait for it or use it because it appears to be, beneficial?
Next speaker is Dr. Saurabh Srivastava. To speak on Indian so we can identify this.
First of all, I thank the organizers, especially Dr. Anil Maheshwari sir, Dr. Narsingh Rao sir, Dr. Anil Urmani, Dr. Jayant Panda for giving me opportunity to be present in the front of August gathering. My topic has been taken care of by, we have 3 gastroenterologists speaking before me. There are functional disorders we have talked about, so topic is, most of the things have been taken care of. coming to irritable bowel syndrome, with the Rome criteria have already been described by the previous speaker, that functional bowel disorders are being classified by Rome criteria. So Rome 4 criteria signifies that there is a prevalence of IBS worldwide, and in India, the prevalence comes to be around 5 to 7%. And if you see this slide, that global prevalence of irritable bowel syndrome is around 11%, and if we come to Southeast Asian region, it is around 7%. It is being associated with many comorbidities such as functional GI disorders, functional gastrointestinal disorders, and psychiatric conditions, and had major impact on the individuals in the lowering the quality of life, avoiding difficulty in concentration, loss of income, and loss of freedom and spontaneity. So everyone experiences an upset stomach time to time, but it passes. However, when there is an irritable bowel syndrome is a player, the upset stomach won't end, and it keeps coming back every day. To make matters worse, the symptoms of abdominal pain, bloating, gas, diarrhea, or constipation, they aren't predictable. They can come anytime. IBS can wreak the havoc in people's personal and professional life. About 2 of the 3 people with this syndrome are female, and most are younger than 50 years of age. Female to male ratio, around females have about 2 to 2.5 times more than this disorder as female, and most common manifestation, men is diarrhea and women is constipation. The Rome diagnostic criteria for irritable bowel syndrome is the recurrent abdominal pain on an average at least 1 day per week in the last 3 months, associated with 2 or more of the following criteria. That is, the pain is related to defecation, it is associated with a change in the frequency of stool, and or associated with the change in the form of stool. The criteria fulfilled for at least 3 months with symptom onset and at least 6 months prior to the diagnosis. And these things have to be ruled out. There should be no warning signs. Age should be, that is age more than 50 years, recent change in the bowel habits, evidence of overt GI bleeding, nocturnal pain or passage of stool, unintentional weight loss, family history of colorectal cancer, palpable abdominal mass or lymphadenopathy, evidence of iron deficiency anemia or blood testing, and positive test for fecal occult blood. All these things are present, then patient requires further evaluation. This is the Rome 5. Once you make a classification based on the IBS, then we have to classify on IBS subtypes. This chart has already been shown, Bristol stool chart. However, the type 1 and type 2, they classify for IBS-C, that is constipation. Type 6 and 7, they classify for IBS-D. And in between 3, 4, and 5, they classify for IBS mixed, that is, they alternate between hard lumpy stool, that is diarrhea and constipation. And it is when 25% of the is the threshold for the classification. Whenever the patient is in more than 75% of time, it is constipation, then it is classified for IBS-C. If 75% of the time it is for diarrhea, it is IBS-D or it is mixed. The location of the pain is basically, and the severity of pain increases as the stool, the hardness of the stool increases. The major contributor for it is gut-brain axis. The microbiota in the gut, they influences the mood and behavior, stress and anxiety, and neurotransmitter. And the brain, the signal goes to brain, and it influences the secretion, motility, delivery of nutrients, microbial balance, and immune functions via vagus nerve. And the involvement of the systems are enteric nervous system, CNS, gut wall, and HPA axis. This is the same thing which we are discussing. The pathophysiology is that the genetic factors and the environment with the effect of gastroenteritis, abuse history of drugs, or other precedent factors lead to abnormal central processing, psychological disturbance, GI motor disturbance, visceral hypersensitivity, immune dysfunction, serotonin, increased intestinal permeability, or altered microbiota with the triggers of food and stress coping leads to symptoms which may require consultation. This is the pathophysiology for visceral hypersensitivity in patients of IBS. And the gut microbiota also plays a major role, that if a patient having healthy bowel has gastroenteritis, up around 90% completely recover. However, 10% can lead to change in the motility, dysbiosis, and can lead to IBS symptoms. Pregnancy also can increase the effects of IBS via the use of, because of the luteal hormones, mast cell activation, sex hormones, sex steroids, relaxin, hyperprogesteronemia. This we are using the FODMAP is fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. These are the dietary sugars which they are malabsorbed in the intestine. They are fermented malabsorbed sugar, have an osmotic effect and lead to bloating sensation, abdominal discomfort, flatulence, diarrhea, and constipation. The psychological issues are also there, the stress, history of sexual or physical abuse, poor coping, adverse events. They can have changes in the central nervous processing and altered mentality, ultimately leading to dysbiosis and IBS. The triggers for IBS can be fatty foods, caffeine, spicy foods, stress and anxiety, alcohol, antibiotics and NSAIDs, and non-food triggers can be poor sleep, stress, menstrual cycle, dehydration, and little or too intense exercise. Fructose may also disrupt gut if we take the food containing high in FODMAP. The fructose is slowly absorbed and can pass into the colon. It ferments over there, causing bloating and diarrhea. The fructose-rich food can cause the symptoms more, such as mangoes, apples, pears, and watermelons. And avoid sugar-free drinks made with artificial sweeteners because they contain polyols and they can also be harmful. Vegetable juices can also bring troubles. Onion and garlic are considered to the major contributors of IBS. However, any vegetable juice which has the vegetables having high in FODMAP such as asparagus, legumes, peas, cauliflower, mushroom, they are to be avoided. Milk also can contribute to the intestinal distress. Cow milk is high in FODMAP due to lactose content, so it can also be contributed to IBS. So alternatives to it are almond milk, coconut milk, soy milk, hemp milk, and oat milk. Yogurt is the only really exception for the patients with IBS. Caffeine again can aggravate the symptoms and can cause diarrhea. However, moderation is the key. So you can take 1 or 2 cups, which can be beneficial effects also. The symptoms, they can be bloating, constipation, gases, nausea and vomiting, diarrhea and abdominal pain, and all these things can be due to bacterial overgrowth, impaired motility, bacterial fermentation, mast cell activation, and altered visceral innervation. If a patient comes to you, the clinical assessment is first to establish the cardinal symptoms of IBS, evaluate the presence of alarming symptoms and signs, inquire about the past medical history, review the patient medication because medication can also be helpful, and can also be contributory to IBS, ask for the family history, and conduct a physical examination and review the result of the previous investigations. If we see the IBS consultation pattern, the consultation with specialists is very less. However, you can see that 75% of the patients are non-consultants. They don't even consult the physicians, and of which 70% of IBS persons are female, and only 30% are male. Coming to the management, the diet and nutrition management is the basic therapy, then medical management using pharmacotherapy and behavioral management, and the integrated care is the best form of therapy for the patients. For dietary management, we can use low FODMAP diet, fiber intake, there can be recommendation of fiber intake, and probiotics. Low FODMAP diet, I have already discussed, the elimination of FODMAP can help the patients of IBS. They produce short chain fatty acids and gases. The high FODMAP contents can be in honey, apple, pear, peaches, mangoes, fruit juice, dried fruit. They can be in fructans, sorbitol, raffinose. All these things are important FODMAP which should be avoided while we are prescribing patients. Coming to the dietary fiber and IBS, if the fiber is less, then also it is harmful because it can lead to constipation and worsen the symptoms. And if fiber is high, then again it is harmful because it can lead to breakdown and fermentation and can cause increase in the symptoms. Probiotic, although it has no major roles, but there are benefits in helping the bowel movement, inflammation, causing bacteria, balancing the gut flora. All these are benefits, but they are not being found to have major role in this. First thing is stop eating junk because they are nutritionally deficient food and they are bad for IBS because they have high fat content, low fiber content, they have artificial sweeteners and food additives which can promote the symptoms of IBS. Stop unnecessary dietary restrictions because the triggers for IBS can be stress, hormonal change, or simply eating a large meal can be trigger. So just by avoiding everything, you cannot cope up with the life. So significant restriction of diet only for the food that one feels safe can lead to risk of nutritional deficiency. So every person should keep a food diary to follow an elimination diet. The risk of excessive restriction of low FODMAP diet can lead to complication because they are not intended for long term and they can be quite good also. Identify the problematic food map and avoid that initially, then periodically try to reintroduce if and see whether the tolerance have improved or not. The low FODMAP fruit can be blueberries, grapes, kiwis, lemons, limes, oranges, pineapples, and strawberries. Low FODMAP vegetable juices, which can be alternative, can be carrot, celery, cucumber, spinach, sweet potato, eggplant. Decaffeinated coffee or weak caffeinated tea can be an option. Herbal tea doesn't contain caffeine, so it is a great choice. Dairy-free milk can be used. In general, it is a rule that a smaller portion of anything doesn't cause symptoms, so a small portion can be taken. Stop avoiding fibers because too much or too soon situation can be harmful. So they are the friend of yours, so make fiber your friend. It is essential for overall digestive health. But the best way is to start and increase the fiber is to start slowly. Increase dietary fiber ingesting whole grains, fruits and vegetables, and avoid bran because it can be irritant. Lifestyle intervention in the form of exercise and sleep management, they are helpful for the patient of IBS, and low to moderate exercise may help to prevent IBS symptoms. And good sleep is preferred for the patients of IBS. These are some of the yogasanas which are found to be useful in the patients of IBS. They can be Adho Mukh Shwanasan, Ardha Matrendasana, Majrasan, cat pose, or Pavan Muktasan, Bhujangasan, and Dhanurasan. These are the asanas which are helpful said to be helpful in the patient of IBS. Coming to pharmacotherapy, the pathology can be either pain predominant, diarrhea predominant, or constipation predominant. So if the patient is having less of the dietary fiber and food intake and having constipation, then dietary and lifestyle modification will help best. If there is reduced bile acid, then ileal bile acid inhibitor, ileobixasat, can be used. If the methane production is the major reason for the constipation, then methanins are the bacteria producing methane are the culprit. Then rifaximin and probiotics can be used. If in the constipation predominant IBS, the osmotic agents and secretagogues such as osmotic laxatives, lubiprostone, lincolite can be used. Slow motility or low serotonin is the pathology. Then pro-motility serotonergic agents such as cisapride, motapride, tegaserod, or prucalopride can be used. And biofeedback evacuation disorders, fecal evacuation disorders can help with the biofeedback. However, if the diarrhea is the prominent symptom, the food fermentation products such as elimination of the FODMAP diet, the increased bile acid, then we can use cholestyramine or bile acid sequestrant. Gut microbiota, if the issue is because of the gut microbiota, then again the rifaximin probiotics can be used. If there is fast motility is the problem, then anti-motility drugs such as loperamide, diphenhexylate can be used. Anticholinergics including tricyclic antidepressant have a major role. If the high serotonin is the problem, then anti-serotonergics such as allosterone can be used. Inflammation of mast cell, mesalamine can be used. Then the novel therapies for IBS constipation predominant is lubiprostone, guanylate cyclase antagonist, that is linaclotide and pliclanetide, and tegaserod is the only USDA FDA approved 5-HT4 receptor which modulates gut motility and sensory functions. For diarrhea predominant, rifaximin is the non-absorbed antibiotic which can be used. Allosterone is 5-HT receptor antagonist which can be used. Iluxadoline is a peripherally acting mixed mu and kappa opioid receptor agonist which is approved for the treatment for the diarrhea predominant IBS, and tricyclic antidepressant, they are the major factors. Coming to other form of therapy, if the patient is not relieved with the lifestyle interventions and drug therapy, then psychological intervention in the form of cognitive behavioral therapy and gut-directed hypnotherapy can be helpful. Patient education plays a major role because it is a cornerstone of therapy. The knowledge about the stressors, development of awareness technique can be the key factor in the treatment. Many patients may manage symptoms with attention to the dietary triggers. So these type of charts can be given to the patient so that patient get educated themselves and can avoid the triggers so that get relief of IBS. Coming to the last part of the talk, towards the personalized dietary management for IBS patients, get a prospective dietary history, link dietary history to the symptom outcomes, detect dietary triggers, assess the habitual diet and exclude personal triggers, and assessment of the improvement or duration of the symptoms, and continuous follow-up is required. And this is toward the personalized dietary management of IBS. To summarize, while it is true that unpredictability of the IBS make it hard to plan activities and make a person apprehensive about leaving the house, it is important not to let the disorders over your entire life. Abdominal discomfort and pain, they reduce by participating in distracting and rewarding activity. It is always essential to keep in the mind that geography is not the IBS trigger, it is the anxiety which is the trigger. So you can go out, geography is not a IBS trigger. There are often anxiety about being out and about the worsening of symptoms which led the patient to be inside the house. Develop anxiety management skills as relaxation exercises. Many patients are being told that there is nothing that can be done, just live with it. However, if you read a IBS memoir or IBS success story, you will see that most of the patients with IBS, it takes multiple strategies to ease symptom. So hope is the only option. Thank you.
Whatever type of ideas, whatever we can decide something. You can have questions.
Sir, I already said that it is a never-ending story. So the minimum duration is the better duration. So I think that you can go ahead with the rifaximin for around a month or so, not more than that, and try to find out the triggers. The important management for IBS is basically the finding out the triggers, and lifestyle management is the basic answer for the patients of IBS. Pharmacotherapy, it has to be given for lifelong, so I don't think so pharmacotherapy is the better option for IBS patients. So most common trigger is basically food is said to be a trigger, but what I feel the major trigger is the stressful lifestyle. If a person has some disharmony at the workplace, he will have some symptoms of IBS, he will try to avoid that workplace. And the foods are there which help, which causes IBS symptoms. It is there, but the most important trigger what I have seen is the stressful lifestyle is the basic trigger in the patient of IBS.
So thank you, chairpersons. And with this, we end this session. May I request Anil Kumar Mani sir to kindly felicitate our esteemed chairpersons and speakers. And now we move on to the next, a very interesting session. that is when you are in clinic. And for this, we have chairpersons Dr. Lalit Mehar, Dr. K.C. Mohanta, and Dr. B.N. Mohanty. So request the chairpersons to kindly initiate the proceedings.
Really an interesting topic, mostly data oriented. And intelligence and skills and decision making. This is really required for every clinician who is practicing medicine, and also mostly to the undergraduate and postgraduate students. Just this one. Hello. But that is not okay. Good morning. Thanks to the organizers to give me this opportunity for speak in front of these August gatherings. Thank you, Chairperson sirs. This topic is clinical examination skill and decision making. We all know that in our day-to-day practice, these two things are very much dependent on one to the another. If we do not rely on our clinical examination skill, we cannot come to a good decision making. As Sir William Osler said, to study the phenomena of disease without books is to sail an uncharted sea, while to study books without patients is not to go to sea at all. In our day-to-day practice, it requires decisions in every steps. So mastering the technical aspects of medicine alone, unfortunately, does not ensure the mastery of the practice of medicine, because the medicine is a science of uncertainty and it's an art of probability. The three most important pillars on which the craft of modern medicine are expertise in clinical reasoning, rational diagnostic tests and its interpretation, and finally, the evidence-based medicine to take the clinical judgment in the care of individual patient settings. First of all, we have to understand what is a skill. Skill is an ability and capacity acquired through deliberate, systemic, and sustained effort to smoothly and adaptively carry out complex activities or job functions involving our ideas, that is cognitive skills, then our doings, that is a psychomotor skills or technical skills, and finally interpersonal relationships, that is a people with people. Next comes what are the types of skills we know. When we domain, our domain is a cognitive domain and the underlying component is the knowledge component, then it is called an intellectual skills. Suppose we explain a liver function test in a case of jaundice, then our intellectual skills acts. If we draw a blood by a venipuncture, then our psychomotor skills acts. So these are two important clinical skills. Then comes to the communication skills. When you talk with the patients, patient relatives, or a general population to involve them, to motivate them for a blood donation, then our communication skill acts. And finally, as doctors, we have to work as a team member in operating setup or in a project works, then there is a team skill or interpersonal skills are requiring. What is the importance of clinical skill? In medicine, each patient poses a great challenge, and we have to identify the clue hidden by elaborated history and by our physical examinations. It strengthens the physician and patient relationships. So good history and well-performed clinical examination helps get relief from burden of the battery of tests. What is the evidence of importance of clinical skill?
Medical history and physical examination guided to correct final diagnosis is nearly 60 to 70% of cases. And sometimes it has been shown laboratory investigations had a role in the diagnosis of only 10% cases. Even new diagnostic tests can lead to wrong results in 6 to 8% cases. In a prospective study from India, it has been documented nearly about 80% cases were diagnosed based on clinical history alone. Physical examination and investigations contributed to a diagnostic conclusion in only about 8% and 13% cases respectively. So what are the types of clinical skills? It is basic clinical skills. They are needed regardless of the discipline and setting, like a communication skills, examination skills, procedural skills. There may be a problem-based clinical skills. When you go for taking a problem, suppose a patient of having a fever, cough, in these situations, there is a problem-based clinical skills are requiring. It may be a discipline-specific clinical skill, like a gynecological skill for doing a delivery, a surgical skill for aseptic tactics. And finally, there is called continuum of care and skills, where an internist rotates to different clinical settings in inpatient, outpatient, emergency situations, and in the community. So this is a continuum of care and skills. What are the levels of clinical skills? As Dreyfus suggested that when we start our journey into our medical careers, we can come from a novice to advanced beginner to competent, then proficient, and finally expert. Suppose in a novice person who has no exposure previously, has a very less knowledge, they requires a complete supervision to do an endotracheal intubation. And gradually, on supervision, gradually they are doing every day, they becomes an advanced beginner to competent, and finally the proficient. And finally, this comes to a stage of expert when they innovates and trains others in the technique of endotracheal intubation. So how can we enrich our clinical skills? Either by the clinical skill laboratory, we can go for a simulation-based learning. Another important step that is called a Patton's 4-step approach, which are used in medical education system. We can be used by the problem-based learning systems, or we can go for a structured clinical observation to enrich our clinical skills. Let's come to this Patton's 4-step approach, which are mainly used as a teacher in our medical education systems, where the trainer demonstrates the skill in the real time without giving any instruction or explanatory words. That is called a demonstration. Second step, when trainer repeats the same procedures, telling each and every necessary sub-steps. This is called a deconstruction. Then the most important part, that is called a comprehension. When the trainer performs the duty as directed by the learner, so that the learner will guide the trainer, you have to do this way. So this is called the comprehension, and that is the most important step of this Patton's 4-step approach. And finally, the trainee performs the skill on his or her own. This is called the performance. Another method can be used, that is called see one, do one, or teach one. That is called a Sodoto method, where the learner observe and expert perform a procedure, then perform it themselves, and after practice, they train others to perform it. The problem is that here this is a very poorly structured, so assessment may be difficult, and it is performed on real patients, so there may have a chance of harm to the patients as the learner is not well equipped. So this can be overcome by a skill lab beforehand, so that the learner can go to the skill lab and then comes to the Sodoto methods. Let's some day-to-day practice what clinical examinations we are doing, because this is an enormous chapter. We can come to some examples that. Let's we go for a pallor, but in general survey. We all know where we have to examine that, but we have to understand what are the pitfalls are there. Suppose a patient is having the peripheral circulatory failure, myxedema, nephrotic syndrome. These patients have anemia. There is a pallor, but without anemia. When we examine for icterus, we all know which sites we have to examine for the icterus, but we have to understand that there are some causes of unilateral icterus may be present, particularly in case of the hemiplegia, in the presence of unilateral edema. The pitfalls, there is a carotenemia may be present in case of the hypothyroidism, diabetes mellitus. We have to understood what is subclinical jaundice, and also we have to understood the reverse subclinical jaundice. That means when there is patient's eyes are yellow, but biochemically the bilirubin level is in the normal range. So this clinical examination can come to our clinical decision makings. When we examine for in another genres of examination, there is a blue fingers, a cyanosis, which is a medical emergency. We have to understood whether what is the Raynaud's phenomena, and if it is a Raynaud's phenomena, whether it's a primary or secondary Raynaud's phenomenon, and what are the drugs we have to take, and this is very important. And we have to understood what is the differential cyanosis, and in differential cyanosis, if it is in the blue feet, then there is a PDA with reversal of shunt, and whether it is a blue hands, there is a coarctation of aorta with transposition of the great vessels. Another important domain, that is a face reading. We assess by face reading, some clinical examination skill can lead to our diagnosis in decision makings. Lots of phases, acromegaly, thyrotoxicosis, Bell's palsy, moon phases, mass phases, and so on and so forth. Let's take one example. This is a patient is having a moon phases, which is a bloated and rounded, commonly seen in Cushing syndrome, myxedema, prolonged corticosteroid therapy. But we have to keep in mind that sometimes superior mediastinal syndrome can be presented with a moon phases. So if we think about that, we have to examine whether the JVP is raised or not, which is non-pulsatile, and whether there is an absence hepatojugular or abdominojugular reflex. So this clinical examination skills leads to our decision makings. Then examination of the tongue is a very muscular organ, and this tongue, if we see for a pale tongue, we can suggest it is an anemia. If it is a white tongue, it's an oral thrust. When you get an oral thrust, we have to take the proper history whether this patient is suffering from any immunocompromised states or not. There are other tongues like a magenta red tongue in riboflavin deficiency, whether there is a black tongue, whether there is a strawberry tongue, and so on and so forth. In lymph node examinations, when we examine the lymph nodes, whether we have to understood whether there is a significant lymphadenopathy, whether it is a generalized lymphadenopathy is present or not, and particularly we have to assess whether there is an epitrochlear or Virchow's dots are palpable or not, which guides us to a little bit of specific decision makings. When we examine for the splenomegaly, we all know that which area we have to examine, what are the methods, what is mild, moderate, what is massive. We all know the causes of the massive splenomegaly, but the clinical clues we have to take care of when with pallor there is a malaria chronic calazar, with icterus, hemolysis, with hemorrhagic spots, there is an acute leukemia, with lymphadenopathy, autoimmune disorders. So these clinical clues guides us to a very difficult decision making. In purpuric spots also, these are 3 to 5 millimeter in diameters. If it is palpable or non-palpable, if it is a non-palpable, then we have to take care of whether the bleeding from mucous membranes or no skin, then there is a platelet disorders associated with bleeding into joints, muscles, hemophilia may be present, only palpable purpura is vasculitis. Leg ulcerations, it may be venous, it may be arterial insufficiency, it may be neurogenic. So the clue to the diagnosis is whether there is a venous ulcer in lower leg, around ankle, and it is surface temperature is normal, associated with pitygythema, it is suggestive of venous ulcers. If it is an arterial ulcer, it is a seen foot, surface temperature cold with reduced ADP or PTA pulse. If it is a neuropathic ulcer, we all know that it has to be documented in the heel, ball of the great toe, they are painless, and sometimes the ankle jerk is reduced. So these clues can lead to us to the decision making. So in clinical decision making, we have 3 integrated phases like a diagnosis, assessment of severity, and a management. So appropriate clinical decision making considers to need to make a precise diagnosis, and we have to assess what is the pre-test probability, and we have to do not use the indiscriminate use of the diagnostics tests. And also in the treatment decision, we have to take whether there is an adverse outcome are present or not. So what is the 4-step approach to clinical decision making? This is first we have to identify your probabilities. Suppose an example, a patient presents with a fever with productive cough and decreased appetite. Our initial hypothesis is that probably patient is suffering from pneumonia or respiratory tract infections. Then we further gather by evaluating, examining the patients, whether there is an bronchial breath sound is present or not, crepitations are present or not. Then with critical decision making, it's a case of pneumonia. Then update our probabilities based on the data we have gathered. We suggest the pretest, considering the pretest probability, we go for a chest X-ray. And where we see there is an AR bronchogram is present, so we suspect that this is a case of pneumonia. And if we get this thing, then we consider an intervention depending upon the investigations. In a case of pneumonia, if we get there is a parapneumonic effusion is present, then we have to go for a aspiration of the pleural fluid. So this 4-step approach we have to take care of. So what is clinical reasoning? Clinical reasoning may be intuitive or by analytical reasoning. Intuition systems, that is a very simplifying system, rules of thumbs, or it is called a heuristic system. For example, fever with chills equals malaria. But all of you know that every fever with chills do not suggest malaria, because there are lots of other causes like urinary tract infections, cholangitis, cholecystitis can be presented with fever and chills. So in these situations, we do not rely on these intuition systems. We have to rely on the analytic system. The other form of reasoning is the dual process model, is a slow, methodical, deliberate, and effortful. So if a patient fever with chills, having a pallor with splenomegaly in a tropical country, then we suspect the patient is probably suffering from malaria. So this reasoning, clinical examination skill leads to the good reasoning. So what are the types of heuristics we know? It is a little bit of clumsy side, yet for the sake of knowledge, we have to know what is the representativeness heuristic. First is that consider a patient with hypertension who has a headache, palpitation, and diaphoresis. So this triad leads us to a diagnosis of pheochromocytoma. But what is the prevalence of pheochromocytoma? Very less. Commonly, essential hypertension are much more prevalent, and most of the cases of essential hypertension can present it with headache, with palpitation, and sometimes diaphoresis. So that we have to understand that only the representative heuristics cannot lead to a good clinical decision making. So what is the availability heuristics? Suppose in our day-to-day practice, for a long practice sessions, we can understand someday we have seen a patient with sore throat eventually found to have a leukemia, or a young athlete with a leg pain subsequently found to have an osteosarcoma, or a young lady with non-specific abdominal discomfort in early morning found to have a snake bite. So this is called an availability heuristics. We have to keep in mind for our decision making. What is anchoring heuristics? This is called a stickiness. Suppose a clinician may still judge the probability of coronary arteritis is due to, in spite of there is a negative exercise perfusion test. He suggests you go for a cardiac catheterization. So it is an anchoring heuristics. But commonly we are doing the simplicity heuristics, which is that what are the symptoms, what are the signs, and which can be explained by which disease, and what there is no biologic basis for it. So what is the pitfalls of these systems? This intuition system, that is, it is a complex cognitive process, but it is not going, it is an undisciplined pattern. So it can result into a premature closure. So that some example is, there is a 55-year-old occasional alcoholic pain man presented to the emergency department with abdominal pain, which was localized to the epigastrium and exacerbated upon eating food. The emergency department clinician examined his vitals, absolutely normal. He discharged the patient, considering the patient suffering from gastritis with PI and sucralfate. After 6 hours, patient collapsed and brought to the emergency department, found to be a case of acute myocardial infarction. So this is the intuition system's pitfalls. So we have to rely on the analytic systems. So finally, actually we have to do the shared decision making. The best decisions are often made in partnership with the patients. Doctors have the knowledge of diagnostic techniques, diseases, prognosis, treatment options, preventive strategies. But patients have knowledge of their prior illnesses, the social circumstances, habits and behaviors, risk tolerance. So this process of sharing these two bodies of knowledge has several names called patient-centric care or informed decision making. So this is a model which is an information gathering, then comes clinical reasoning, then comes clinical judgment, but kept in mind the patient is in focus. So this is called a collaborative decisions. So finally, when we come to clinical decision makings, we have to think about the individual level, our personal experience, our perceptions, practicing site, what about our knowledge, awareness, then comes to the interpersonal relationship, physician-patient, physician-peers, physician-administration, and then comes to the accountability and evidence in which setups you are doing your jobs. What about the teaching experience, what is the cost, what is other things, and considering the organizational effects, environmental effects, socio-political effects, then finally comes to a clinical decision making. So in a nutshell, we can say that medicine is learned by the bedside and not in the classroom. Let not your conceptions of disease come from the words heard in the lecture room or read from the book. See and then reason and compare and control, but see first. So, August gatherings, the clinical examination skill is completely dependent on your decision makings, and decision making is also dependent on your clinical examination skills. Thank you very much for your patience hearing.
Finishing in very right time and for a wonderful lecture. Unless you have mastered this skill, then the field design is very difficult to make a diagnosis. And our field design to be master ourselves regarding how to make a diagnosis. So mastering in the history, being very meticulous in examining the patient and think of the important findings, coming to a differential diagnosis, and again ordering some important investigations, and lastly, when reasoning is important. So all these things you have to know. Thank you very much for any questions on this. Then we can go to the next topic. The next topic is clinical guidelines, racial and ethnic bias to be delivered by Dr. J.K. Sharma. Dr. J.K. Sharma, please.
वैसे कर दो, ऐसे कर दो, हाँ पूरे में सच.
Good afternoon, respected chairpersons. I extend my heartfelt thanks to Professor Anuj Maheshwari and even before that to Dr. Anil Virmani, Dr. Jayant Panda, Dr. Anil Virmani for allotting me this important topic. And in the next 20 minutes, I would like to take you away from the OPD settings in the hospital settings to the research, where the stalwarts are sitting and they make the clinical guidelines. I think clinical guidelines are very, very important, and the points which I am going to discuss are very important for the people who are part of the clinical decision making and clinical guidelines. But the people sitting over here, they also have an important role, but in the times to come, these are the people who are really going to help us into that. So I will introduce the topic, then we go to the studies and the statistics, showcasing the racial and ethnic disparities, the current clinical guidelines and what are the consequences of these in the clinical practice, and then
recommendations and the limitations. The word bias that refers to a negative or a positive idea a person has about someone or something, and bias is the evaluation of something or someone that can be positive or negative, and implicit or unconscious bias is when the person is unaware of their evaluation. Now, what are clinical practice guidelines? These are the recommendations on how to diagnose and treat a medical condition. They are mainly written for doctors, but also for nurses and other healthcare professionals. And these guidelines, they summarize the current medical knowledge, weigh the benefits and harm of diagnostic procedures and treatments, and give specific recommendations based on this information. And all clinicians sitting in the OPDs, taking their rounds, seeing patients, they are always reminded that please look about the clinical guidelines. And the teachers, these professors, they ask the students, what are the clinical guidelines for this particular thing? So they are very, very important. And but how they are developed? First, a guideline committee is formed, including the specialists, to cover all the important aspects of the medical condition in question. The committee is usually led by a member of the medical association responsible for the medical condition. And I'm happy that Governor ACP, Dr. Anuj, the past president of RSSDI, Dr. Vasant Kumar, and many stalwarts are sitting here. It collects as much information as possible from the different sources and assesses the information based on predetermined criteria, and the various assessments and opinions of the committee members are discussed and taken into consideration when writing the guidelines, and the committee members have to declare any conflict of interest. The importance of addressing racial and ethnic bias in healthcare algorithms is commitment to addressing the racism and the injustice. Algorithms are widespread use. They affect healthcare outcomes, new or emerging awareness of potential bias in the algorithms, and potentially high prevalence of bias in the algorithms. So, algorithms are useful for combining the complex information and multiple variables more quickly and consistently than individuals can, making them valuable or even essential in the healthcare. And the continued use of race and ethnicity within the algorithms may perpetuate stigma and discrimination against racial and ethnic minority groups. So this is very, very important. Now, the current clinical guidelines address biases pertaining to the following. There may be biases to the sex and gender, the race biases, socio-economic status, ethnicity, age of the person, geographic location, and the sexual identity of the individual. The bias starts with data and evidence on which guidelines are based. Right at the start, the new study reveals previously invisible health issue among Asians in the US. And you can see here that non-Hispanic whites, according to the study, but when researchers disaggregated the data, they uncovered a number of disparities. Among them that Vietnamese respondents report fair or poor, and Japanese and Koreans reported higher rate of diabetes than the non-Hispanic whites and Asian overall. There are very limited data available from our country, which I will also discuss. Now, diversity in clinical trial recruitment statistics. The minorities and people of color have been underrepresented in the medical field. The FTS found that African Americans represent 12% of the US population, but only 5% of clinical trials participants overall. And the Hispanic people make up 16% of the population, but only 1% of clinical trial participants. So we can very well see here that how much is the bias. In cancer treatment studies conducted between 2001 and 2010 that reported race or ethnicity, the reviewer found that 82.9% of the participants were white, and 6.2% were African Americans, 3.3% were Asians, 2.2% were Hispanic, and 0.1% were Native Americans. And you can see these guidelines,
they apply to each and everyone from the various race, various ethnicities. Now, racial or ethnic bias and attitudes, such as feeling that white people are nicer than black people, whether conscious or not, can lead to prejudicial behavior, such as healthcare providers taking more time with white patients than black patients and therefore learning more about the white patient's needs and concerns. Biased guidelines can seriously hurt the patients while putting doctors in a difficult situation, because if they choose not to follow guidelines they disagree with, they may suffer professional or legal repercussions. Some clinical guidelines take a patient's race or ethnicity into account when making decisions, which may cause physicians and decision makers to make decisions that differ based on the race and perhaps have an impact on the disparities. So we come into a soup. Now there are various studies or statistics showcasing racial and ethnic disparities and its influence. See that the epidemiological studies. High rate of cardiac arrest in the blacks and individuals from socio-economically disadvantaged backgrounds. Global disparities in acute myocardial infarction treatment exist, with minorities less likely than white or get proper care in the various countries. And in a recent UK study found that during the COVID-19 pandemic, minority patients with ACS faced more treatment delays and higher mortality rate than the white persons. In the UK and South Asian patients with coronary artery disease, issues are less likely than white patients to receive proper test, treatment and medications. Now, in this particular paper, clinical guidelines which use race cause treatment biases. These guidelines which often say black patient must be more sick than non-black patient to get the same level of medical testing or care worsens the healthcare outcome. These guidelines are meso-level sites of race, racism, purification processes, which means that they are a part of the healthcare system where racial stereotypes and biases become more set in stone. Researchers should revise guidelines for more equitable healthcare. So this is a lesson for the researchers and the people who are going to make the diagnosis, the clinical guidelines. In 2020, American Academy of Pediatrics for urinary tract infection testing in JAMA Pediatrics was criticized for using a guideline suggesting racial differences in testing for UTI in children. UTIs occur when bacteria enter the urethra, and there is no physiological difference in the urethra among various races. The flawed guideline required black children to show more severe symptoms than white children to qualify for the UTI testing, and you can see the results into that. When we come to cardiology, again the American Heart Association risk score system that has resulted in unequal care of black and Latinx patients. Use of race adds 3 points to the risk score if the patient is identified as non-black. This addition increases the estimated probability of death. Higher score predict higher mortality. The Society of Thoracic Surgeons has calculators that use race to estimate the risk associated with cardiac surgeries. The reasons for these differences are not clear, and the use of race, the risk score for operative mortality and major complications increases in some cases by 20% if a patient is identified as black. Again, in nephrology, so this is in all systems, nephrology, kidney function and racial biases. Equations suggest better kidney function for black individuals, but there is skepticism. Using race might delay care for black patients who already face several kidney issues. Estimated eGFR, MDRD and CKD EPI equations again estimate GFR rate on the basis of a measurement of serum creatinine, which is biased. Use of race, the MDRD modification of diet and renal disease. Equation reports a higher eGFR, estimated GFR by a factor of 1.2 if the patient is identified as black. This adjustment is similar in magnitude to the correction for sex also. So in our country also we need a good workup for these guidelines based on the race and the ethnicity. Again, kidney transplantation in KDI approach reconsidered. Proposals exist to replace KDI's racial categorization with specific genetic markers like the
APOL1 for fairness. The use of RAS increases the predicted risk of kidney graft failure if the potential donor is identified as African American. A risk adjustment intermediate between those for hypertension and diabetes and that for elevated creatinine values. Then the urology stone score predicts the risk of urethral stone in a patient who presented with frank pain, and use of RAS produces a score on a 13-point scale with a higher score indicating a high risk of urethral stone. 3 points are added for non-black RAS. This adjustment is the same magnitude as for hematuria. So by systematically reporting lower risk for black patients than for all non-black patients, this calculator may steer clinicians away from the aggressive evaluation of the black patients. Endocrinology again, osteoporosis risk score, simple calculated osteoporosis risk estimation, and determines whether a woman is at low, moderate or high risk for low bone density in order to guide decisions about screening with the DEXA scan. And by systematically lowering the estimated risk of osteoporosis in black patients, again, score may discourage clinicians from pursuing further evaluation in these cases. Similarly, pulmonary function test use spirometry to measure lung volume and the rate of flow through airway in order to diagnose and monitor pulmonary diseases. And in the US, spirometers use correction factor for persons labeled as black. Inaccurate estimates of lung function may result in the misclassification of disease severity and impairment for racial or the ethnic minorities. So, what are the consequences of this racial ethnic biases in the clinical practice? Provider bias and discrimination, racial disparities in health are thought to be caused by institutional and provider bias and discrimination, which can lead to racial discrepancies in diagnosis, prognosis, treatment choices. And this data is supported by a large and well-established body of the research. And in accordance with this research, people claim that they were treated unfairly when seeking medical care due to their race or ethnicity, and it is a matter of legal problems. Disease stereotyping and nomenclature again. Racial stereotypes are used to illustrate diseases in some medical training methods and materials, and racial heuristics. Race-based pharmacological prescribing guidelines again. Although race is sometimes taken into consideration when prescribing medications, this decision making is frequently based on scant evidence from small studies and may lead to ineffective dose and therapy. We see that in the guidelines, when a drug comes, it is always written, we do not know about the pregnancy, we do not know about the children below the age of 18 years, what this drug will cause. The reason is that the elderly people, the females, pregnant females and the children, they are never taken into consideration when researches and the guidelines are prepared for various drug and the treatments. Then use of race in clinical algorithm tools and guidelines. Clinical calculators using race only lead to health disparities, and other tools may unduly influence medical decisions based on the race. Some clinical tools show varied accuracy based on skin color, like pulse oximeter, missing low oxygen levels more often in black patients, potentially leading to detrimental health outcomes. As healthcare increasingly adopts artificial intelligence, potential racial biases in algorithms can affect patient care with skewed data, potentially leading to inaccurate predictions and disparities in the treatment. Now, what are the recommendations to reduce the impact of racial and ethnic biases? It is recommended that cardiologists make efforts to mitigate their individual biases. Tools like computer-based implicit association test can measure these biases, and implementing regular bias mitigation workshops where clinical cases are discussed with a focus on potential bias triggers can be effective. Limited evidence is available, so more data is required for this. Now, the use of artificial intelligence to reduce the impact of racism. Artificial intelligence can potentially reduce a racial bias in cardiology if implemented correctly. Not only cardiology, even in radiology, that is also very, very important. And while AI shows Only in standardizing care and reducing disparities, it is not a complete solution to racism in medicine. The data input and clinician oversight must be bias-free. So the reducing the impact, the lack of racial diversity in cardiology stems from educational biases, inadequate resources, and high cost, affecting minority students from early education through medical schools. Diverse physicians serve underserved communities better, have fewer biases, and can improve patient compliances. Witnessing racism requires moral responsibility to act and advocate. Solutions include outreach to young minority students, mentorships, unbiased selection processes and policies, prioritizing cultural competence and service to disadvantaged communities. Now, call to action. The American Heart Association strategies to address structural racism is by advocacy, quality improvement program, by leadership, human resource, business operations, and the science, and not only the American Heart Association, even the American College of Physicians, and especially our India chapter can also look after this call to action. There are certain limitations. Research on racial bias affecting cardiometabolic and cardiovascular health has limitations. It can be both direct and indirect and varies in process. The need for a medicine-specific bias test and its validity across races is uncertain, and research mainly focuses on black population, overlooking other racial and health-related biases, and disparities exist in studies linking implicit bias to health outcomes. And Dr. Martin Luther King Jr. long back he said, of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. So dear friends, and all seniors, all stalwarts in the various disciplines of medical fraternity, please look after these biases, these races, the rest in clinically and in formulating the clinical guidelines. Do not forget about the children, do not forget about the women, and especially the elder population. With that, I thank you all. Thank you very much.
Well, thank you, Dr. Sarma. Before time, I was giving a very excellent lecture. You have rightly pointed out that this ethnic racial discriminatory and this needs to be addressed. And you have suggested, so any questions from the floor?
Fantastic on an unusual topic.
Thank you, sir.
Let us forget African Americans. Suppose if we want to have people from Punjab and then from West Bengal or from Assam or from Maharashtra and South India for any study, what are the measures we should take?
So the very important is that, as I have told you right in the beginning, that we don't consider that this patient is from US or America or UK or South Africa, anywhere. We take the example of our own country. In that case, we should decide what is the geographical situation where the patient is situated. What are the environmental factors? How are the food habits? What is the socioeconomic status of the patient? What is the gender? And what is which particular disease is preponderant because of the epidemiological things. So the committee making the clinical diagnosis should take into consideration all these. It should not be that we take a sample data should not be taken, because that is again a bias. Complete data, if we really want to give some clinical guidelines for our own country, we must consider each and every group, all age-wise, gender-wise, socioeconomic status of the person, even the education part also, and then a holistic clinical guidelines should be brought out. I think the guidelines from the Indian Society of Hypertension have recently been published, and I think Dr. Narsingh Verma and the other people must have done justice in the races, and there should not be any bias. That will come to know in the times to come. Thank you, sir. Thank you, sir.
Thank you, Governor, ACP Professor Anuj Maheshwari, Dr. Anil Virmani, sir, for giving me a very interesting topic, and the scope was very wide. So it kept me waking for many nights. And what I tried to bring in was how we can avoid these diagnostic errors. So I tried to focus more on that because more and more we are encountering these. So I'll be touching on the diagnostic errors, and at the same time, I will be focusing on the ways how we can avoid these diagnostic errors. Yes. Yeah. So, what are the common diagnostic errors in medicine? So, this is my topic of the talk. And from time immemorial, we have been trying to look for subtle, and we are missing the gross. So, this is what has been our approach, and we humans, we are trained like that we are looking for subtle and we are missing the gross. So, this is what it is like. So, the patterns associated with initial presentation might be misidentified. And I think my predecessor, Dr. Krishnendu, has already delved on this. So a rash of herpes zoster and a rash of poison oak. So they can look similar, ureteral colic, but in fact may be a dissecting aneurysm, acute pericarditis or myocardial infarction. So similar looking, similar presentations could be with varying diseases. So we have to look for the clinching signs, and we have to order the right diagnostic tests for getting these presentations. So coming to the magnitude of the problem, so we have a systematic review, and it identified the diagnostic difficulties and errors in primary care among people, because more and more we are concerned with the primary care. Because if you are going to a specialized center, we have got the armamentarium to look for that. So the most common problems were associated with the diagnosis of cancer, heart attack, meningitis, dementia, iron deficiency anemia, asthma, tremors in the elderly, and human immunodeficiency virus. Then another study of 190 cases of diagnostic errors found that errors were common in patients with pneumonia, decompensated congestive heart failure, acute renal failure, cancer, and urinary tract infections. And I would understand that the learned audience will understand that in a primary care setting, they are difficult to identify. And another study identified errors most commonly involving infections, trauma, and malignant neoplasms. So then WHO identifies what could be the problem areas, and they have identified these 4 things which could be missed at the level of primary care. The first could be a missed cancer diagnosis. That is very obvious because they don't have the armamentarium to look for it. Infections, they are also missed or misjudged. And then we have, as regards to cardiovascular disease, and pediatric issues are also very common misdiagnosed conditions. So a small overview of these. So cancer, the burden of cancer is significantly in countries across the world, and delayed cancer diagnosis is both harmful and costly. You all will concur. And the cancer diagnosis is challenging, especially because many cancers can present as non-specific symptoms in primary care providers. So infections are another cause, and I think that is the biggest brunt with our societies. So there could be diagnostic errors, and most commonly viral infections are often misdiagnosed as bacterial infections, and we all are prescribing antibiotics off and on for simple viral infections. Diagnosis of malaria can be particularly troublesome because key features such as fever are not specific. People are not looking for the clinical signs and symptoms, so that could be a problem. Almost 10% of the cases of tuberculosis may be misdiagnosed due to misinterpretation of test results and failure to use basic diagnostic tools such as microbiology or imaging. So these are all from relevant studies as regard to the misdiagnosis. And globally, the diagnosis of children with pneumonia, dehydration from diarrhea and malaria are often suboptimal. Then as regards to cardiovascular disease, errors may occur when subtle premonitory symptoms are missed or disregarded in primary care. Identifying people for whom primary or secondary prevention is needed requires appropriate diagnosis and management of risk factors or predisposing conditions, such as diabetes. We all know that it is symptomless in around 50% of the patients. So that could be a problem. Hypertension and high cholesterol levels. Then this particular area is of great concern because in primary practice, pediatric diagnostic errors are very, very common, and they contribute to nearly 7 million children who die each year, mainly from preventable causes. Information from misdiagnosis in children is limited. We don't have a lot of studies to understand that, and the common conditions resulting in claims in children are meningitis, gastroenteritis, pneumonia, appendicitis, sepsis, and malignancy. So these are the problem areas. And now I would be walking you through one or two cases, and these data are obtained from CRICO. So CRICO is basically it's an insurance party, and they have tried to collect the number of cases, and these collections are from the Harvard Medical Institutions. So this is an illustrative case. So the lack of appreciation for significant elements of the patient's history and physical examination led to missed pulmonary embolism. So there is a 33-year-old obese patient with remote history of asthma and on oral contraceptives presented to her primary care clinician with a 3-day complaint of right thigh pain, swelling, and red streaking on her skin. On examination, her right inguinal nodes were enlarged and antibiotics were prescribed. 3 days later, she returned with a complaint of new onset shortness of breath, chest pain, and rapid heart rate. The patient had diminished breath sounds. Her physician thought she was having an asthma flare and advised her to continue antibiotics and asthma medications. Later the same day, emergency personnel were called to the patient's home. After she fell, she was brought to a local emergency department where she quickly decompensated and died. And the autopsy revealed a large pulmonary thromboembolism. So we tried, as the sir was saying, that we have an anchoring bias, that whatever we think, that is what we think, and we want to continue with the diagnosis. So thinking and ruminating on what we are thinking, that is very important, and it should not be missed. Another example, a missed X-ray of patient with pneumonia led to respiratory failure and death. So a 55-year-old male was diagnosed by his primary care clinician with sinusitis and prescribed an antibiotic. 6 days later, he was evaluated in an urgency care clinic for shortness of breath, labored breathing, extreme fatigue, and chest pain with cough. The patient had temperature, a fast heart rate, and low oxygen saturation. After he was treated with an aerosolized nebulizer, his oxygen saturation improved. Based on a negative interpretation of chest X-ray, the urgent care clinician diagnosed a viral upper respiratory infection and instructed the patient to see his family doctor the next day. 2 days later, the X-ray was read by a radiologist with impression of pneumonia. The clinic called the patient and instructed him to go to his local emergency department for evaluation and treatment. Before he could get to the emergency department, the patient died of respiratory failure associated with pneumonia. So all these cases of misdiagnosis, diagnostic errors, in US they are maintaining a database of that, and this is from the Harvard institutions where they are doing a lot of work on this. So now coming to the magnitude of the problem, what we are still seeing is the tip of the iceberg, and we have large number of diagnostic errors which go unreported because we are not proactive to bring them on the fore. That may be because our own biases or the shamming that is involved in reporting these diagnostic errors. So 1 in 20 adults experience diagnostic errors in outpatient settings each year. So that's a huge magnitude. 40,000 to 80,000 patients die annually from diagnostic errors. And a diagnostic error is any mistake or failure in the diagnostic process leading to a misdiagnosis, or a delayed diagnosis. A diagnostic error can occur at any stage in the diagnostic process with the spectrum of patient consequences related, ranging from no harm to severe harm. So what we intend to do is to proactively stop the harm spectrum of this particular thing. So this is the complex process which starts from the patient experiences a health problem, patient engages with the healthcare system, then we have an information integration and interpretation, then with the juggernaut of clinical history and interview, physical examinations, referral consultations and diagnostics testing, we reach to a diagnosis and that is communicated to the patient, then treatment and outcomes. So if you see all across from the first stage, second stage and third stage, we can have these diagnostic errors: failure of engagement, failure in information gathering, failure in information integration, failure in information interpretation, and then failure to establish an explanation for the health problem, failure to communicate the explanation. So all these things are involved in diagnostic errors. So what could be the common diagnostic errors? It could be a delayed diagnosis, failure to diagnose an unrelated disease, failure to diagnose a related disease, misdiagnosis, failure to recognize complications, and misdiagnosis. And my dear friends, you all would be concurring with me that nowadays we are having a plethora and a very big whole body examination reports that the patients are coming, and we have a problem of over-diagnosis. And we have to have, and then there is a cascade of investigations to prove what is being marked with a black line in the patients. So that things are to be understood. So what could be the factors which could be contributing to a diagnostic error? It could be the cognitive biases, which is basically the SCP's problem. Then we can have systematic errors, inadequate access to patient records, fragmented care and time pressures, and then communication issues. So we don't have very good emotional intelligence, and we do not have one-to-one listening with our patients. Miscommunication or incomplete information sharing can lead to misunderstanding and diagnostic errors. So coming to cognitive errors, she looks apparently an old woman, but actually she is a young girl wearing a beautiful headdress. So intuitive approach similar to gut feelings. As Dr. Mohanty was saying, that we have a gut feeling. Over a period of practicing for very long times, we start having a gut feeling. This thinking is characterized by mental shortcuts and tend to be reflexive and automatic. So we always create shortcuts, and we try to stick to those shortcuts because we are pressed for time and we do not have the access to a big clinical testing juggernauts. So this is the anchoring bias. Anchoring bias, the tendency for clinicians to stick with the initial impression even as new information becomes available. Then we can have a confirmation bias. The confirmation bias is the tendency to selectively seek information that supports initial impressions. Then the status quo bias is the tendency to stick with initial impressions as the number of new possible alternate diagnosis increases. In a control study, clinicians were 19% more likely to stick with an initial management plan if confronted by 3 options instead of 2. Then premature closure is the failure to consider alternative diagnosis after the initial impression is formed. So just thinking what else it could be, that question will give you the alternate diagnosis and make you reach to a proper diagnosis. Then the framing effect. Framing effect is a tendency to be affected by how information is framed or presented. So we have this bias that some particular clinician has already formed a diagnosis and we keep on sticking to that. So for example, in a randomized controlled trial, physicians were 10% more likely to list coronary artery disease as their initial impression for a chest pain scenario if the scenario was framed by the statement that another doctor thought that the patient might have coronary artery disease. So we are guided or misguided by what our predecessors have already predicted. So now coming to the most interesting part, what interventions we should do to prevent the diagnostic errors. So first and foremost is using trigger tools. So we should be forthcoming. It could be from our own board, which is looking the efficiency of what we are doing, or it could be the trigger which was started by the physicians. If you are making a wrong diagnosis and then they're going to refer to, so communication is very important. Encourage and facilitate voluntary or prompted reports from patients. So this is very important because that could give us some insights what could be done to prevent that? Encourage and facilitate error reporting from physicians. So our colleagues can also help us a lot. So in US, they have got groups where they are discussing that this what particular thing was initially diagnosed as this, and after further investigations or a second review, the diagnosis was very different. So these are the, this is a busy slide, but we can have, these are the potential interventions to reduce the burden, improving diagnostic reasoning, encouraging government policies that support primary care, providing systematic feedback to clinicians about their diagnosis, optimizing diagnostic strategies in primary care, and involving patients. And then improving access to diagnostic tests, developing methods to identify and learn from diagnostic errors, and improving information technology. So these two, improving information technology and developing methods to identify and learn from diagnostic errors, are very important. Design triggers to identify patient records that may contain diagnostic errors. Assist clinical champions to encourage physicians reporting and learning from errors. Identify and fix process breakdowns in follow-up. Use non-punitive and non-defensive discussions to find and analyze cases of diagnostic error. The most important thing is that we have to understand that we are not going to punish or shame anyone for doing this, because anyone or everyone can commit mistakes. So a good and frank discussion would lead to better outcomes. So this is the inverted pyramid model of diagnostic proficiency. So initially a beginner is going for deductive reasoning. Then we have got a knowledge-based skill set, use of heuristics that are the shortcuts that we always formulate for diagnosing something. So we are moving from that, and now we are going to primary system and cognitive strategy. So over a period of time, we are going from a beginner, intermediate, and expert levels. So it needs a lot of continuing medical education, review of what we are going to, what we are learning from our own mistakes. So that is very important. Then these are the recommendations from the National Academy of Medicine Committee. Facilitate more effective teamwork, approaches to identify, learn, and reduce diagnostic errors. Establish a work system and culture that support the diagnostic processes. Design a consultative service for widespread use. We have got now lots of records, and the AI and the machine learning could help us in this thing. Enhance healthcare professional education and training in the diagnostic processes. System-based approaches build a no-blame culture. So that is very important, because we are not forthcoming to accept our mistakes or the mistakes of our colleagues. So we should be blunt, because that could save someone else's life. Report diagnostic errors to prevent future errors. Learning from mistakes prevents future harm. So what could be the system-related approaches? Existing practice, obtain history, obtain complete history of your own. So in these things, we can be held by our paramedics. So they can assist us in that. Perform physical examination, perform comprehensive physical examination, make an action plan, generate a comprehensive list of diagnostic possibilities. Not one diagnosis, go for a differential diagnosis. Act on plan, take time to pause and reflect, stick to the plan, embark on the plan, and ensure feedback and follow-up. That follow-up can come from our colleague, from our patients. These are the steps for improving reliability of diagnosis, and the health information technology, the HIT approaches can help us in expanding the areas. Then the checklist is consider for possibilities before accepting the first diagnosis, to look if the patient came in with the right diagnosis, proper reviewing the patient data, consistency of diagnosis with the data, appropriate history taking and review of reports to manage time for individual patients. Then these are the most important. These are the provider-based approaches. So think aloud. Just think what could be the probable other differential diagnosis for this problem. Then commit and confirm. Commit to a diagnosis and think about what data supports or refutes that diagnosis. Then check in. Every time you encounter the patient, next appointment or the next time you're around, continuously reassess the diagnosis made and the response to therapy. Is it still appropriate? So keep on ruminating. Just keep on thinking what it could be, why, where we are failing, or what. So this self-analysis is very important, and we have a term for this. This is called metacognition, that is observing one's own thinking. So we ought to think how we are thinking as a second person. Do we think in the right direction, or we need to have corrections? So what is metacognition? It is a developing helpful thinking strategies using reflective thinking before, during, and after A task help you plan effectively, having high self-awareness. That is very important. You have to understand critically analyzing how you think. So we have to think how we are thinking about it. So that is in a second person. Always ask yourself the question, what else might be this? So that is the gist of everything that I've been talking in last 10, 12 minutes. So there is a true goof up. This is a cartoon and the patient says, the doctor says to the patient, it seems we had a mix up with your test results. The patient responds, then I am not going to die. The doctor says, we doctors are amazingly smart, but occasionally we make little errors. The patient says, well, I understand. And the doctor says, by the way, your pap smear was normal. So we can have these problems when we are not looking to our patients, we are looking for the diagnosis. So thank you very much for the patient hearing.
Multidisciplinary approach discussion with a multidisciplinary problem, having expert from other disciplines, also not having doctor artificial intelligence or information technology, which has come up recently. So, any other opinion or any suggestions or questions from the If not, then we stop this paper over here and we move on to the next.
Thank you. Moving to other one and looking to a clinically very important session. Usually great debate and discussion going on this kind of when we are getting some nodule on this X-ray, what is this and how to correlate with that clinically. So theme is climate crisis and pulmonary nodules. And for this, I would like our esteemed chairperson, Dr. Vijay Mishra sir, Dr. Manoranjan Das and Dr. K.B. Parida. Please welcome as chairperson. Join here. And I know our esteemed speaker, Dr. Chawla, is here and he is a very great orator. So this topic is going to be great. So I think no other chairperson is here. Dr. Vijay Mishra, Dr. Manoranjan Das and Dr. K.B. Parida. One is here, yeah. Yeah, please, okay, you start the session, they will join again. Yeah, you start it.
Should I start? Good afternoon, friends. First of all, I would like to thank organizing committee, Dr. Virmani and Professor Anuj Maheshwari, Jayant Panda sir, to giving me this opportunity and including such a topics with a vast kind of which are of the future needs, and we have to think about it. You have seen in due course of time there were many new topics which were added first times, and I have never heard before in any conferences. So this topic was new for me, and definitely it is the need of time. We have to be alert to deal with this climate crisis so that how we can improve the patient's health in this era. So climate change is definitely decreasing the quality of air we breathe, food we eat, and water we depends upon. It is impacted different way to our health. It has butterfly effect, meaning thereby the rising temperature of the environment leading to expanded lifespan of ticks and mosquitoes. This further leads to higher incidence of vector-borne disease like malaria, dengue, and Lyme disease. COVID-19 itself has butterfly effects, meaning thereby it has affected mental health of many people despite they were not having any infections with the COVID-19, but because of the social isolations, lockdowns, and economic impact, they were affected very well with this COVID-19 crisis as well. So there are three things: climate crisis, COVID-19 crisis, and equity crisis. Climate changes and COVID-19 are not the equal opportunity killers. Black Americans are nearly twice prone for the COVID-19 as far as the death is concerned as compared to the white, and the black Americans breathe more polluted air as compared to the whites. Intergovernmental panel on climate change in March 2023, which was formed by UN as well as World Meteorological Organizations, say climate change is a threat to human well-being and planetary health. There is rapidly losing window to secure a livable and sustainable future for all. By the year 2050, more than 250,000 deaths per year attributable for the climate change. And these, most of them, half of them are from the African countries. Air pollution. Recently, a Chicago study estimated reduced span of nearly 12 years due to the air pollution of the elites. The study was published by Professor G.C. Khilani he was former head from AIMS, Delhi. The air pollution is now the biggest killer, and it is claiming more than 5 million premature deaths each year from the heart disease, respiratory disease, diabetes, hypertension. It is more than the AIDS, tuberculosis, and malaria combined. If we look into the causes of climatic crisis, the increase of greenhouse gases like carbon dioxide, methanes, chlorofluorocarbons, nitrous oxide, and ozones are the important contributor to increasing in the greenhouse gases, and deforestations and the excessive use of fossil fuels and increasing agriculture activities and the change of land use patterns as important contributions. Vehicular emissions is important contributory factors for the air pollutions and in turn climate crisis. If we see climate changes in India, India emits roughly 3 gigatons of carbon dioxide, which is about 2.5 tons per person, and it is significantly less as compared to the other world countries. The carbon dioxide emissions is 1/4 of as compared to the China and the half of as compared to the US. You can see this China contribute 28%, and Russia this USA come 15%, and followed by India 7%. Climate can affect in various ways. Like I already told, air pollution is a major contributory factors, and the poor air quality can cause respiratory, cardiovascular disease, premature deaths, and there are various developmental problems. Extreme waves and extreme weather heats can lead to heat stroke, heat exhaustion, and respiratory problems, as well as many injuries followed by floods, or there may be storms, cyclones can cause many injuries. And rising earth temperatures increases the vector-borne disease. Climate change can affect heat-related illnesses, mental health issues like anxiety, depression, sleeplessness, and injury from natural disasters, food and water insecurities. Whenever there is a natural disasters, there are lack of water available. One cannot have the drinking water which is available, and the natural disasters like hurricanes, storms, and floods can very well impair all these things. Then who have the responsibility, and who will help us to deal with this climate crisis so that we can improve the health of the person as such? The government agency can play important role, public and communities can play, and the healthcare sectors can play. National Action Plan for the Climate Changes was formed in 2008, and it includes various things to mitigate the pollution burden or the climate crisis burden. It includes national solar missions, national water mission, national mission for sustainable habitats, and so on and so forth. Indian government has efforts to reduce the emissions, and recently climate change performance index was released, and India stand in the position 8 and 2 position up from the last release of this climate change index performance, and India stand 8th and United Kingdom at 11th position, followed by Germany 16th. Among the G20 countries, India is on the top rank in reducing the emissions for the last decades. To achieve this climate resilient and environmentally sustainable healthcare facilities, WHO issues some guidelines, and goals are to increase the climate resilient healthcare, to protect and improve the health of their communities, optimizing the use of the resources, and minimizing the release of the waste, and becoming environmentally sustainable. To achieve these goals, there are certain objectives which have to be formulated, so that we have to guide the professionals working in healthcare settings to understand and effectively prepare the additional health risks posed by the climate changes. We have to monitor, anticipate, manage, and adapt health risks associated with climate changes. We have to guide the healthcare facilities officials to work with the other environmental agencies, like for the water, sanitation, transportation, food, and urban planning and environments. Promote actions to ensure that this then can be achieved. We can have a certain strategy to mitigate these things. We can evaluate and monitor, identify the hotspots of healthcare facilities, and much more carbon footprinting, life cycle assessment, and benchmarkings. And energy efficient procurement is important, low carbon transportation is important, waste reduction and recycling. We can use in our day-to-day practice, we can shift to renewable energy, sources like solar, winds, geothermal energy can be used, and it can very well reduce greenhouse emissions of the gases. Green infrastructure. With the healthcare facilities, we can use green roofs, rooftop gardens, living walls can help to prevent the loss of water from the storms, and it can improve the air quality and hence improve the health of the persons and society as a whole. There must be community resilience, ensuring that healthcare facilities have backup power for the safe drinking water, contingency plans in which they make the difference of disaster situations. Healthcare facilities like telemedicines can help us in reducing the transportations, and like we have seen in the time of COVID-19, telemedicine played a very important role. Earlier, although telemedicine was not legally allowed, but now after the era of the climate crisis of the COVID, we can have it, and we are using it nowadays very well for, and it will reducing the transportation of patients from faraway places, and thereby reducing the emission of gases. Active transportation like cycling can be used, and it can reduce emissions and promote the physical activities. The important thing is we can have sustainable food supplies. Recently, once I visited UK, I found they used to allot some houses plot to the society's members, and they can have the kitchen garden there, and it will help in reducing the waste, decreasing emission from transportation, promote healthy eatings. And we faces certain challenge like initial investment, organization cultures, and the budgetary constraint is also there. So these are the important hindrances which can prevent us to develop environmentally sustainable healthcare facilities, but we have to take all the challenges so that we can overcome it. There are various agencies which can provide certification for greenhouse office certification can be achieved by the medical professional for their clinics, and it will help in climate and health alliances, and Doctors for Environment is a group which is making the ideas, and they are playing the roles in reduction of emissions by health friendly and sustainable, like use of solar energy in the clinics. The important thing is we have to educate our patients, make them understand environment. If environment is good, you will definitely have a good health. Otherwise, you are not going to have a good health despite of all medications. We have to advocate the policies and lead by the examples. We can form clinics with a solar panel, use of reusable energies. That is very important. This has been proven by various studies. In Canada, there was Kaiser-Babmanit study in America and the Green Ormond Street Hospital, London. What they have did, they have started using LED, they have started using green walls, they have started using, whenever they are constructing, they are, environmentally sustainable green kinds of buildings are constructed so that they reduces the carbon emissions by 8.4% in many years. So benefits of incorporating climate changes, we can improve the patient health, cost saving is there, and improved quality of lives. These things can be very well be used in our clinical practice. So to conclude, as a medical professions, we have a responsibility to address the health impact of climate change. We can educate our patients and advocating the policy for the change, adopting the sustainable practices in our own offices. Climate change is an impacting population health and our future patients. Remaining silent is not an option. We can make a difference and improve the patient's health. So thank you very much. The climate is changing. Why are not we? We have to make our clinics by reducing the emissions, carbon emissions, so that the health of our patients as well as healthcare professionals can be in a better way. Thank you. Thank you very much.
Yeah. Very good afternoon to everyone. So, thanks, Chairperson. At the outset, I would like to thank the organizers for having given me this opportunity. So, my topic is basically a very common entity that we come across in our day-to-day practice. And the difficulty or the problem with it lies the fact that we have to differentiate between the benign, whether it's a benign lesion, whether it's a malignant lesion, what's the diagnosis, and until we diagnose that, treatment won't be possible. Solitary pulmonary nodules are considered as a lung opacity of less than 3 centimeter, more than 3 centimeter, it's called a mass. It's discrete and does not attach to the lung border or pleura, and usually it is surrounded by pulmonary parenchyma. No lymphadenopathy is associated, and most of the solitary pulmonary nodule or the incidental pulmonary nodule are benign. And those few that are actually malignant, those only possess the challenge. So nodules can be classified as solid or subsolid. Subsolid nodules are divided into pure ground glass, that is no solid component in that, and part solid nodule, that is both solid and ground glass components are present. Lesions that measure more than 30 mm are considered masses rather than nodules, and they are more likely to be malignant. So here you can see that on the left-hand side, the chest CT shows a nodule of homogeneously solid density in the right middle lobe, measuring less than 30 mm, that's a solid nodule. On the right hand side, you can see the arrow pointing to a pure ground glass pulmonary nodule. And this chest CT shows a nodule of both ground glass and solid density measuring less than 30 millimeter in the right upper lobe. So basically it's a mixed type. The causes of incidental pulmonary nodules can be categorized as benign and malignant. The estimated frequency of each etiology varies substantially among studies. This is because that they use different methods. The population, the composition of the population is different. Nonetheless, most of the screening studies, even among smokers, suggest that most nodules identified on computer tomography are benign. The Pan-Canadian Early Detection Lung Cancer and the British Columbia Cancer Agency studies, they had taken up around 12,029 nodules and only 1%, that is 444, were malignant. SPN can be found incidentally in around 0.1% to 0.2% on chest X-rays and a very large number, around 13% on CT scan. And these occur more frequently in patients having smoking history and history of previous malignancy. It's more often in men than women when screening is used, but there's a very interesting fact regarding this. Among the non-smoking population, it's more, malignancy is more common in women than in men. So etiology, they can be malignant, it can be primary, or it can be metastatic, or carcinoids. Carcinoids are considered as slow cancers in slow motion. Benign etiology are infections, benign tumors, vascular etiology, and other etiologies. So adenocarcinoma is perhaps the most common, which presents as a pulmonary nodule. Then comes squamous cell carcinoma and large cell carcinoma. Rarely, primary extranodal lymphomas and primary pulmonary sarcomas can present as a nodule. Having a history of extrathoracic malignancy, there is a 25% chance of malignancy when a pulmonary nodule is detected on a chest radiography. The metastatic, cancers that metastatize to lungs are malignant melanoma, sarcoma. They can be from the colon, kidney, or the bronchus. Among the infectious cause, granuloma constitute around 80%. They can be because of mycobacteria, whether it's tubercular or non-tubercular, or endemic fungi like histoplasmosis, coccidioidomycosis. Staphylococcus aureus can also present as a solid infection by Staphylococcus aureus can also present as a solitary nodule with cavitation. This is a chest CT with contrast showing a 2.8 centimeter nodule and punctate calcification. Central lucency within the nodule indicates cavitation. On the left panel, you can see a chest X-ray PA view which shows a solid nodule in the lingula. On the right side, the CT with contrast in the lung and soft tissue windows shows a solid nodule and measuring and the attenuation is around minus 30 Hounsfield units. That is consistent with fat. The nodule was stable over the next 2 years, suggesting that it was a benign nodule. Among benign nodules, benign causes, 10% of the benign nodules are hematomas, and they typically present with popcorn calcification, which we all know. HRCT is useful in characterizing the tissue present in the hematoma. Less common fibromas, leiomyomas, and hemangiomas may be present. This is a CT chest without contrast, shows a solid pulmonary nodule with characteristic popcorn calcification. Then another cause of SPN may be pulmonary arteriovenous malformations. It's very important to identify this lesion because a biopsy should be avoided in these cases, and rarely vascular lesions like pulmonary infarcts, pulmonary varices, and pulmonary contusion or hemangiomas can present as SPN. Here you can see the CSCT showing a nodule in the periphery of the right middle lobe with a proximal tail-like extension corresponding to the supplying artery and the draining vein. It is a very important clue in identifying a pulmonary arteriovenous malformation. Other causes can be inflammatory like granulomatosis with polyangiitis, rheumatoid arthritis, sarcoidosis, periphyseal pulmonary lymph node or a bronchogenic cyst. The presence of a systemic disease may increase the likelihood of an inflammatory nodule. But conversely, nodules can occasionally be the initial presenting feature of the underlying disease. Pleural pseudotumor, that's a loculated fluid in the interlobular fissure. They can disappear with diuretics, or mucoid impaction. They can also disappear with when you give some expectorants. So the evaluation should be both clinical and radiographical, and the assessment is most important for nodules between 8 to 30 mm. More than 30 mm that lack benign features should be resected. Less than 8 mm without documented growth is followed up with serial CT. You can do these CTs once in 3 to 6 months or 6 to 12 months, depending upon the risk factors. The risk of malignancy and diagnostic options are variable between the range. This is the range 8 to 30 mm. This is the range that we are really concerned about. So the malignancy risk should be assessed either clinically or by quantitative predictive models and by using calculators. There are a lot of calculators in the net available, but you can use this solitary pulmonary nodule malignancy risk in adults by Brock University Cancer Prediction Equation. So these are the parameters they take into consideration: age, sex, family history of lung cancer, emphysema, nodule size, nodule type, nodule in upper lung, nodule count, and speculations. So this Brock model considers old age, female sex, family history of lung cancer, emphysema, large nodule size, location of the nodule in the upper lobe, part solid nodule type, lower nodule count, and speculation. The last one, speculation, how often we have diagnosed a malignant malignancy in a nodule from only speculation from the chest X-ray. This model showed excellent discrimination between benign and malignant nodules, even when applied to nodules typically difficult to characterize, that is less than 10 millimeter. Low probability less than 5%, intermediate probability 5 to 65%, and high probability is more than 65%. These are most useful for the nodules between 8 to 30 millimeter. Increasing age and underlying risk factors for malignancy are important, very important to stratify the risk of malignancy in SPM. And from the age from 35 to 39 years, the risk is 3% when you detect a pulmonary nodule, and it rises to more than 50% above 60 years. Risk factor for lung cancers are smoking, especially current smoker, family history, female sex, emphysema, prior malignancy, and asbestos exposure. Whenever you come across a nodule in an immunocompromised person, always consider infection before malignancy. Imaging, you can select any modality like chest radiograph, chest CT, fluorine 18 labeled fluorodeoxyglucose FDG, PET CT with CT, PET CT of the whole body. Usually we combine PET with CT for better resolution. And usually chest CT is the preferred modality of our initial evaluation for malignancy risks because the nodule size, growth, and lobar location can very accurately predicted. Visualization of nodule attenuation and borders can be also done. So images should be helically acquired as contiguous thin 1 mm section. Iodinated intravenous contrast is usually unnecessary, but is sometimes administered when a vascular malformation or infarct is suspected. So nodule size is an important risk factor for this malignancy. Less than 5 milliliter, chances are less than 1%, and it rises to 50% if the nodule size is more than 20 mm. Attenuation is important, solid or subsolid. Solid nodules less than equal to 8 mm are less likely to be malignant, but they are difficult to get biopsy from them. Not reliably characterized by functional imaging, and best characterized with CT surveillance. Solid nodules more than 8 mm have greater likelihood of malignancy, reliably characterized by functional imaging like PET, likely to be successfully diagnosed by biopsy. So, on imaging, subsolid nodules have less soft tissue attenuation such that normal parenchymal structure, you can see through them like the airways and the vessels. And compared with solid nodules, subsolid nodules are often less amenable to functional imaging and biopsy. We have already spoken about it. The most common histology with ground glass morphology are atypical adenomatous hyperplasia, adenocarcinoma in situ, and minimally invasive adenocarcinoma. Follow-up CT once in 3 to 6 months or 6 to 12 months, depending upon the risk factors. For solid nodules, growth is defined as an increase in size of more than 2 millimeter. For subsolid nodules, growth can be identified as an increase in attenuation or increase in the size or development of a solid component over the background of a ground glass appearance. A solid nodule that has been stable by a CT for at least 2 years does not need any further diagnostic evaluation. Malignant nodules, this is volume doubling time, is an important parameter. So usually malignant nodules have a volume doubling time between 20 and 400 days. If the volume doubling time is less than 20 days or more than 400 days, it's unlikely to be malignancy, but we have to keep in mind that some low-grade adenocarcinomas and carcinoid tumors have high volume doubling time, BDT. Thus, purely ground glass lesions may be less readily detected as actively growing by CT and follow for 5 years to determine the stability. For in case of subsolid lesions, you take 5 years to declare it as that no workup is required further. Calcification pattern is also important. Central, diffuse, and lamellated are seen with prior infections. Popcorn calcifications are seen in hematomas. Chest radiography usually is whenever we detect a nodule, we go on to CT, but in certain cases, CT is not required, particularly when the nodule is because of a nipple shadow. Patients have symptoms of infection and pneumonia is suspected, and the pattern of calcification is very, very characteristic, like popcorn calcification. PET CT, solid lesions, the ability of FDG uptake can be helpful in differentiating between benign and malignant lesions. In contrast to solid lesions, ground glass nodules or ground glass portions of part solid nodules are not reliable characterized by PET. So PET is less helpful when there is subsolid nodules. False positive, you may get PET CT positive infections, inflammatory conditions, in particularly pneumonia, mycobacterial diseases, and false negative in less metabolically active tumor like adenocarcinoma, and particularly in diabetes who have high blood sugar, which high blood sugar actually retards the uptake of this FDG by the tumor or malignancy. Management options, a growing nodule, a permanent nodule that has clearly grown on serial imaging is likely to be malignant and should be evaluated pathologically. So basically, whether we go to for pathological diagnosis or not, we just screen out by CT. Stable nodule, a solid stable nodule that has been stable for 24 months and a subsolid nodule that is stable for more than 5 years by CT should we stop workup. and characteristic calcification if it's there which should stop workup. So bronchoscopic, what are the modalities available for biopsy? It can be by bronchoscopy, and bronchoscopy techniques are usually used when the lesion is in the center, it's large, and non-surgical biopsy is usually done when there is intermediate risk for malignancy, or who are at risk of malignancy but are not candidates for surgery. Choice of sampling, it depends upon the size and location of the nodule. Typically, bronchoscopic technique like endobronchial ultrasound and conventional bronchoscopy are preferred for larger, more centrally located lesions. Transthoracic needle biopsy techniques are preferred for smaller, more peripheral lesions. These are the various bronchoscopic techniques available. The EBUS, that radial probe EBUS is the most advanced, one of the most advanced ones, but I don't think it's available in our state at present. So this is in the peripheral lesions, we can go for transthoracic needle biopsy, and this is the procedure. The needle pierces the chest wall, the pleura, parenchyma, and it is usually CT guided. Surgical biopsy is the gold standard, and for diagnosis of a pulmonary nodule, and can be curative for some malignancies. A diagnostic wedge resection by video assisted thoracic surgery can be used, particularly used in patients who have a high risk for malignancy more than 65%, or intermediate risk of malignancy when non-surgical biopsy is non-diagnostic or suspicious for malignancy. Benign diagnosis is suspected but requires therapy like mycobacterial diseases. Non-surgical biopsy was non-diagnostic. Patient who place a high value on diagnostic certainty. So even PET can be used for taking biopsy. Usually it is helpful when the nodes are more than 8 mm, but always CT is combined with PET because PET alone doesn't have a good resolution. Thank you. So you can add on. You can add on to that. More than 3 centimeter is not a nodule, it is a mass. It's a mass. So actually, what I have said one, this population, they have taken various, the population is heterogeneous. This the Canadian study and the British study, only 1% out of. Yes, that's PET. Near to the. E-bus is the R e-bus. Is it available in Odisha? R e-bus? No. No. Fine.
So we have come to the end of this session, and I would request the esteemed chairpersons to kindly come for felicitation and the speakers also. Request Dr. Sajid Ansari to felicitate. So now we are going for the insulin symposium, and for this we have 3 esteemed chairpersons, but I think they are busy with the lunch. So I would request Dr. Sajid Ansari. Dr. Sajid Ansari. Dr. Sajid Ansari will be chairing this session. And for the first talk, we have Dr. Abhay Sahu. He will be talking on insulin initiation, doing it right for the first time. So over to Dr. Abhay Sahu. Introducing Professor Sahu.
Thank you, sir. Respected chairpersons, my dear friends and colleagues, at the outset, I am thankful to Joint Pandit sir, Anuj Maheshwari sir, for giving me this opportunity to discuss about how we are going to, because this is a very pertinent topic regarding diabetes management, specifically how we are going to initiate insulin and how this insulin will help the patients. We'll discuss that part. So, insulin initiation, doing it right for the first time. So, this is Mr. Chakravarti, 57-year-old gentleman, is a lecturer, diabetes since 2010. Patient is having dyslipidemia from 2016, and patient wants a cataract surgery in near future. So, you will see patient's weight is 68 kg, BMI is 24.8 kg per meter square, patient's diabetic is for last 13 years. And the challenges is patient is having uncontrolled blood glucose, and also patient wants a cataract surgery in the near future. And if you see the HbA1c is clearly have a 10.2%, fasting is 178, post breakfast is 242, post lunch is 186, again post dinner is 278, and serum creatinine is normal. Again EGFR is also normal in this patient, and what the patient is taking, patient is on metformin 1000 milligram per day, empagliflozin 25 milligram, glimepiride 4 milligram per day, and statin 20 milligram per day. So patient is on all anti-diabetic drugs along with statin, and patients having significantly uncontrolled blood glucose in this patient. So what is our plan? Whether we are going to start insulin, whether we are going to start GLP-1, whether we are going to start glitazone, whether we are going to start DP4. You will see DP4, probably the HbA1c lowering property is only 0.8%. So looking at the baseline HbA1c of 10.2%, probably it is not going to help us. Again, if you will see glitazone, same 1%, so not going to give from 10.2, it will come around 9.2, so it's not going to help. Again, GLP-1, robust HbA1c 1.5 to 2, but still we are not achieving the target because with GLP-1, we can at least achieve maximum up to 8 or 8.2, 8.5. But insulin, no limit. Any sort of HbA1c is there, it can bring down to normal. So that is the beauty of insulin in comparison to any sort of OHA, what we have discussed, what we are using in our clinical practice. So this is one of the pertinent slides because a lot of the time what we used to do in our clinical practice, today we have given 2 medicines, not controlled, patient tells, no sir, please give me medicine. So we go to 3, then 4, then 5. We try to actually give number of medicines, whatever. But you see, this is the data we are showing. If you are going for second medicine, HbA1c lowering property is good, 1% loss. But if you are going to third medicine, probably the HbA1c lowering property is coming down, maximum another 0.5% decrease will be there. Again, if you are going to fourth medicine, there will be hardly any change in HbA1c will be there in fourth or fifth medicine. So once someone is having already 3 medications, probably the best thing is go for insulin directly instead of putting another medicine and expecting that the HbA1c will come down to normal. So that is the beauty of this side. So in the clinical switches, when it gives where the HbA1c remains above the goal, despite of concurrent use of optimal dose of 3 oral OHs, probably the best time is this is the time where you should go for insulin. Unnecessarily, you should not waste time for actually doing or putting another OHA and wasting time in reducing the blood glucose level. So what our RSSD 2022 guideline is telling, insulin initiation after 3 OHs. Insulin therapy should be considered in all patients who fail to achieve glycemic control, not required. Target within 3 OHs. However, additional OHs again can be considered in subjects of HbA1c of more to 1 to 1% higher is there above. Then clinicians must consider the situations, limitations of individual oral agents when we are giving combination in terms of quantum of HbA1c reduction. As I have already discussed, with pioglitazone 1%, with DP4 0.8%, if you are going GLP-1 1.5 to 2%, not more than that. So, but when we start insulin, a lot of the time what patient thinks, probably it is the failure in my side. So you should encourage the patient and you should tell the patient that starting of insulin is not a personal failure or it's not a punishment. It is the disease course which warrants us to start insulin because we know after 8 to 10 years, probably no OHA is going to work. So it is the course of the disease which warrants us to go for insulin, and insulin always the best thing, but our best thing people think about the sense of well-being, probably in comparison to any sort of OHA, probably insulin has the best sense of well-being in comparison to anything what you want. So looking at these things, what are the newer insulins? Because we have a lot of old insulins, newer insulins. We have started previously old insulin, but we have a lot of newer insulins which gives not only a rapid blood glucose control, but the risk of hypoglycemia is significantly less, the risk of weight gain is significantly less. So that is the beauty of this medicine. So if you see the IDAGAS, it is a choice of initiating insulin in the people of type 2 diabetes, specifically who? Those who are having significant higher blood glucose level, again those who are having postprandial hyperglycemia, again those who are having repeated hypoglycemia. That is another thing, that those who are having significant recurrent hypoglycemia, probably these are the newer insulins which have significant less amount of hypoglycemia. Again, we can initiate when HbA1c is more than 7%, when postprandial blood glucose is more than 180. The rationale is starting a fixed dose combination addresses both fasting and postprandial simultaneously. So you are not only like that, you fix the fasting first, then subsequently you are targeting the postprandial. Here you are taking care both fasting and postprandial with single injection. That is the advantage. So we know this IDAGAS is 30% is aspart and 70% is degraded. And this is not a premix insulin. This is a co-formulation. The basic difference of co-formulation and premix is in co-formulation both are 2 separate insulins which has been actually mixed in such a way with every unit 30% will be short acting and 70% will be long acting. So that is the beauty of this molecule. And the combination of quick release postprandial with particular slow release vessel. So you know that if you are aspart rapidly releases, it controls the fasting or postprandial blood glucose, and the short acting, that is the degludec part, actually releases slowly and it tries to control the blood glucose for 24 hours and also try to control the fasting blood glucose in this rapid way. So that is the way how the aspart rapidly releases, whereas actually degludec part actually releases slowly. After once one zinc is removed, then it comes out, and that actually gives actually slow release of the molecule, and that controls the blood glucose for 24 hours. You see how it's going, yeah. So once, yeah, this is the way how it is slowly being released and controls the blood glucose for 24 hours. So then what is the beauty is that with single injection, you see that this is the part, the red part, which actually the mealtime postprandial part, which is being controlled by the aspart, and the green one is actually controlled by the degludec, which is remaining for 24 hours. It is truly basal insulin that is absolutely peakless. So for 24 hours, the blood glucose control will be the very good one. Then what is the ideal profile? Where you should start? These are the people, if someone is uncontrolled on OHA, needs for safety, and if someone is having the flexibility for initiation. That means degludec is a molecule which can be given anytime. Suppose today patient has taken in the night, next day patient has forgotten, and next day morning patient is taking, still the risk of hypoglycemia is less and still the H1C control is same. That means even if you are mixing or you are just forgetting one dose and after 8 hours you are taking, that is also going to work and that gives the same result. So again, what are the other things? Uncontrolled with basal insulin, need for flexibility, unacceptable weight gain, also unacceptable hypoglycemia, they should be taken. And if we see the specific patient wise or specific category of patients, then safety point of view, elderly and frail patients, hepatic impairment, renal impairment, fasting condition, and also erratic meal behavior, all those people can safely use this molecule without any hesitation. Then patient profile for initiation, already on premix or basal plus, still blood glucose is not controlled, poor fasting, need for flexibility. Also, if someone is having recurrent hypoglycemia, these are the ideal patient where you can start this molecule. Again, if someone is on basal bolus, we know because someone is on basal bolus, patient is taking 4 doses. Here, patient is not ready to take 4 doses or 4 pricks. We want to reduce the dose or reduce the pricks. Probably only 2 pricks, it will help, and it will be truly basal bolus with only 2 pricks. Then unacceptable variability, recurrent hypoglycemia, and also needs for flexibility of those patients. Which and why? In one side basal is there, one side idagasp degludec is the combination, this combination is there, or this co-formulation is there. So which one should choose and which is the best one? So the shortcoming of basal insulin is they inhibits hepatic glucose production, they don't have much effect. Of course, they lower the fasting plasma glucose, but they don't have postprandial effect on the postprandial glucose, because we Asian people, we Indian people, we rice eaters, those who are having a significant rise in the postprandial blood glucose, usually it's classically not being taken care by particularly basal insulins. So again, there is different glycemic response among the Asian and non-Asian people on basal insulin. You see, in the non-Asian, the basal insulin, the effect is quite good. Of close to 47% people achieving the target, H1 of less than 7%. But once it comes to the Asian population, once it comes to Indian population, it is reducing to 39%. So that means those who are actually high carb intake people, those who are having actually significant rice eaters, or those who are having a significant large meal, probably their prandial control is important, and probably basal insulin is not sufficient to control their glucose. So this is the efficacy and safety of this directly head-to-head comparison of this Ryzodec versus basal insulin. This is Glargine. What they have found, that significant better postprandial control. Postprandial is reduced by another 60 mg%. Further H1 reduction is 1.4%. And if we'll see the fasting, there is similar control both with basal and also with Ryzodec. So if we'll compare Ryzodec versus only Lantus, then probably Ryzodec is actually the best in this class to not only control the postprandial blood glucose, not only controls the significant reduction in HbA1c. Also, if you see the hypoglycemia point of view, again, that is found to be significantly less. With IDEGAS, 72% more patients achieve target in comparison to basal insulin or in glargine insulin. Then again, if you see the insulin initiation in OHA failure type 2 diabetic patients, can IDEGAS write a new concept in the subcontinent? If you see the change in HbA1c over a period of 3 months, if you see they have taken 3 insulins. This is upper one is black one is glargine, then the blue one is glargine U300 and the green one is IDEGAS. So of course both glargine U300 and IDEGAS are both superior than glargine, but if you compare all three, probably IDEGAS has the highest percentage of people or highest fasting control, better fasting control, better postprandial control, and also better HbA1c control is this there. Again, if you see that what is happening to the doses of insulin, that is one of the important things, because we know once the dose of insulin increases, there will be weight gain, the risk of hypoglycemia increases. You see comparison of glargine, the left one is glargine U100, the middle one is U300, and last one is glargine, this is Ryzodec. What has clearly shown that Ryzodec has significant less increase in the dose over a period of 3 months for control of blood glucose. So again, that shows at the end, there is a significant increase in the insulin dose requirement with particularly glargine or glargine U300, but there is not that much increase with particularly this Ryzodec. Again, there is no significant, but if you see the hypoglycemia point of view, there is no difference. So that means we are giving less insulin, less hypoglycemia. That if we reflect it, weight gain will be also significantly less, particularly with this group of medications. Then this is the real world data, particularly comparing this IDEGAS was this Ryzodec with glargine U100 and 300. That has clearly shown that insulin dose baseline with the end of the studies, there is a significant reduction in basal and total daily insulin requirement with particularly this Ryzodec. If you see the quality of life, again see that there is significant improvement in the quality of life with particularly this Ryzodec. And again, 75% people prefer taking this Ryzodec in comparison to the basal insulin alone. Then this is another part that try to see what is happening to the quality of life and treatment preference among the people. 94% people manage their day-to-day activities better with particularly Ryzodec. 90% people have improved quality of life with reduction in the number of pricks, and 87% people are comfortable in injecting this insulin from that pen in comparison to whatever other pen are being used. So that means again, that is also one of the important factor. Whatever the pen we are using, how comfortable it is, how easily we are administrating, that is also one of the important factor for particularly patient satisfaction point of view, and that is found to be better with particularly Ryzodec. Again, the reduction of pill burden, if you see, once you are giving Ryzodec, then the reduction of pill burden is actually those patients who are baseline HbA1c of 9 to 11%, those are already on baseline 2 OHA, the pill burden is reduced by 13%, on 3 OHA reduced by 47%, on 4 OHA it is reduced by 7%. So in nutshell, the number of pills what the person is taking, that is also coming down significantly once you are using using this molecule. Again, if you see co-administrating with, in the first you can use SGLT2 inhibitors, in the second you can use sulfonylureas, in the third one you can use GLP-1. The importance is if you are using SGLT2 inhibitor, you have to reduce the dose of insulin, because we know that SGLT2 itself has a quite potent molecule, so you have to reduce the dose. In the second, if you are going for 2 doses of Ryzodec, probably you should stop sulfonylurea. But if you are going for 1 dose, then at 1 dose Ryzodec and another sulfonylurea you can continue, whether it is the morning or night, that is your choice, but you can continue sulfonylurea. In the third part, it can safely given with GLP-1, but important thing again is I have already discussed with SGLT2, you should reduce the dose of insulin, or that protocol is you give 10 to 15 units from the beginning and try to bump up the dose and try to control the blood glucose as required to make the blood glucose normal. So that is the advantage of this molecule. Again, from the cost effectiveness, you see the upper part, the medication cost wise, probably the Degludec is actually, or this Ryzodec is bit costlier. But you see the lower part, outpatient visit, emergency room visit, inpatient hospitalization, and number of ward days visit.
that has actually significantly less with particularly use of Rhizodex in comparison to particularly other insulins what are being used. So if you see the total cost, it is quite significantly less with use of Rhizodex in comparison to other insulins. So that's also initial cost might be little bit higher, but if you take a yearly cost, in total cost, probably it is significantly less with use of this Rhizodex. So again, the second part is whether we are going to premix, older premix, or whether we should go this co-formulation. This is the difference. If we are going for co-formulation, it mimics truly physiological insulin secretion. There is no shoulder effect. There is chance of late hypoglycemia will be less. Then also it simplifies the insulin regimen what you are classically giving. But if you are giving this premix insulin, then there is variable glycemic control. Truly they are not 24-hour control will be not there, and also there needs resuspension because there needs some sort of mixing before giving this particular drug. We know everybody in this August gathering. Then looking to our patient, suppose patient is taking only tea biscuits in the breakfast, lunch, soup and something, but the major meal is at dinner. So the rule is you should give this co-formulation with the major meal. Whether it is lunch, you give in lunch, but if it is dinner, you should give it dinner. So with the major meal, you should give the insulin. Then important thing is, so if someone is administered Idagas with most carbohydrate heavy, as I have discussed, heavy meal, and can be given in different meals once in the different days. If suppose today you have a heavy lunch, you take at lunch, next day you have a heavy dinner, you take at dinner. There is no problem. So that flexibility is there, particularly with this Rhizodex. Then administering this twice daily, with particularly if someone is aware, actually our people, our lunch is quite heavy, our dinner is quite heavy. So in that case, you can give twice daily administration, and that will help us to control the both prandial rise in lunch and prandial rise in dinner can be taken care of both. So Mr. Chakravarti, as I have already discussed the baseline things, in this case, as our guideline is telling, you can go for either you go for a basal insulin or this co-formulation. In this patient, co-formulation was started. It causes less hypoglycemia, requires low dose. Also, the weight loss, weight gain is significantly less. Again, patient is having a flexibility time of administration. That is important thing with particularly this molecule. So, the practical recommendation, weekly titration is required. If fasting is above, you can increase by 2 units. At target, you maintain the dose. If someone is going towards hypo, you can reduce the dose by 2 units so that at least you can maintain the blood glucose clearly. Again, you should start with major meal to control the fasting. If someone is having it twice daily, then you should go for pre-breakfast, pre-lunch and pre-dinner. All three should be taken care of or should be controlled. Just 30 seconds. And if titration of pre-dinner and pre-breakfast should be taken care of with this thing. So patient was started, you see within 3 months, from 10.2 the HbA1c come down to 7.8. Fasting comes down from 178 to 110. Post breakfast from 242 to 142. Then post lunch has not done it, but post dinner has again come to 146. So that shows everything is truly controlled, absolutely normal for the patient. So this Idagas is having lower risk of hypoglycemia. The meal, there is mealtime flexibility, very simple regimen. It is convenient of device, better quality of life. It is found to be cost effective. Along with glycemic control, all this truly, all things, the Hexad, that is fasting, PP, HbA1c, patient quality of life, risk of hypoglycemia, everything is being taken care with particularly single dose. At the end, OISCON is actually being held on 27th to 29th in the Hotel Swasti Premium. I am inviting everybody for OISCON from this platform. Thank you.
So in this symposium, we had two topics, and the last topic and Dr. Swami, Professor of Technology, the alumni of PhD, dichotomy of innovation.
Good afternoon, everybody. Thank you, chairpersons, for this nice introduction. At the outset, I would like to thank the ACP Governor, Dr. Anuj Maheshwari, the organizing chairpersons, Professor Jayant Panda, and that scientific chairperson, Dr. A.K. Virmani for giving me this opportunity. And I would like to thank Navhov also. So, though it is the last part of the academic section, it is the real truth of the world, the real scenario of the diabetes and diabetic management. So, my topic is dichotomy of insulin innovation and adaptation. So, my agenda will be discovery and innovation of insulin with glycemic control and variability, real-world insight on uses and preference, understanding the discrepancy between the innovation and adaptation, and bridging the gap between the two. As you know, we have crossed 100 years of insulin discovery. The Bunting and Best, the first persons who discovered insulins 100 years ago. And after that, we have that NPH insulin, purified insulins, human, the bovine insulin is coming to the field. And after that, NPH insulin, after NPH, we have the Detimirs and U100, that is analog basal insulin, and first generation of the basal insulins. Now we are in the second generation of the basal insulin, that means Glargines 300 and insulins Digludax, which is the ultra long form of the insulins we are using. See how after this evolution of this basal insulin, I would like to explain something regarding the premix insulins. And in terms of these basal insulins, the half-life of NPH insulin is 5 to 10 hours, and that of the first generations of this basal insulin is 12 to 15 hours, and the second generation of the basal insulin is about 25 hours. And the glycemic variability of the NPH is very high in comparison to that too, and the ultra long acting, that is newer basal insulin, have less or low range of the glycemic variability. But we physicians don't want that glycemic variability. It is well correlated with the cardiovascular morbidity and mortality. So the less glycemic variability is useful to us. Coming to the premix insulin, evolution of the premix insulin, as we know, the isolation of insulin in the past 1921. After that, there is ultra pure insulin is coming to the field in 1973, and the premix insulins, combinations of the premix conventional insulin I am talking, it has come to the field in 1980. It is the combinations of the both in 30, 70, 25, 75 of the regular acting and the intermediate acting insulins. After that, the analog premix insulins are coming to this field, and now we are in the co-formulation preparations. And Professor Avesa has nicely described the co-formulation, how it is released, the ultra fast acting insulins, immediate with response to this meal, it is coming to these bloodstreams, and the long acting taking care of the hepatic glucose output and fasting blood glucose. So we are in the era of the premix co-formulation. Similarly, devices. With the discovery of the insulin, with the evolution of insulins, our devices have evolved from that of the glass syringe to that of the pen, pump, and artificial pancreas. And here I like to emphasize on this insulin degludec, that is newer insulins, long acting, ultra long acting insulins with the, I will highlight some of these portions like glycemic variability, like that is flexibility, and that of the side effect like hypoglycemia and weight gain. Here it is, they have compared this ultra long acting insulin degludec with that of the glargines 300s. They found that the lower rate of hypoglycemia in insulin degludec as comparison to the insulin 100 and insulin 300s. Again, glycemic variability, as I have described previously, significantly lower rate of the glycemic variability, both interday glycemic variability and intraday glycemic variability is less with the insulin degludec as compared to the other second generation insulins. And coming to the flexibility, that in case of the insulin 100, we don't have any flexibility, but in case of the insulin glargine 300, we have some flexibility of the 3 hours. But if you look to the insulin degludec, we have the flexibility of the 8 to 40 hours. So great flexibility, less chance of hypoglycemia, less chance of weight gain, and variability is less with the insulin degludec as compared to the other second generation insulins. There is good number of evidence and good number of studies are there. So particularly after this basal insulin, I would like to highlight this combination, that is insulin degludec and aspart combinations ideas. And our RSSDI 2022 recommendation is that the choice of insulin initiations is maybe the co-formulation insulin degludec. Why you are preferring insulin degludec? The Professor Sao has nicely described with a case scenario, and I will highlight some of the key points like lower hypoglycemia is there with insulin degludec, and that is flexibility, what I have described, simpler regimens, what we have discussed in the last 1 hour, and convenient and also cost effective, and efficacy also, that is substantial evidence from that. So we are preferring the co-formulation because of the robust evidence from the global trial to that of the real world evidence in the Indian scenario. And the real truth is that diabetes, the populations of the diabetes increase day by day. That is in the tune of 783 millions will suffer from the diabetes at the end of the 2045. So the burden is increasing rapidly. And along with that, if you look to the ICMR INDIAB study, the prevalence of diabetes and also pre-diabetes is very high in India. About what we previous studies are there, it is very much more higher than that. That is 11% of the Indian populations are diabetic and 15.3% of the Indian populations are pre-diabetics, and this number is much more high than the previous studies. Next, coming to that of the burden, we have discussed the burden of the diabetes in India. Now the burden of the glycemic burden, uncontrolled A1C in India. We have our DICARE study, we have TIDE study, CAR study, and IDCI study. And that study from the 2011 to that of the 2020. And in all this study, this only 19 to 23% of patient, or 15 to 25% of these peoples, they have the good glycemic control. That means A1C level is less than 7. So we are having poor glycemic control. This is the scenario of world and scenario of India. So next part of my discussion is the real world insight on uses and preference. So if you look to this Indian scenario for the current insulinizations, 31% of these people's diabetes being managed with insulin. Next, 70% of these peoples, they are with oral hypoglycemic agents or on with. And second part of the scenario is 46% of these patients with uncontrolled type 2 diabetes, they delayed the insulin secretion. This is the truth. 30% of these peoples, they are taking insulin, and 46% of these or 50% of these patients, they have delayed the insulin initiation in Indian scenario. And that slide has been discussed by my previous speakers. And if someone is taking 2 oral hypoglycemic agents and you are going to adding his second ones, then you will not get substantial benefit. That A1C reductions is the tune of 0.2 to 1% by addition of another one molecules, another oral hypoglycemic agent. But that is the substantial improvement, reductions of the A1C in the tune of 1 to 1.3% or 1.4% from the pre-treatment level with the additions of the insulin. So substantial benefit for the initiations of the insulins and early initiations of the insulin is there. Next, coming to this, patients and physicians identify that higher frequency of insulin injection is a burden. It is definitely real truth. So more than 90% of the physicians and the patients wish for the good control, good glycemic control, but with the insulins, that is, they will not inject every day. This is the study published in a good reputed journal. So we want a good glycemic control. We want to take insulin, but not daily. This is the fact. And about 33% of these patients omit their insulin dose. That means non-adherence in the Indian scenario is 33%. I think all over the world, this is the scenario all over the world. And we all know uncontrolled glycemia is having, if you have the A1C much more ahead from the your goal, and you may have the microvascular and macrovascular complication. So the third part of my agenda is understanding the discrepancy between the innovation and adaptations. We have insulins, discovery of the insulins, we have crossed 100 years. From that of the unpurified insulins, we have the highly purified insulins and once daily, once weekly insulin. Still our A1C is much ahead of the goal. Then what is the, why is that is a discrepancy? So there is a insulin, we are using less insulin as these studies are there, but what is the barrier for the insulinization? It is the physicians related and patient related. If you look to the physicians related part, that is insufficient resource. That means we are overburdened. And around 74% of the physicians, they don't give more than 10 minutes for consulting a physician. This is the real scenario. It not in the India, all over the world, it varies from 6 minutes to the 12 minutes. So average 74% of the physicians, they are giving 10 minutes for the patient's consultations. And again, a lack of manpower. That means we don't have the trained paramedical staff, nurses, diabetes educators, and we Indians don't have that concept. So the lack of manpower and lack of time is the main constraint for the achievement of the glycemic goal. And coming to the concern, physician, another aspects of the physician concerns, that may be the inadequate knowledge regarding the hypoglycemia, fear for the hypoglycemia, fear for the weight gain, and fear for the poor quality of the life. So if you have, if you don't have the time for the counseling, if you don't have the time for the repeated revisit of the patients to your setup, then hypoglycemia, you will be fear for the hypoglycemia. So 75% of the physicians started the risk of hypoglycemia was a barrier for the insulin therapy. And second, weight gain, diabetes and obesity are well correlated. So if insulin is lipogenic, so if you have increased weight, then you may have the deranged glycemic status. And opposite to weight, if you reduce the weight, you have the A1C reductions, blood pressure control, and lipid parameters will be controlled, and you will get so much of benefit from the weight reductions. And for most of the physicians, they are thinking that if you are giving a complex regimens, then quality of the life will be disturbed and patient will lead a poor quality of the life. This is the barrier. And also some suboptimal knowledge regarding that insulin regimens, regarding that guidelines and different recommendations in the different guidelines, and newer therapies coming to this field. And if you will not update yourself, then that must be fear regarding the hypoglycemia, weight gain, complexity, and all the things. So this is part of the physician. Coming to the part of the patient concern, it may be the we'll consider the three aspects that after giving a insulin prescriptions, that patient's barrier may be the knowledge barrier, maybe the cost or socio-economic barrier, maybe the psychological barrier. Knowledge barrier, in case of the knowledge barrier, the two aspects: low prioritizations of the diabetic disease in comparison to the other disease. And the second part is for lack of awareness of the benefit. If your A1C will be controlled, you will have the such benefit. So this awareness will not there with the patients. And coming to the psychological barriers, it consists of a complex set of things that includes meaning of the insulin therapy, poor self-efficacy concerning the skill needed for the insulin therapy, fear of the insulin injection, and lack of accurate information. These four are included in the psychological insulin barrier. So what happened? In psychological, as I have described, in the psychological barrier, low self-esteem and other anxiety, cost, and all other things are included in these psychological barriers. In a study of more than 3,000 patients, after prescriptions of insulins, more than 300 patients, these patients, they have taken these prescriptions but delayed these insulin initiations. And more than 600 patients, they have not started the insulin at all. Only 2,000 patients, they have started the insulin. So this is the result of the psychological barriers with the patient. And then next part is, the last part of my discussion is the how to bridge these gaps. So as a result of the psychological barriers, physicians and patients should understand that if you have this psychological barrier, we will have a bad glycemic controls or A1C much higher from this goal, and you will land in the microvascular and macrovascular complications of the diabetes. So both should understand this. So how to solve these problems in case of the physician's barrier? That means use of the nurse, pharmacists, diabetic educators in our clinic or in our setup, and that more frequent visit, we should advise these more frequent visits and repeated regular counseling, and also update ourselves regarding the newer regimen and newer guidelines, and constantly we should build a good relationships with the patients, and we should gain the trust of the patients so that we can overcome the psychological barrier of the patients. Next, another important thing is lipohypertrophy, concern with that of the previous insulins, and somehow it is the hypertrophy of the repeated. If you inject an insulins repeatedly, there is hypertrophy of that particular area, and not only it is concerns that it is cosmetically it is hypertrophy and looking ugly. It is not thing is not like that. There is absorptions and this pharmacokinetic, pharmacodynamic, and this control of this blood glucose is different. If you have lipohypertrophy, which is seen in the previous insulins, and we don't desire lipohypertrophy because of the it will hamper the absorptions of the insulins, and we will not able to achieve our glycemic goal. So reducing the daily number of injections should be given priority to prevent the development of the lipohypertrophy. This is one solution. So there is a need for the insulin regimens that are less restrictive and burdensome. So next, that lipohypertrophy and the other concern will be resolved in the newer insulins, which have less hyperglycemia, less weight gain, better quality of the life, and less adverse effect, what we have discussed previously. So this, and coming to the patient, how this patient's barrier, how it will be solved? It will be solved by the self-educations, and so many apps are there at present, like self-assessment apps and CME and hands-on trainings and repeated interaction with the physicians and the patients will solve the barrier and solve the problem of a psychological insulin resistance, and it will will have a better glycemic controls. So again, it is a good publications by Dr. Sanjay Karla et al. We should set expectations, not that 100% will achieve our goal. So we have a discussions with our patients, we'll set a goals and we'll try to achieve that goals. By that things, we'll able to achieve our glycemic goal, overcome the psychological insulin resistance, and we'll overcome the concerns regarding the physicians and regarding the patients. So we'll achieve our goal, though not 100%. So at the end, our future is bright. Now we are going towards the end of our insulin innovations. That means once weekly insulins. So this lipohypertrophy portions is less in once weekly. Injection phobia is less. So flexibility is more. Good efficacy is more. So once weekly may solve that problems. And also oral. When injection phobia is there, oral insulins may have this better acceptance. And another is some regimens that have the glucose sensitivity, that will be better for the in those patients, those who are fear for the hypoglycemia. And the next important thing is that beta cell replacement. So these are the newer things which will make which if all the things are freely available, we will achieve our glycemic goal and overcome our resistance in the part of the physicians and the patients. So to summarize my presentations, poor glycemic controls have microvascular complications and microvascular complications. Physicians and the patients should able to understand these problems. And despite of the advancement of the newer analog insulin with better efficacy, safety and convenience, the adaptation is at low. Frequent insulin injection is burdensome and inconvenient, contributing to the therapeutic inertia and poor treatment adherence. People with diabetes and physicians prefer fewer injections to reach the glycemic goal. In this aspect, once daily insulins, Ikodac may be the good option for both physicians and the patients. Thank you for your patience hearing.
Thank you, Professor Shah. We all agree that our patients know the but the inertia of initiation is in the physician mind more than the patient mind. Rightly you have told, but the insulin therapy, the thoughts need to be motivated to encourage the patient, tell the benefits of insulin therapy so that he lessens that will go along. And it should be a turning point in the management of diabetes, because thereby we can decrease the complications, achieve a good glycemic control, and hopefully manage the patient over the years. So that was the last presentation of the Hall A in the conference. Now it's open. I'll invite questions 1 or 2 before we go for the valedictory. The content was very obvious and the message was very clear by Professor Shah. So there are no questions. So give a big hand to Professor Abhishek and Professor Jayashree Shah for this insulin symposium. With that, with thanking to the organizers, I close the session and volunteers for the arrangement of the report. Thank you. To come forward to receive the memento from Professor Maheshwari. At the closing faculties of the conference, and I request Maheshwari to deliver the mementos. The mementos ready? William Oslo, station is on. We'll be waiting 5 minutes for them to join the Valerie. At that time, request, thank you.
I think you all had a great scientific feast, and every good thing comes to an end. So we are ready for the valedictory session. And for the valedictory session, I would request our Governor, Professor Anuj Maheshwari, to kindly come on the dais. The organizing chairman, Dr. Jayant Panda, scientific chairman, Dr. Anil Kumar Virmani, and our esteemed secretary, American College of Physicians, Professor Narsingh Verma, to kindly adorn the dais. And our vice president, and Dr. Jugal Kishore Sharma, sir, kindly come on the dais. May I request the dignitaries to kindly adorn the dais. एक मिनट रुक जाओ, मैं आपको 2 मिनट बात करूँगा, मैं आपको कॉल बैक करता हूँ. So I would request first our scientific chairman to kindly give his words about the program and the proceedings. Please, Dr. Anil Kumar Virmani, sir.
Good afternoon, friends. So finally we have come to internal medicine, and I'm sure a lot of you will carry good messages and good memories from this conference. Thank you.
And we extend heartiest welcome to Dr. Jayant Kumar Panda, sir, who has been the organizing chairman of this wonderful conference. And I would request him to kindly speak a few words in the valedictory session.
And I must thank ACP whole team, and all council members, advisors for taking this up, and for the preparatory to discuss highest number of faculties have become speakers and chairpersons and judges for assessment, balancing the volume and so topics every delegate may be postgraduate or member register. He edit fee for our associates, for our team, for the postgraduates, and many people from capital hospital up and take the advantage of it. So the big hand to the good fully land of operation that help mostly the Indian graduates. The
be an international event. It's great and those will get that opportunities once in a lifetime, and that will encourage more youngsters they'll be participating. Dr. Birmani, single word I'll tell you, he has not left any stone unturned. 1 month before, he has completed the scientific program. In Goa program, I think difficulties such a diversified membership and the fellowship, but he did it very first, and then topics given by him, prefix topics listed by the speakers, he did the program, scientization name, and name topics. Because he came early, formulated the topic well, included. Number 3 papers, speaker last 2 days, but being had Dr. Virmani. We had a very beautiful advisory meeting, pre-conference, where most of the advisors were there, and concrete decisions for coming here, every front, like early career initiative, movements, in projects, the Joy Award session, how important like COVID, taken by the teamwork is done in guideline of this. So before so many things were achieved, this started a new avenue, new phase in the all together. Use among youngsters. Early career condition, achievement. It takes every category physicians told repeatedly, now sky is the limit. Everybody wants to know anything and everything that is in his own field. Not working in medicine can be operated at global level. Finally, I'm grateful for the organizing the competition assembly and very well. Very difficult to manage everything. My postgraduates, organizing delegates, a remote team at the activities we covered from job for the conference. Finally, I feel that it's very well.
The success of any conference comes from the abstracts that we receive, And if we can ignite the young minds to do research, I think we are going to solve the purpose of this conference. So we had some exciting prizes for the winners, and I would request Dr. Anil Virmani sir to kindly announce the name of the recipients, and please do come over the stage as your name is called for.
We had a very enthusiastic response from the students and delegates regarding the various presentations. The results are out. As far as the clinical case presentation was one of the categories, the third position goes to Dr. Sabyasachi Hota. Is he here, Dr. Sabyasachi Hota? The second position in clinical case presentation goes to Dr. Abhay Sahu. Dr. Abhay Sahu. And the first position in the clinical case presentation goes to Dr. Utkalika Das.
People believe that giving pre-paper and presenting pre-paper is job of junior doctors, postgraduates and residents. Professor Sahu has proved it wrong. He is the Professor HOD of Endocrinology of IMS and SOM Hospital, and now practicing with the Apollo Group, and he has many followers. He has presented a paper, pre-paper, and got an award also. Please give a big hand.
I think this conference shall be remembered that for the reason that maximum number of the professors presented the paper in this conference. Not only Dr. Abhay Sahu, Professor Jashi Swain, and Professor Mukhya Pran Prabhu, I'm not whether he is here or not. So this simply shows that Odisha is academically keeping highest level of the standard, and what I could really perceive seeing the crowd and seeing the people's interaction, and we were really getting delayed in sessions because of the lot of interactions were coming up out. So thank you very much. Next one, Dr. Utkalika Das. Utkalika, please. And she has won the first prize. Residency at Patna, and basically you are from Odisha. Wow. Another son of the soil, not daughter of the soil. Daughter of the soil has got the prize. Wow. So it is a matter of pride for Dr. Panda.
2020 COVID time, I was there. So she graduated 2020 from ACB, our student, and now a resident in the AIMS Patna. So give a big hand. She scored the first prize.
One comment here that all the marks which these people have got, they have got it 100% on their own. The judges were totally unbiased. We calculated the numbers from that. So it was that. So it should not appear that it is something, and there is nothing like that.
The next category was poster presentation. The third position in poster presentation goes to Dr. Asmita Gera. Is she there, Dr. Asmita Gera? Next, second position in poster presentation goes to Dr. Bishal Soin. Is Dr. Bishal Soin here? And the first position, no, he's not there. First position in poster goes to Dr. Asif Dabir Jafri. Dr. Asif Dabir Jafri gets the first position for poster presentation.
Congratulations.
The next category is research paper presentation in undergraduate category. So the third position goes to Dr. Samyukta Umashankar. Dr. Samyukta Umashankar. Ajay.
I have an appeal to the Honorable Governor. From next time, please separate the categories. No, in the the faculty separate and the PG is separate.
इसमें स्पेलिंग मिस्टेक हो गया ये नहीं है अजय तिवारी लेगा बहुत टाइम हो गया सर
Right.
So the
Everybody.
Second position in the research paper presentation undergraduate category goes to Dr. Komal Verma Saluja. Dr. Komal Verma Saluja. And the first position goes to Dr. J. Tiwari. Dr. J. Tiwari is here.
Dr. Ajay Tiwari is here.
Research paper presentation in the postgraduate category. Third position goes to Dr. Mukhe Pranab Prabhu. I think he has left. The second position to Dr. Aniket V. Inamdar. Dr. Aniket V. Inamdar, please come.
Hello. Few words I will say for Dr. Aniket Inamdar. He practices in a very small town, but his zest for research is overwhelming, and I think he has presented posters in almost all the international conferences. So he is a rising star.
And the first position in the PG category research paper goes to Dr. Jayashri Soy. Dr. Jayashri Soy, please. नहीं हो best publication present. The next category was best publication presentation. The best publication presentation, third position goes again to Dr. Aniket V. Inamdar. I think he's there. Second position to Dr. Gokul Krishnan. Dr. Gokul Krishnan is there? Yeah. And the first position goes to Dr. Rohit Jacob. Dr. Rohit Jacob. That finishes the presentations and publications. We had an ECG workshop and the ECG quiz. And the third position in ECG quiz goes to Dr. Asif Dabir Jafari. Second position in ECG quiz to Dr. Saurav Kumbar. Saurav Kumbar. And the first position in ECG quiz goes to Dr. Saswat Kumar Bainipati.
Now I would request Professor Anuj Maheshwari, our dynamic governor, to give his words to the valedictory session.
Thank you. Thank you, Ajay. Thank you, Dr. Vermani, for making this wonderful scientific program. And thank you, Dr. Jayant Panda, for organizing this everything for everyone. 1, 2, 3 messages are very important. Of course, all of us are very much happy that this much of the crowd is in the valedictory session. I can see that the crowd which was in the same amount of the crowd what was in the section is there in the valedictory also. So usually we do not find this much of the crowd in the valedictory. But one message I would definitely like to go, my all postgraduates, whosoever they are, they should not be really desperate for anything. I can see that some people are very much intelligent, they are doing very good, and they are getting the prize in their own capability, and they are winning it. But despite that, if they are trying to through some unpious channels, it just reduces the grace of the prize. So you should not be doing that kind of a thing. I am really very happy the person who has been doing that has got the first prize. Later on, he has got the first prize in another competition also. But the things has that this which makes in our mind that something is fishy there. So I request all the postgraduates, don't do these kinds of the things. Don't try to influence the results. Although I did it, I ensured it that this kind of the influence may not work, and I believe that it might not have worked. But please don't do that kind of the things. It's a general message. Second, I wish that like in this conference, all senior faculties, all professors and associate professors came up for the presentation of the research work, and it should be encouraged further in other conferences also. Presentation of the research is not the job of only postgraduates. I'm very happy that a lot of undergraduates are also coming up. Undergraduates, those who are very much busy in multiple topics, multiple subjects they have to read. Not only the medicine they have to read. They have to read so many subjects. And still they get data collection time, still they get the time to make the paper and present in some conference. This is really creditable and commendable. So I really appreciate all the undergraduates, those who participated here, and I wish that more number of the undergraduates, especially the MBBS students, whom ACP gives the free of cost membership. ACP's membership is one of the very costly affairs as far as the membership is concerned, but for MBBS student it is free of cost. So I wish that all the MBBS students of the Odisha should become the member of the ACP, and at the same time they should also be actively participating in annual conference and they should win the prize. This will make a foundation of developing future researcher who will be very much sound in their work. Otherwise what happens in postgraduate, we start doing the work and many times it is good, it may not be good, and so many times we compromise with the quality of the work. So the endeavor and aim of the ACP is that we should come out with the good quality research in our country. In this conference, a lot of things has happened. I am not going to repeat. Many new things has started. Many good things has been done, like presentation of the research initiatives of the ACP, like Indian Society of Hypertension guidelines, which has come for the first time in India. ACP has given its platform for their presentation, for their first presentation. Of course, those guidelines has been released in the conference of the Indian Society of Hypertension, but ACP has given a platform for their discussion. Hour-long discussion has occurred and a lot of things has come out of that discussion. Similarly, all the doyens of their field participated as a speaker in this conference. If I take the name, Dr. Anup Mishra, Padma Shri, Dr. Anup Mishra, Padma Shri, Dr. V. Mohan, Padma Shri, Dr. Shashank Joshi, any more Padma Shri which I am missing? Padma Shri Kamlakar Tripathi. So there were the 4 Padma Award winners were the speaker in our conference. Hats off to Dr. Jain Panda and Dr. Virmani who brought this. So before I ask you that this conference is over, I would like to felicitate these 2 pillars of this conference, Dr. Jain Panda and Dr. Virmani, one by one. Dr. Virmani, you come first.
Request the House to clap for their wonderful services to the ACP. And the ever smiling organizing chairman, Dr. Jayant Panda, a huge round of applause for him.
Actually, the felicitation.
So,
And then, Anuj, 1 minute.
next year, we
First-
shall be meeting.
1 minute.
You want to say something?
Yeah. The felicitation has reached up to Dr. Birmani and me. No, one more is left. We want to felicitate you. I tell you, get a flower bouquet. That's all. Yeah, bouquet and Pattachitra, Uttariya. Actually, there may be many beads, but a thread is required to hold. Make a garland. And I realize now that the governor is the thread, where there can be a Nursing Burma, there can be a Ajay Tiwari, there can be a J.K. Sharma, there can be a Virmani, there can be a Jayant Panda. And connecting all the wings, taking people across the globe and getting the youngsters so many awards, more than 100 awards, fellowships. I salute the vision of Professor Anuj Maheshwari, who has given a big leadership to the ACP. And it's a privilege to work with him, and I'm sure the history will remember such an academic movement in India. Give a big hand for him.
बस 2-3 मिनट में कोई फर्क नहीं पड़ेगा 8 घंटे में 2-3 मिनट when we have started this conference, lot of hiccups were there. You know that NMC guidelines, and apart from, after that, so many companies were withdrawing and a lot of difficulty of the fund. And when the conference has reached our main guest, star speaker and ambassador, ACP ambassador, who was traveling to India from United States, Dr. Alisa Choi, she couldn't make her visa. So with all of these hiccups, it was the only Lord Jagannath who brought this conference up to the end, a successful end without any hassle. So my pranam to Lord Jagannath at this point of the time, that we all could be made is successfully without any hassles. And this is chamatkar of Dr. Jayant Panda and his bhakti to Lord Jagannath, because whenever I come, he gives one idol of the Lord Jagannath to me and everyone. I think nobody is left who might not have received that idol of Lord Jagannath from Dr. Jayant Panda. With these words, with my pranam to Lord Jagannath, I invite all of you next year to Lucknow for another conference of ACP India chapter, because we have started from the west in Goa, did in south at Visakhapatnam. Today we are completing at east in Bhubaneswar, and north will be at my hometown, that is Lucknow. So it will be completing a cycle of the country. So you all are invited. Dates we shall announce very soon, but must be in the September or end of the August. So keep available yourself for that. And all of you must be there in whatever capacity you can be. If you come in as a speaker, chairperson, as an attendee, you all are invited there. Be there, become the member of the ACP, keep on working in the ACP, getting your benefits of the ACP. Thank you very much. Jai Jagannath.
I request all to join for the lunch, those who are not taken, and the conference comes to an end.